Saudi Gastroenterology Association, Professor Najib al-Madi, the President, Dr. Faisal Betwa, the Vice President, and the whole Saudi Gastroenterology Association Board. I would like to welcome you to this meeting. We have a great program ahead of us in the next 2 days, and we had wonderful workshops yesterday. Our meeting will extend from now until the end of the day around 4 o'clock, and we look forward to multiple interesting sessions and lectures. So the first session this morning will be the General Gastroenterology session. I would like to welcome Dr. Abdullah Musa, who is a consultant gastroenterologist at King Saudi Hospital in Unaiza, chairing the session along with Professor Lisa Sharkey, who is visiting us from King's College in Dubai. She's a professor of gastroenterology and a specialist in small bowel disorder and small bowel transplantation. So Dr. Abdullah and Professor Lisa, please welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. We'll start with the first session. The session will have 3 lectures. Each lecture will have 20 minutes. And we started the first talk with Dr. Ihab Abu Farhan. He is the Associated Consultant Transplant Gastroenterology and Hematology for small bowel rehabilitation and liver and small bowel health center in King Fahd Specialist Hospital in Riyadh. The stage for you, Dr. Ihab.
Good morning, everyone. Thank you, Abdullah, and thank you, everyone, for your effort for organizing such prestigious event, which I was attending for the last few years. And I have the pleasure to be one of the presenters today. So today I'll go with you through a journey. I'll start speaking about small bowel anatomy, physiology, and motility, how to diagnose small bowel motility disorder, and what are small bowel motility diseases, management of small bowel motility disorder, including bowel transplant, and when to refer to bowel rehab or transplant center. I have nothing to disclose. So I'll start with a few slides to remind everyone and myself about the small bowel anatomy, physiology, and motility. So as you know, when we are talking about small bowel, we are talking about duodenum, jejunum, and ileum, which are about 6 to 7 meters in length. And of course, we are talking about the mesentery, which now recognized as an organ because it has a special blood supply and lymphatic drainage. Microscopic anatomy of small bowel is unique. It has 4 layers: mucosa, submucosa, muscularis, and serosa. Mucosa is the lumen-facing portion. It's folded to allow maximum absorption. And then we have the submucosa, which is a connective tissue layer that composed of fibroblast and mast cell. And we have the muscularis area, which is composed from outer longitudinal muscle and inner circular muscle and smooth muscle as well. And the serosa, which is the thin lining with the celiac cell. The physiology of the small bowel, as you know, small bowel is the major site of absorption of electrolytes, nutrient, and water. Most of the absorption happens in the duodenum and proximal half of the jejunum. 9 liters of water per day enter the small intestine, including 7 liters of secretion and 2 liters from diet. Absorption of fat-soluble vitamins, calcium, iron, and folic happens in the small bowel. Talking about the motility of the small bowel, which will help us to understand the small bowel motility disorder. Small bowel motility controlled by the enteric nervous system that driven the motility from the parasympathetic vagus nerve and the sympathetic splanchnic nerve. We have 2 muscles, as you can see in the right and left. The longitudinal muscle, which I mentioned in the microscopic anatomy, which allow the transit in a single direction, and the circular muscle, which allow the mixing and breaking of the food particle. The 2 fundamental contraction names as segmental and peristalsis contraction, and the time take 3 to 5 hours to reach from the pylorus to the ileocecal junction. Smooth muscle generate the initial movement or contraction, and the slow, which we call it the slow wave. The slow wave are generated from the interstitial cells of Kajal, and it forms something called MMC or migrating motor complex. As you can see in the bottom of the slide, I don't know if the pointer is working. So in the MMS, we have 3 phases: phase 1, phase 2, and phase 3. And this MMS, or the migrating motor complex, is important during fasting as a housekeeping, which help to push the gastric content and control bacterial overgrowth. And you can see how it starts slowly in phase 1 and 2, then it comes like spikes in phase 3. Again, MMS started the gastroduodenal region and then it migrated to the proximal bowel. When feeding happens, that MMS button is interrupted, as you can see in the right side of the screen, and this will allow us to eliminate the spikes and will allow maximum time or increasing the time of absorption of the nutrient. So how we can investigate or how we can have a solid diagnosis about small bowel motility, we divide the investigation to two categories: contractile activity and transit status. So the small bowel manometry, or what we call it intraduodenal manometry, is one of the manometry tests which you use it to detect small bowel motility disorder, which is a catheter introduced either transnasally or endoscopically beyond the ligament of Treves. And it has, as you can see, 8 sensors compared to the esophageal manometry, where they have 20 or 36 sensors. 5 of those sensors are at the pylorus region, and 3 sensors are proximal to that in the duodenum. We have to allow 1 hour between the intubation, then the start of the data acquisition is recommended. And why we allow 1 hour? Because as I see, the MMS complex happens during fasting. So when you introduce this catheter endoscopically, the air can sometimes interrupt the MMS complex. So we allow 1 hour as a pause, then we start recording. In the right side, you can see an image of the fed response measured by the intraduodenal manometry. And you can see some of the indication of using gastroduodenal manometry, including clarify the diagnosis of patient with upper GI symptoms, confirm the diagnosis of patient who is suspecting to have chronic intestinal pseudo-obstruction, identify generalized dysmotility, and this is important. As a motility gastroenterologist, we keep getting a consultation from our surgeon colleague, for example, pre-subtotal colectomy for chronic constipation. And identifying the patient who is having a global dysmotility is important because some of those patients will not be benefiting from the intervention. Assess the possible mechanical obstruction and determine which organ needed to be transplanted, and I will talk further about this. Wireless motility capsule, one of the excellent tools to determine the small bowel or the whole gut motility. Unfortunately, maybe some of you know this was taken or withdrawn from the market 3-4 months back. I'm keeping this slide, hoping in the future it will come back. The motility capsule has 3 sensors: pH sensor, temperature sensor, and the pressure sensor. And the patient will swallow, and it will keep measuring the pH, temperature, and pressure, and it will give you an idea about the whole gut motility from the time of absorption till the time the capsule is out. The capsule now is withdrawn from the market, and I think in the future we will see it again by different companies. And the reason of withdrawing the capsule is related to investment rather than a medical withdrawal or a complication. MRI, or dynamic MRI, is a modality we're using to do a time or consequence image, MRI image. Then we use an automated software that provide the quantification of segmental or global small bowel motility. So multiple MRIs, then using a special software, it can give you either the global small bowel assessment or segmental small bowel assessment. The breath test has a limited role maybe in the small bowel motility assessment. And here we are using the concept about the peak of the hydrogen or methane when the lactose or fructose reaching the ileocecal valve, and this is what we call it orocecal transit time, and from that we can calculate the small bowel motility. Scintigraphy, it's the same idea as colonic transit time or gastric emptying study, where the patient will eat or drink a labeled material, and we will take multiple scans, usually during 6 hours, and depends on the numbers of the isotope or percentage of isotope we see at 6 hours, we can have an idea about the small bowel motility or the whole gut motility. As you can see, all of those, or each of those modality has this advantage and disadvantage, including cost, radiation, validity, and all of that. And to decide in which modality you will go, it will be case by case depending on the underlying etiology. So I start by the investigation before talking about the small intestinal motility disorder. What's the definition of a chronic small intestinal dysmotility? It occurs with the failure of coordination in the intestinal propulsion, which I explained in the motility physiology, and it gives the symptoms and signs of intestinal obstruction, including abdominal pain, nausea, vomiting, dilated bowel, in absence of mechanical obstruction or mechanical cause. And we define this this intestinal dysmotility severe when it's associated with malnutrition with a BMI less than 18.5, or the patient lost 10% unintended with weight loss in the last 3 months. The diagnosis of this patient is very difficult because we don't have a definite histological confirmation, though some of the diseases nowadays we have a histological clue, I will say. What conditions can mimic small bowel dysmotility? So multiple conditions can be presented or mimicking small bowel dysmotility. So in all cases, you have to do a basic labs, including CRP, albumin, platelet, fecal calprotectin, do an endoscopy and a cross image. In one series, the most frequent misdiagnosis for the small bowel dysmotility was volvulus, megacolon, and chronic constipation. As you can see in the right, usually those patients, they present with malnutrition, psychological problems, abdominal surgery, and opioid dependent. And this can worsen the symptoms if they don't have a motility disorder, and can worsen also the motility disorder if they do have. This is what we call it hypermobile Ehlers-Danlos syndrome, or EDS. Here, myself, Dr. Colin Barker, Yvonne C. and Louis Lou from Toronto, we reported around 70 cases of patients with multiple GI symptoms, including nausea, vomiting. They present likely or similarly to small bowel motility disorder, but those patients, based on the objective assessment, they don't have this motility disorder. They have a visceral hypersensitivity, or what we call it functional GI disorder. So what's the causes? We spoke about what mimics small bowel motility disorder. What's the causes of small bowel motility disorder? We can divide it to myopathy, neuropathy, or idiopathic. Myopathy, we can divide it to primary and secondary, neuropathy, primary and secondary, and to differentiate between myopathy and neuropathy, intraduodenal manometry, one of the tools which can be utilized. For example, in myopathy, haloviscous myopathy, systemic sclerosis. In neuropathy, we have the mitochondrial disorder, and we have a neurological disease and neurofibromatosis, or idiopathic, which we cannot reach a diagnosis. As you can see, again, functional bowel disease, drugs, psychological disorder, malnutrition can mimic and can aggravate intestinal dysmotility. Those are examples, again, about myopathy and neuropathy. I'll speak briefly about 3 of them. Visceral myopathy, or what we call it haloviscous myopathy. It's a milder form of visceral myopathy, and usually they present with a similar GI disorder, including nausea, vomiting, upper GI symptoms. The diagnosis is very challenging. Most of those patients, they present with a neurogenic bladder as well. Full thickness intestinal biopsy is the investigation of the choice. I'll skip the treatment here. Mitochondrial disease, or what we call it MNGI. Nowadays, we see more and more of those cases. Those patients, they present with severe gastrointestinal dysmotility or leukoencephalopathy, including ptosis with malnutrition. Actually, those patients, they had been referred to us as Crohn's or IBD, and from Dr. Abdullah, if he's here, I received 2 cases just last week with a similar presentation. We see them as a gastroenterologist as a case of multiple pseudoosmotic obstruction, dysmotility, malnutrition, and sometimes they refer directly to the neurologist with no clear etiology. I think in the literature there is around 200 reported cases of MNGI worldwide. The first case was reported in the Middle East was in 2015 in our hospital with our colleague and hematologist. That patient underwent a stem cell transplant, and he did well in terms of MNGI, but he died afterwards from sepsis. Now, the new literature, they are speaking about liver transplant compared to stem cell transplant treating MNGI diseases. And few studies or very little evidence shows the liver transplant has a better safety profile compared to stem cell transplant. Intestinal neural dysplasia, another form of intestinal motility disorder, and here we have type A and type B. Type A is very rare, and most of those patients, they died before we see them. And type B represent around 95% of those cases, and again, they present with multiple obstruction, dilated bowel, and upper GI symptoms. So what's the physiological consequence of severe small bowel dysmotility? So small bowel dysmotility will lead to impairment of coordination of gut contraction, which lead to gut stasis, bacterial overgrowth, malabsorption, and problem of undernutrition. And they can present with any symptoms, including abdominal pain, nausea, vomiting, constipation, and most of those patients, they have psychological or psychiatric history. And many of them, they have opiate or even painkiller addiction. So when you see a patient with a suspected small bowel motility, you have to do a full thorough history and physical examination, including a neurological and motility examination. You ask for dysphagia, gastroparesis, history of intestinal obstruction, ataxia, stroke episode, seizure, optic atrophy, and all of that. Investigation, as you can see in the right table, when we want to differentiate between neuropathic intestinal pseudo-obstruction and myopathic intestinal obstruction, we can use the antroduodenal manometry, which in the neuropathic will show lake of MMC, but in the myopathic, the MMC is generated, but because of the muscle issue, it's a low amplitude contraction. Specific investigations are performed once organic obstruction, a drug effect, and eating disorder has been excluded. Blood work, sometimes we need to use autoimmune or genetic testing, depending on the underlying etiology. How to manage those patients? Of course, the key of the management of those patients should be multidisciplinary team. Treating the underlying etiology, treat the symptoms, nutrition and dietary management, neuromodulator, psychiatric, surgical, and including small bowel transplant. Underlying etiology, so some of those patients, as I mentioned, they have an autoimmune disease, they have endocrinology disease, some of them, they have an organic obstruction which can be missed. And there is a clue, if the prokinetic drugs make the pain worse, then rethink again about organic obstruction. Some metabolic storage disease, including Menji, can be treated with a specific enzyme replacement. Treatment of symptoms, we have many drugs which most of the gastroenterologists, they use. But again, in those patients utilizing which drug from which class, I call it an art. You have to know the underlying etiology, you have to know the pharmacokinetics of those medication, and you have to balance and know how to use those medication, which we use it all the time. Nutritional and dietary management, I will not speak a lot about this. I'll leave this to Dr. Lisa tomorrow, but some dietary factors may delay gastric emptying, including the FODMAP, high FODMAP diet. Stoma replacement will be tackled tomorrow. Enteral nutrition is preferred if the gut is accessible and absorbing. In carefully selected patient, feeding jejunostomy with or without decompensation, venting gastrostomy may be tried. And really, I keep saying in carefully selected patient, 2 weeks back, we have a case of one of the patients who had a big tube replacement and secondary to motility disorder. Then the tip of the big was penetrating the jejunum, and the patient went for an exploration. TBN, long-term TBN should be reserved for patients with a significant malnutrition or electrolyte disturbance, complication related to TBN known including sepsis, infection, cholestatic hepatic dysfunction, which now honestly overcalled, and the attendee who attended with us the workshop yesterday, we are not calling any abnormal liver enzymes at the early phase of TBN as a cholestatic hepatic dysfunction. The sentence, if you allow me, I'm quoting the sentence at the end from Howard and his group, which was maybe in 1990 something, but they emphasize about the clinical outcome of home parenteral nutrition in a large extent is a reflection of the underlying condition. So 70% of the patients with underlying Crohn's or ischemic bowel are fully rehabilitated after the first year on home parenteral nutrition. Only a third of patients with a chronic intestinal dysmotility are rehabilitated. That means they achieve nutritional autonomy. And those patients, the 30%, most likely they don't have a dilated gut. Neuromodulator, as in gastroparesis, still under a trial. And psychiatric, as I mentioned, anxiety and depression, personality disorder, and substance misuse should be evaluated carefully in those populations. This motility disorder also associated with self-harm inducing suicide. In one case, serious, 6 patients diagnosed with intestinal failure have a significant psychological underlying etiology, which they require specialized psychiatric unit treatment. Surgical bypass surgery, surgical rehab, and small bowel transplant or multivisceral transplant will be the treatment of choice for those population. And I will talk about each one of them quickly. So for surgical rehab, you know Lilith and the STEP. Most of the surgeons, they are moving to the STEP nowadays, which is an elongated process of the small bowel. And again, you have to choose the patient carefully, depend on the length of remaining bowel, presence of ileocecal valve or not. Small bowel transplant, I always saying the right operation for the right patient at the right time. And just quickly for your information, you can see the types of bowel transplant we have. Starting from the left, isolated intestinal transplant, combined liver and intestinal transplant, and here we use it for patient who has a TBN-associated liver disease, and sometimes if the underlying etiology is hitting the liver as well. Nowadays, with microvillus inclusion disease, we start seeing BIFIC, and those patients, they have proven at least bridging fibrosis, biopsy-related, even if they are not on TBN. Modified multivisceral without liver in certain indication, and full multivisceral in certain indication. Each procedure can include a part of the colon, depends on the underlying etiology. Going back in 2010, nutritional support here, they are talking about transplantation for patients on the TBN for short bowel syndrome in general, and they said transplantation should be reserved for patients who develop complications related to parenteral nutrition. The role of small bowel transplant to improve the quality by stopping the TBN is debatable. The indication for transplantation may be broadened in the future, and here we are talking about 2010. Later on, we noticed this is a study from US, one of the centers from 1994 to 2022. They noticed 25% at least of the kids underwent bowel transplant, motility disorder were the underlying etiology. And I'll be quick here also from Cape Town, they are talking about intestinal transplant for motility disorder, and they advise for early referral for assessment of transplant center is advised. And still, till that time, they think it may be for patients who develop complication, but the referral has to be done earlier and to consider doing it to improve the quality of life. Again, here they are talking about the outcome of motility disorder and bowel transplant in patients with total or near total againgilia. And they think the outcome of intestinal transplant in those patients is equivalent to other indication, but careful assessment need to be done, including the type and the extent of the bowel, the extent of the organ. Early referable is desirable in those population. 2017, we have the status of intestinal and multivisceral transplant, and the approved indication, at least for Medicare in US, to do a bowel transplant. This was done by Karim Abul Majd and his colleagues in US. And you know the classic indication, which we talk about failure of TBN. Then what added recently, high risk of death contributing to underlying etiology, including desmoid tumor, congenital mucosal disorder, ultra short bowel syndrome, which rehab is very unlikely to succeed, intestinal failure with high morbidity or low acceptance of TBN, including intestinal failure with high morbidity or inability to function. Patient unwilling to accept a long-term TBN was a raising indication of bowel transplant nowadays. And the new insight of indication of intestinal transplant in 2019 done by Kaufman in Georgetown and his colleagues. Here they are talking again with the same classic indication, and in the end they add also life-threatening morbidity in the setting of parenteral nutrition should be considered. In children, they talk about the number of admission to ICU. In adult, case-by-case basis should be discussed. And again, the novel indication and recent prognosis, this was published in June 2023, and they are expanding the indication, talking about unreconstructible GI tract, frozen abdomen, tumor involving the hepatic hilum and root of mesentery, complete portomesenteric thrombosis, patient unwilling to accept long-term TBN. Lastly, in 2022, we are, I'll call ourselves a starting center in bowel transplant. We did 5 bowel and multivisceral transplant. Compared to other US centers, we are number 5. As you can see, the number of bowel transplant is not comparable to the liver and kidney in all centers. We are talking about King Faisal Specialized Hospital and Research Center in Riyadh, which we are a large tertiary transplant center. We do around 800 organs per year, including at least 300 or 350 liver, 400 plus kidney. We did a total of 16 intestinal and multivisceral transplant. 36 of them were due to motility disorder. So the take-home message, small intestinal motility is understudied area because of the lack of expertise, and the patient often report unclear symptoms. In addition, there is a complicated relation between small intestine and enteric bacteria in relation to motility and immune function. Small intestinal motility disorder may be primary, visceral myopathy or myopathy, which may be inherited or sporadic. Investigation that help to detect the extent of the involvement gut, including manometries, gastric emptying, intraduodenal manometry is important. And management of those patients very complicated and need to handle in multidisciplinary team in the presence of motility gastroenterologist. Patient with intestinal dysmotility as a cause of intestinal failure present a special challenge, and early referral to be assessed in a transplant center is advised. Intestinal transplant for motility disorder represent now minimum of 25 of the current indication. The decision to list those patients for transplant, particularly those with no other indication, should be made on a case-by-case basis. This is our hospital and my personal and hospital email, and we are welcoming any referrals, and thank you.
Thank you so much, Ahab. We're going to have all 3 talks and then a Q&A session at the end, I believe. So next up is Dr. Saeed Al-Subidi from King Saud Hospital in Riyadh, where he has a number of positions I was reading. So Deputy Director of the Fellowship Programme, Head of the Motility Unit, and Chair of the M&M Committee. But today he's going to talk to us about the increasing problem of eosinophilic esophagitis. Thank you.
Thank you very much, Professor, for this kind introduction. Thanks, SGA, to have me today. So it's my pleasure. So without any delay, I'm talking about my topic today is about eosinophilic esophagitis, what's the updated during 2023. So this is my agenda today. I have nothing to disclose. So it's usual. Actually, it's a common disorder that we are facing in practice during our through the GI clinic. So the definition is it is the chronic inflammatory condition, which is usually immune-mediated and clinically have esophageal dysfunction and also histological bioeosinophilic predominant inflammation. So this is nowadays it's very common and increase the prevalence and incidence of this kind of disease. Actually, the first cases was described was 1970 was as associated with eosinophilic gastroenteritis, and distinctly as isolated disease was discovered in 1990. So in our area, actually, the data is not that much. However, there is a little bit studies going on. Then hope that to get some data in the soon future. So this is a disease of pediatrics and adults, and it's male common than female. If you see the chart, that's how is that increase the prevalence and the incidence globally. And this is the chart just show the effect of that eosinophilic among the age. If you can see, this is in general, this is a young disease, and it's commonly employed. That's the 30 age. So what could be the possible risk is multifactorial. I mean, nothing's only one reason. So it's depends that it's environmentals, even food or allergen. This is, some people have a genetic predisposing to have this kind of disease. So pathophysiology is important. So if we know the pathophysiology, then it can easy to control the disease. So what's gated from with the cooperation of our colleagues in allergy and immunology nowadays, that's eosinophilic esophagitis is came under umbrella of type 2 inflammation. What does that mean when a patient just get risk factors that food allergen or air allergen? And then that will bring the cells that's presenting this antigen and will be activated others inflammatory cells and mainly T helper 2 cells. So then the what will be increase the cytokine release. This is the main importance. Interleukin is interleukin 4s and IL-13s and 5. And then that will, this is the way, pathway, this is inflammation, and then will, I mean, that bring the patient to have more, I mean, acute inflammation, and later on, if not diagnosis earlier, then will lead by chronic inflammation and fibrosis and remodeling. So again, this is what he told is type 2 inflammation. For that reason, there is another disease associated or came under umbrella of this type 2 inflammation. So allergy and type 2 asthma, atopic dermatitis, and COPD. So you will have a patient with eosinophilic esophagitis associated with other inflammatory disease. So as you mentioned, this is the most common disease associated with AOE. This is the first one is allergic rhinitis. It's the most common. and asthma, atopic dermatitis. So diagnosis, just according to the last SGA, that we need patient should to diagnosis, you need to have clinical symptoms, suggestive physiologic dysfunction, and we'll talk later on what is the most common symptoms. Again, also endoscopic and biopsy to get eosinophilic more than 15 is very important and potentially important in this disease. Also, not always the EOE, I mean, that's the only one causes eosinophilia, so you have to rule out secondary causes. So this is the most common, symptoms presented with EOE. It varies depending on the age, but the common things in the adults is the dysphagia and food impaction, and it is one of the most common causes of food impaction is EOE. And if you could see, this is about the older children and the infants. It can vary variance than an adults and came with non-specific symptoms. So this is now, we get this new scores. I mean, just from 2017 is validated scores to evaluate the patient with EUE, if in diagnostic or follow-up. However, it is not yet common adapted by the gastroenterologist. It's a bit needed times and to be familiar with. I think hope in the soon future, all of us get familiar with it. Then they make the things more organized and the language of EE a little bit standardized. So if you could see, this scores contain like an inflammatory marker and also fibrostenotic markers. Is edema and exudate and furrow. This is inflammatory marker, and rings structure. This is one of the fibrostenotic features. So, however, when you get more score, that's probably increase the chance to have the disease. So, how important that? So now, when we collect that and unify all that feature. We'll take it one by one, and maybe it is not that much specific and even sensitive. So when we uniform all that or unify all that, then increase the sensitivity to 88 and specificity 92, and with negative predictive value of 94. However, there is still 10% chance to have a normal EGD, and this is mainly among pediatric patients. So very important, the endoscopic biopsy is very important, have rules in diagnosis. So it's important to take enough biopsy, then it will help much in get a diagnosis. Especially, it should be not less than 6 biopsy, especially when you have patchy disease, because sometimes maybe all of us get result that it's biopsy not suggestive despite endoscopic going with the EUE. So better to get enough sample, and better to have from this area have more furrows and plaques. That's meaning there is more eosinophilic in this area. So again, what we have now, 2017 also has validated score, histopathological. It is concentrating in others parameter more than eosinophilic numbers. However, again, it's need expertise to pathological, and this is the feature of that. It's kind of 7 items. It depends on eosinophilic abscess and microcephalic eosinophilia and the others. So anyway, nowadays what we are concentrating on only the number of the eosinophilic. So suppose that patient already started in PPI, whatever, then get masked the things. So we have another endoscopy, also histopathological feature, which can help much to figure out this the debate case. So how important of this diagnosis? So as early as you catch the patient, so it will affect positively in the outcome of the disease and the quality of life. Whenever you get delay, that's the meaning poor outcomes and will affect the quality of life. So the management, we know we can divide it to two items nowadays. Is the conventional treatment, which is contained what we familiar with. So anyway, what we get learned from the IBD that we are trying to get standardized and just have treating to target. We should have benchmark, then we'll assess how the things goes with the treatments such disease. So previously we been just concentrated in the symptoms and the number of the xenophilics. So however, there was no, clear standards in that. So nowadays, I think we can, we will be in this way that we should monitoring the patient according to the symptoms and histopathological and endoscopic. So will increase the specificity and sensitivity. So anyway, this is a proposal approach, how to approach the patients. First of all, this is the diagnosis, very important. Then I think patient-based treatment decision is very important. You have to sit with the patients. Regarding this is the conventional treatment, I cannot, we have BBI and elimination diets and topical steroid. This is the most common medication we have. It's dilation. If there's a patient came with high caliber stenosis, and then you have to. Then you just give a patient chance 8 to 12 weeks and bring him back and assess him, and later on we'll see if his response. Then we'll may continue maintenance. Otherwise, we'll see this is the new treatments with biological. So this is the elimination diets. All of us, we know there is the 6 most common triggering foods for eosinophilic esophagitis, and the most common one is, you can say, the milks and wheat is the leading offending food. So what's the strategy in that? We have to even to go step up elimination diet or step down. So I believe the step up is easy for the patients and for the compliance, while step down a bit difficult to get the patient in and compliance. So however, also we need multiple sessions of an endoscopy, which is practically difficult. However, the evidence 6 foods is will high chance to get remission. However, there is now multi-center randomized controlled trial compare 1 food with 6 foods, and you can see there is no much difference. So at minimum, 1 or 2 foods strategy will be so easy for the patient. So BBI, it is one of the easiest and applicable and feasible and low cost effects and safe drugs that usually all of us maybe use it as the first line. So how does that work? If you think in that, just it's going to have anti-inflammatories features. So it's work in the what's called etotaxin. That's when they bring the eosinophilic to the esophagus. So it's blocked away. The second things, maybe if all of us familiar with start BBI, and then the patient get improvement. So maybe sometimes there is a GERD associated with UAE and then get improvements. On the other hand, there's maybe a patient have the eosinophilic esophagitis is cause what you call an effective peristalsis, or so may get a benefit from BBI. So this is, to be honest, is not a bit frustrated, data. So we bring this from the SGA-SDDF, suggesting that using BBI offer no treatments. However, because if you could see, this is the first part. This is not that much. Good result, but however, because high heterogeneities of the studies, we cannot finally conclude in that. So still the BBI is a chance, but however, the chance to get histo remission is only 50%.
2 minutes, please.
So the second conventional treatment is the topical, which is have variables. Formulation is very familiar with suspicion or buffs or even or dispersible. So is one of the famous things is fluticasone and budesonide, even oral viscous. So that's the typical that we get from SGA-SDDF recommended topical steroid over no treatment. So so this is a little bit the evidence is in favor for use topical steroids. So there is no all of that. Even BBI steroid is not yet FDA approved. The issue with this topical steroid is a bit increase the risk of to get severe candidiasis. But however, if you compare with the benefits, may be neglectable. So we just head-to-head trial budesonide and fluticasone affected in even endoscopic or histopathological or symptomic-wise. There's no much difference. So you can use whatever you like. Again, for the maintenance issue, this is a little bit a debate for the gastroenterologist. When you start the induction and then patient get benefit, what to do, even to continue or to stop. So the evidence came with that continuation of typical steroids is better than discontinue this treatment. However, again, just sit with the patients and take the decision with him. Is that there is a possible for relapse, and then the only 10% risk to have this candidiasis infection, and you will go from there. So
just 1 minute, please. Thank you.
Oh yeah, sorry. So anyway, for the BBI, there is 100% to get relapse. A typical steroid, there is 80%. So this is the need for have to continue in the maintenance. Anyway, the new Jorphesa, this is the new one that's yet here. I think it's approved in Canada, and this is all dispersible. It is easy to use, no time to go through it. So therapeutic endoscopy dilation, in that case, we need to dilation. You have to go slowly, and there is like a less risk to have any complication. Last thing, I will talk is the biological era. I think it's very important because it is we're targeting the pathway, clear pathway we are targeting, and it is like in a weekly, and in the case now can use it in that refractory case, and it doesn't need any workup as because we are not it is labeled as immunosuppression. So this is the important one. This is now approved with only first FDA, and so if they approved the Dupilumab, this is working IL-4 receptor alpha and 13 receptor 1. So there is a studies, to be honest, and was released. One was phase 3 studies, and this was randomized 3 arms. If you can see here, this is compare part A and part B, Dupilumab and placebo, and then later on who has this is a kind of eligible, and then goes to use Dupilumab for it was for the first 24 weeks and then 52. Class B is that the Dupilumab sub-Q weekly, and others 2 weekly, and the placebo, and then the patient who is reached to the specific criteria continue in the same dose for 52 weeks, while the people receive placebo, they shifted to Dupilumab. So this is the result. That's fantastic. That show part A is Dupilumab 60%. So anyway, this is symptomatic and histological. They show much better. And about the side effect is a little, only that's the injection reaction. So this is the thing. There's now clinical severity index, which is very important to standardize the outcome. Pipeline, there is a lot of, biological treatments targeting the pathway. We cannot have no times to go through it, but there is a lot of biological in the way. So conclusion at the end, eosinophilic is nowadays became more prevalence, and diagnosis early is very important and crucial, and very important endoscopic to confirm the disease. Dupilumab you can now approved, you can use it at the point is for the refractory disease. Still conventional treatment widely accepted modality for you. Thank you.
So the third lecture the speaker, Dr. Ayman Mhedib. He's a consultant in interventional endoscopy at King Faisal Specialist Hospital and the Research Center in Riyadh. He will talk about the endoscopy management of the GERD. Dr. Ayman, the floor for you.
Thank you for the introduction. So in the interest of time, I'll try to summarize what we need to know about endoscopic management of GERD. So I'm starting my lecture today, just some definitions. As you all know, what's GERD means. GERD is a condition that reflux of the gastric contact going to the esophagus, causing some symptoms and complication. Presence of mucosal injury or abnormal esophageal acid exposure on the reflux monitoring study that's proven reflux. So let's talk about quick pathophysiology. There is a lot of things in reflux that play a major role. So there is a poorly functioning EGJ, anti-reflux barrier known as a crural diaphragm, and LES, also the impaired esophageal clearance and alteration of esophageal mucosal integrity, other contributors like decreased salivary production, delayed gastric emptying, and esophageal hypersensitivity. Anyway, a couple of things also play a role why we have GERD. We need to understand all the mechanism before we can treat that endoscopically. So that's why I'm going through a little bit of basics in a couple of slides. So we have all these factors can lead to reflux, so we need to really understand it very well in order to treat GERD endoscopically very well. So there is hypomotility mechanism, which is impaired clearance and EGJ dysfunction. Also, we have structural mechanism, which is EGJ dysfunction and hiatal hernia. The hiatal hernia and EGJ lead to EGJ dysfunction. This EGJ dysfunction and hiatal hernia lead to impaired clearance. So it's all related to each other. So elevated esophageal acid to the exposure time, that's the result of all these factors. So in the interest of time, I'll try to go faster on a couple of slides, then we'll go in details and talking about endoscopic management. As you all know, what do we expect on this patient? Typical GERD symptoms, they will have heartburn or regurgitation, chest pain without heartburn or regurg. It also can happen. The complication you all know is esophagitis, stricture, Barrett's esophagus, at the end also adenocarcinoma. You could have extraesophageal manifestation, which you could see. You can have a hoarseness, throat clearing, asthma, or a chronic cough. Some patients always come to my clinic from all of you guys from ENT clinic with laryngitis, pharyngitis, idiopathic lung fibrosis from pulmonary clinic. So this is a very simplified approach for how to diagnose and manage GERD. If you have already diagnosed GERD, then you give them PPI for 2 to 4 weeks. If you have symptom release, we're good. Just keep going and try to wean off the medication and change lifestyle modification. If not improvement, you want to know, are you dealing with real reflux or not? Then you need to do a pH study. If it's normal, then you're probably dealing with functional. If it's abnormal, then this is a proven your diagnosis. And before you do any interventional, you have to make sure you're dealing with a real reflux. And that's what I always talk to my patient. Before considering anything, we need to know this is not a functional, because you all know you could have combination of a functional and I would call it real reflux because it's proven by numbers. So I'm not going to go in details about updated the Lyon consensus, which is the most updated criteria for. But I would highly recommend everyone to go and check it out and to give you a concise approach about how to approach GERD. So now your patient come to clinic and they said, you know, doctor, I don't know if I said, everyone talking about PPI. PPI is like causing a lot of complication. They will also mention what's complication that can happen, vitamin B deficiency, dementia, increased risk of pneumonia, PPI interaction with other medication like Plavix, increased osteoporosis, having bacterial overgrowth, and there is some reports saying increased risk of polyps, magnesium deficiency, reduced gallbladder motility. There's a lot to talk about. And it's a very hot topic, and we know the studies is not as strong as we wanted, but we all know the chronic complication of PPI. It's real, so we have to really talk to our patient about it and try to win them off as much as possible. So here is the thing. Okay, so he's like, everyone in gastroenterology would ask this question, who's the best candidate for endoscopy? So the endoscopic intervention. So you need to understand three components. Number one, you need to know what can play role in your reflex. So you need to know this. We are dealing with three things: lower esophageal sphincter, crural diaphragm, and gastroesophageal flap valve, which is called internal valve. So the success of any endoscopic intervention, it also rely on comprehensive understanding of anti-reflux barrier of the EGJ. So the mechanism must be robust to prevent retrograde movement of the gastric content into the esophagus. So understanding what's happened physiologically will help you to help the patient to prevent reflux endoscopically. So what is the option that we have? We all know in the literature that we have transoral incision-less fundoplication known as TEF, which is Isoflex. Transoral anterior fundoplication. We have full thickness endoscopic plication like Gerdex. We also have with POEM, we can do fundoplication, per oral endoscopic fundoplication. We have augmentation of the EGJ, bulking agent, anti-reflex mucosectomy, and mucosal ablation, and non-ablative RFA. We'll talk about most of them in details. Now, the most hot two topics in the market is, should I use Gerdex or should I use Isoflex? It's a very interesting topic, and everyone is jumping into this field to know more about those. And we just want to know that this is the two most device that we use right now, either Gerdex or Isoflex. So let's talk about TEF, because TEF, which is using Isoflex, is the most studied device so far in the literature. Doesn't mean it's the only option, but that's what we have in literature. So endoscopic therapy, to represent, in general, we're talking about TEF, it's representing a bridge between pharmacotherapy and surgery. So to address gastroesophageal flap valve, the internal valve, and also you need to have most appropriately for intact crural diaphragm, which means you have to have a small or no hiatal hernia, or Hill grade more than, your maximum to do is 2. So 1 to 2, this is the best option. If you have Hill grade more than 2, when using TEF or Isoflex device, you're running into problems. So here is the thing, like you are recreating gastroesophageal flap valve through the full thickness plication. For what we're doing exactly, we're just creating a surgical fundoplication. It's a gastric fundus folded up into the distal esophagus, which has been retracted below the diaphragm using at least a 12 fastener. This is the typical, usually 3, 4, 3, 12 to 10. That's the minimum number. We'll talk about the details in this couple of slides. So this is re-established the the flap valve mechanism up to 3 centimeter and 270 to 300 degrees circumference. So here's the device. This is Isoflex, which is American device. It's basically creating the valve we talk about. It's a bigger device compared to Gerdex, but it's still easy to use. It needs more experience. We need to be trained on multiple cases before you can really master it. I'm not going to go in details for this study. We'll talk about it in the next couple of slides in interest of time. Also the CTEP for the patient who has more than 2 centimeter hernia, what you can do, you can work with your surgeon and talk to them about like doing CTEP, which proven in study that can be done. They can do correct the hernia for you, then you can go inside and do the fundoplication. We've done a couple of cases like a combination with the surgeon. So in summary for TIF, that it's a long high pressure zone at the distal of the esophagus, prevent reflux, but still allow gas to escape from the stomach. So therefore, the patient had less gas bloat. Ideal candidate for TIF, as I mentioned, you need a hiatal hernia less than 2 centimeter, and you need a Hill grade 1 to 2, the maximum. So we'll go a couple of studies about TIF. Now, TIF, this is a randomized control study having 40 patients with TIF and 20 PPI. GERD symptoms in 6 months was better in TIF group, but the physiological parameters such as acid exposure were not meaningfully improved. For this other study, the TIMBU randomized control study, which had 40 versus 23 PPI, the TIF was extremely effective treating regurg 97 versus 50%, equally effective reducing acid exposure in this study. So now 5-year follow-up where I was available for 44 out of 63 patients. The sustained resolution of the regurg 86 symptoms, 86%, and atypical symptoms 80% improvement with demonstrating long-term durability. I think this is one of the most devices that we have long-term data and durability so far. Now, what's the efficacy of the TIF? On this systematic meta-analysis, it looks about 32 studies with around more than 1,400 patients. It's also significantly improved the GERD health-related quality of life, as well as the gastroesophageal reflux score. And 89% out of those patients in this meta-analysis was able to discontinue PPI. Again, choosing your patient is the key here. So the recent, also they looked at, in 2022, they looked at cost effectiveness, and the recent modeling study demonstrated cost effectiveness on the TIF patient continued to have symptomatic, despite of taking PPI compared to the omeprazole 20 milligram or laparoscopic fundoplication. So cost effectiveness was also looked at in TIF, which is giving a good data. So this is what we already talked about. The same thing. There was some improvement on there was a good improvement on the GERD health the GERD HRQL scores, and also the median RCA, which this is in a 6 study with a follow-up more than 6 months. Weighted average percentage of reduction of a median score of pre-study was 78%. The PPI use that we already talked about, so there was this is a weighted 78% across the 3 studies for more than 59 months. Again, this is a 10-year durability of the TIF. Not a lot of patients though, but it was good to show there is some durability with TIF patient. Okay, so let's summarize the TIF based on the available data. There's ACG guideline and AGA guideline summarizing. The ACG guidelines suggest consideration of TIF for a patient with regurgitation or heartburn who do not wish to undergo surgery or who do not have reflux esophagitis, LA grade C or D, or hiatal hernia more than 2 centimeters. For the AGA guideline, it's also, it's a very shy recommendation. They're really still suggesting that, but I think we need to carefully choosing our patient. Now, switching gear to the other brand. Now, GERD-X. GERD-X now it's an endoscopic fundoplication. It's the difference between TIF and Isofix. TIF is equal to Isofix. GERD-X they're both in the full thickness fundoplication. So the GERD-X will do gastric plication. The TIF will do esophageal gastric plication. Technically easier and smaller device, and it's easy to learn. What's the component? We have applicator, we have tissue retractor, we have 2 suture usually we place, and this is one of the cases that done for GERD-X, and the beauty of GERD-X, you still can technically do more than Hill grade 2 and 3, which is still helping our patient, not really indicated on the literature, but at least personal experience, patient get better. So it can create a nice valve if you choose your right patient. So also both devices can be done, both laparoscopic, both fundoplication. So if you have someone with fundoplication and doesn't want to go on another surgery again, so what you can just offer them Gerdex, okay? But also TIF can be done if you don't have a big hernia or the Hill grade less than 2. Okay, so there is no long-term data for Gerdex, the new device. This is the only data we have from the older version, which was in 2007. They used to place one suture, so it was safe and has reduced GERD symptoms. But again, we don't have a long-term data for the new device of Gerdex, but it's the same idea. So it's a safe device, but we need to know what's the long-term effect. Now switching gear to Stretta, but maybe a lot of you been using this device. So in summary, it was FDA approved in 2000. It's basically you need to have no hiatal hernia, and you have to have a Hill grade 1 to 2. ACG guideline could not recommend that, and being fallen out of favor. I've never used it, and I don't think I would recommend it because we have better options now. Now, this meta-analysis in 2015 with 4 RCTs, 3 trials with 1 sham and 1 Stretta versus PPI, it showed Stretta did not produce significant change in symptoms. So this is another good study that will tell us that probably we should not use that, because we don't know really if that will help our patient. Now, it's interesting, we're switching to anti-reflux mucosectomy. So basically, this is a patient, when it started, it's a patient started with having Barrett's esophagus. They did EMR and incidentally found, oh, this patient got better. Then that's how it started. Maybe we could use that for a treatment of GERD. And it's actually, there was a good study. I mean, there was a 10 study was done, including 307 patients. Clinical response was 80%, and PPI discontinuation was 65%. So what happened, I mean, it's a little bit aggressive, and it could lead to stricture. So I think we probably have better option. I might consider it in some patients, but I would probably not go forward with it. Okay, so here let me summarize the 4. I mean, I'm almost done here, but let me summarize the 4. So we have anti-reflux procedure or other than TIF. So we talked about TIF. We have Gerdex, RCT showing 62% of PPI at 1 year, durability unclear, but at personal use, we have a good response from the patient. Stretta, not recommended anymore, conflicting data on the efficacy. ARMS, which is, have 10 studies showed 80% response, durability unclear. Again, it's still a little bit aggressive if we have other options. And for Muse, which is 65 to 70% improvement, 65% of PPI would need durability unclear. So before I conclude my talk, I will just give my personal experience. So I think the most important part is, number 1, to make sure that patient will benefit from endoscopic intervention. How? Step number 1, make sure you're dealing with the real reflux. It's not functional. So you got to do pH study. You have to make sure you have normal motility in the esophagus before considering anything. Number 2, then now you have to discuss with your patient the risk of complication. Number 3, you have to see if you have a hiatal hernia or not, and what's the size of that, and Hill grade. And based on all this information, then you can decide. I think both devices are really good, and you just need to choose the right patient for each device. In my personal experience, when you torque all the way to 360, it's harder with Gerdex compared to TIF, because TIF it just can take you to the areas where you cannot reach with it, because the Gerdex is a little bit bigger, so there's some area you cannot really reach, I would say at 11 o'clock. But it doesn't mean that we cannot use it. I personally use both, so I think it's highly recommended, but I would use it for the right patient. And by this, I would conclude my talk, and thank you for the invitation.
Thank you very much for that lovely summary and reminder at the end. Could we ask all 3 speakers to join us on the stage? And if you have any questions, please come up to one of the microphones. While you're thinking, Dr. Saeed, if you diagnose someone with eosinophilic esophagitis, how aggressive do we need to look for eosinophilic infiltration in other organs? Like, should we be doing routine duodenal and gastric biopsies when we're following these patients up, or just based on symptoms?
Actually, it's very important just whenever suspected even eosinophilic esophagitis, you have to take a biopsy from the duodenum and also the gastric throughout. Gastroenteritis, which is common to have, association. So I think it's mandatory to have a biopsy. Yeah.
Okay, thank you. Any questions in the room?
I have a question, Dr. Saeed. Now, let's say if you have a patient and you have highly suspicious eosinophilic esophagitis and you do endoscopy and you find most of the feature, do we need to take biopsy from the stomach and intestinal to think about if there is association with the GI esophagitis, eosinophilia?
Yeah, as I told you now, just if already, if initially you have to confirm the disease, it is isolated to the esophagus or also associated with gastroenteritis. This should be basically taken, and then if you already just confirm that nothing there, then treat it with the isolated eosinophilic esophagitis. Yes.
And how many biopsies? The stomach and small intestine?
Actually, regarding there is no clear recommended regarding about the biopsy from the stomachs and the duodenum, but anyway, I will take it as recommendation regarding the gastritis. You have to take at minimum 6 biopsy from the gastric antrum and the bodies. So as you dealing with simple gastritis, but there is no clear recommendation.
Okay, if you have a question, could you come up to one of the microphones, please? Otherwise, we will probably struggle to hear you all the way up here. Thank you.
If you have someone who is responding to PPI very well, and they need to go for surgery because they are worried about the side effect of the PPI, do you still need to go for pH monitoring and manometry of the esophagus, or you just take it and the patient is responding well to PPI?
Yeah, that's a great question, because probably you encounter this every day in the clinic. Nowadays, patients talk about, everyone freak out about the PPI. So it doesn't mean that you're responding to PPI, that you have normal motility of the esophagus. The concern that when you do a fundoplication, even surgical fundoplication, you probably, if you have some motility issue, you will run into issues with dysphagia. So I will never do any case without having normal manometry and actually either a pH or either a pH study or at least evidence of reflux like esophagitis. Okay, at least grade A or B, because specifically now we have a young population. Most of the patient comes have a feeling of reflux, and they are 50% of them have either esophageal hypersensitivity from acid exposure, or they have dysfunctional disorder, and those will never get better, and you're still doing invasive procedure. So in short answer, yes, I would make it as a standard to have at least proven I'm dealing with a good reflux. And the patient, even the data showed that if someone responding to PPI, the chance of responding to TIP is higher. So that's a good sign that you have someone, but we don't really know if you should switch to all endoscopic fundoplication. This has to be discussion with your patient, and you and the patient try to decide, because there is risk of complication with the procedure. But yes, short answer is yes.
Thank you.
Just for this, just comment, because for mortalities, I think so with the new guideline, there is no more, diagnosis geared among subjective. So it's nowadays an objective era. There is no role to try with PPI. Just go directly with endoscopy, or as our colleagues say, this is for mortalities guide, just to confirm the disease. So no more PPI-based diagnosis.
We have just a few minutes before the symposium, so quick questions and quick answers, please. Centre of the room first. Thank you. Okay, while we sort your microphone, we will have the other question and come back to you, please.
Okay, Dr. Ihab. Okay, it's okay. Actually, my questions is a concern because as I saw in different conferences are talking always about the reverse of the immune system regarding some of the disease, which includes IBD and eosinophilic esophagitis, which in my opinion, it is the same disease with different faces. So why we are talking in the future regarding reversing the immune response to these abnormalities? And we take these stages regarding current treatment for all this disease as a bridge for a definite curable disease. That's why I think we have to handle this one to a stage, the GIT and the endoscopist has to stop at one stage. And the reverse, once they reach the diagnosis, to include, to be taken over by the immunologists, which are more expert and have the driving license because you know all everything about the immune system and its secret. And we stop our treatment just to diagnose, treat the complication, staging the disease regarding all the autoimmune diseases.
Thank you. Yeah, we're heading towards precision medicine, aren't we? Yeah, thank you. Okay, one final question, please.
Dr. Ihab, thank you so much for your outstanding talk. If you don't mind, just a recap. So for us working at centers where we don't have advanced motility testing, how would you screen someone for a chronic intestinal dysmotility? I know you showed us a table with comparison like radiological. So would you say you would start with something simple like a small bowel follow-through or any? Can you just recap, please?
Thank you, Dr. Hani, for this important question. Actually, in most of the centers, yes, as you mentioned, those patients usually they missed or treated as a functional GI disorder or recently IBD. So how to assess the small bowel motility? Basically, you need to exclude other etiology. Maybe, as I mentioned, basic labs including CRP, fecal calprotectin, cross-sectional image, endoscopy is important to exclude other etiology before working them up for GI motility disorder. Barium follow-through is a good tool. In the last 2 years, initially we were suffering with the radiologists because it's somehow a time-consuming study. It gives you a hint about the bowel motility, bowel anatomy, and sometimes even after bowel resection, the length of the remaining bowel. So I agree with basic labs, imaging, endoscopy, and barium follow-through will be the minimum before going further for further testing for those patients. Thank you.
And now we close the first session. Thank you for the speaker and thank you for the audience. Thank you.
Thank you very much.
Thank you so much, Dr. Abdullah and Professor Elisa, and thank you for all the speakers. It's a really pleasure to be chairing the Satellite Symposium, the first of 3 industry-sponsored Satellite Symposium in our meeting. This Satellite Symposium is sponsored by AbbVie, and it's a true pleasure and honor to be introducing my friend, Professor Charlie Lees, who is visiting us in Jeddah from the United Kingdom. Charlie is a professor of medicine and gastroenterology at the University of Edinburgh. He's a consultant gastroenterologist at Western General Hospital. He qualified in medicine from London and pursued a PhD in basic science in IBD in the University of Edinburgh. Charlie has several publications, dozens in fact, extending from Nature, Lancet, going through gastroenterology, Gut, Journal of Crohn's and Colitis, IBD, APNT, and the list goes on and on. He held multiple leading positions, including being the chair of the British Society of Gastroenterology IBD Research Group and multiple leadership positions. I would also highlight the important presence that Professor Lees has in the social media. His Twitter account has thousands of followers, and he highlights very important practical points that are useful for clinicians and patients as well. The talk this morning will be entitled "When Upadacitinib Takes the Stage in Managing Patients with Crohn's Disease." And these are the disclosures for Professor Lees and for myself. Professor Lees,
The floor is yours.
Thank you very much indeed. Are you telling me not to use this? It's good? It's great. Happy? Super. Good morning, everybody. It's really a huge privilege to be here. My name's Charlie Lees. Thank you, Turkey. It's a real pleasure to be back here sharing the stage with you this morning. Is this a bit of interference? This better? Okay, we see. How we go. Mustafa's coming to tell me. Okay. It's a very exciting time to be here in... This is still not good, right? Let's use this one. Make an executive decision to change. There we go. That's better. This morning, I want to talk to you about upadacitinib in Crohn's disease. It's been a while since we've had new therapies for Crohn's disease, and suddenly this year we have two. We don't just have two new therapies for Crohn's disease, we have two new therapies that actually work in Crohn's disease, and two new therapies that work in Crohn's disease both before and after TNF failure. And these two new therapies are quite different from each other. We have a new antibody therapy, very targeted, very specific, given intravenous and then subcutaneously. And then we have a new oral agent, a JAK inhibitor, working for Crohn's disease. And what we are finding in the clinic is that this therapy is working as well as we saw JAK inhibitors working in ulcerative colitis. And so this is what I want to tell you about today. I want to tell you about upadacitinib in Crohn's disease, upadacitinib which is now approved for both ulcerative colitis and Crohn's disease, but also for multiple other conditions, psoriatic arthritis, angst-spond, you've got atopic dermatitis, rheumatoid arthritis. So many of our colleagues across dermatology and rheumatology are now getting very familiar with using this drug. In Crohn's disease, over the next 20 minutes or so, I am going to show you the data that demonstrates that upadacitinib achieves significant mucosal healing, rapid clinical response, durable clinical remission, and I'm going to present to you the overall safety experience, not just in Crohn's disease, but across all indications. And I'm going to share some of the highlights from my experience already. I've been using upadacitinib for Crohn's disease for 12 months now. I've treated 75 to 80 patients with upadacitinib for Crohn's disease in the last year. And later on today, at the booth, I'm going to share more of that experience with you and have the opportunity to have a more detailed conversation. Let's reset. So a person with Crohn's disease may experience the classic physical aspects we know about, extraintestinal manifestations, psychological aspects, the long-term complications of Crohn's disease, which we want to prevent from happening, and the impact on everyday life. Our target is to treat the symptoms, control the inflammation, minimize steroid exposure, keep our patient out of hospital, prevent the disease from progressing, and this is now achievable, decreasing surgery and stoma formation, and minimizing complications from not just the drugs, but more importantly, from the disease. So I'd like to introduce you to a young man. This is one of the first patients I treated with upadacitinib for Crohn's disease. He comes from a very affected family. I look after his father and one of his sisters, and one of my colleagues looks after his other sister, who all have a very severe Crohn's phenotype. So when he presented to me a few years ago with gastric, small bowel, colonic, and perianal Crohn's disease, I was very keen to get on top of it straight away. I gave him early aggressive therapy with infliximab and azathioprine, but unfortunately, he developed immunogenicity to the drug. I gave him adalimumab, moving on quickly, escalating the dose, but that didn't work. So I moved him on quickly to ustekinumab. I moved the dose up to every 4 weeks off license. He says he's doing okay. but the inflammatory markers were still high, and the next thing I get a call, he's in the emergency room having a CT scan because he's got a perforation. He then ends up needing to have a colectomy and an ileostomy. We keep him going on the ustekinumab post-operatively 4-weekly. Within 6 months, he has at least 20 centimeters of at least moderately active neoterminal ileal Crohn's disease. His inflammatory markers have shot up again. He is still significantly underweight. Upadacitinib is available. I treat him 45 milligrams once daily for 12 weeks, 30 milligrams once daily as his maintenance dose thereafter. His labs all normalize. His calprotectin comes right back down to baseline. The MRI appearances go back to normal. And when I saw him most recently, I noticed he'd put 12 kilograms on in weight. This guy who'd never been able to maintain a normal weight, not doing anything different lifestyle, just the disease was better. So, that sets the scene for upadacitinib, which is a JAK inhibitor. What do JAKs do? JAKs block, the JAK inhibitors block the ATP molecule from binding to the JAK. Okay? So I'm going to show you this. You have an intracellular receptor, a cellular receptor that binds together. So when your cytokine, let's say it's interleukin 12, binds to its pair of receptors, the JAKs then have an ATP that binds in. That's so important because that's the groove, the ATP binding groove, is where upadacitinib sits. That's the bit it stops. The intracellular receptor gets phosphorylated. You then get your STATs that come in together. Those are then able to move freely through into the nucleus and then transcribe the response to the original cytokine binding to its receptors. And we see that this happens across multiple different cytokines, across multiple different pairs of JAKs. And what we want to try to do is to block the JAK specifically. It's actually a very difficult thing to do because the JAK binding groove, the ATP binding groove on the JAK, is 85% identical across JAK1, JAK2, JAK3, and TYK2. And so the chemistry to find a molecule that is selective for JAK1 is very hard, but with upadacitinib and with filgotinib, we have molecules that will do this. Upadacitinib is the one that does it the best. It's demonstrated a 40-fold selectivity for JAK1 over JAK2. So that gives us a more targeted blockade with a cleaner profile overall, which is exactly what we want in inflammatory bowel disease for our patients. So with that in mind, let's go straight into the important data. I'm going to present to you the data for UEXCEL, UEXCEED, the two-paired induction studies, and UENDURE, the maintenance study. This is the kind of study design we're used to seeing now. 2 randomized populations, placebo-controlled for induction. Remember, for Crohn's disease, it's a 12-week induction compared to the 8 weeks for ulcerative colitis. Patients who respond then get re-randomized 1:1:1 to the 2 doses of upadacitinib, 30, 15, or placebo. Importantly, patients who were on steroids at baseline had a mandatory steroid taper starting at week 4 and ending at week 12 of induction. Here are the baseline characteristics for UEXCEED, UEXCEL, and UENDURE. And you'll notice that for UEXCEED and UEXCEL, you've got 2 columns, 45 milligrams of drug and placebo. And of course, for UENDURE, you've now got 3 columns because you've got the 2 doses of drug. I would like to highlight to you the median disease duration, which for UEXCEED is 9 to 10 years. This is a population where everybody has failed at least 1 biologic. So if you look at the bottom, what you can see is that the prior biofailure is 0, and you can see that the patients who have failed 1, 2, and 3 or more biologics is there. So a third of the patients in UEXCEED have failed 3 or more biologics. 10 years of disease duration. This is a refractory population. In UEXCEL, 50% of patients are non-biofailure patients, so they're bio-naive. The median disease duration here is 6 years, and then in Endure you can see the blended population coming through. Upadacitinib meets both co-primary and most ranked secondary endpoints across 3 phase trials. So here you've got the 2 induction studies, and I'm going to show you the data for the primary endpoints, which are clinical remission at week 12 and endoscopic response at week 12. And we're going to show the same endpoints at week 52, clinical remission at week 52, and endoscopic response at week 52. The definitions are fairly standard. As we're starting to see now, there is a difference in the definition used for clinical remission and response for the US and outside US. So outside US, you've got the PRO2, average daily stool frequency score of 2.8 or less and not worse than baseline. But in the US, we've still got the CDAI less than 150. They show very similar results across all of the different endpoints. And then we've got the different endpoints, maybe just to point out the 3 different endoscopic healing points. We've got endoscopic response, which is a decrease in the SGA-SDDF of over 50% from baseline. Endoscopic remission, which is where the SGA-SDDF is 4 or less and at least a 2-point reduction versus baseline with no subscore than greater than 1. And then we've got ulcer-free endoscopy, which is the stringent endpoint for Crohn's disease we've seen in any trial to date. Here is a patient. Here is a patient from the study with very refractory, lifelong Crohn's disease. He's in his 30s. He's had it since early childhood. He's got a significant SES-CD score and CDA score, as you will see from his baseline severe Crohn's disease endoscopy. So the induction data results. You have the 2 primary endpoints. This is the clinical remission data across the 2 studies. Clinical remission at week 12 of 51% in UExcel and 40% in UExceed. Remember, UExcel is the less refractory population. UExceed is our most refractory population here. So you've got 30% of patients here failed 3 or more biologics in UExceed and 40% still going into clinical remission. Let's look at the biofailures by the non-biofailures in UExcel. You can see here it's 54% and 47%. So both biofailures and non-biofailures entering into clinical remission at week 12. What about clinical remission at week 12 in the US protocol? This is now looking at CDAI. The last slide was looking at PRO2. You can see really there's no significant difference to the previous slide I showed you. Endoscopic response at week 12, so this is an early endoscopic response, 46% in UExcel, 34% in UExceed, with a very substantial delta over placebo in both of these arms. You can then look in the subgroup analysis, looking from UExcel at the bio-naive population and also in the biofailure population. So this is a very important slide, I think. This is early, meaningful endoscopic response in both the bio-naive patients, but also in the very refractory biofailure population that we see here. What about further data to support the rapidity of the drug? We saw with tofacitinib already a few years ago just how quickly the drug was working in UC. We see with upadacitinib in UC very fast symptom response. What about in Crohn's disease? Well, I think it's very impressive to see already this clinical response at week 2, maintaining out through for the rest of the study. You see this for both of the populations here. And on the right-hand chart in the biofailure population, you see even greater separation from placebo early on. Here is endoscopic remission at week 12. So this is the more strict endpoint. The SGA-CD is 4 or less. You can see that that really is 30% in UExcel, 19% in UExceed, with a 16% delta over placebo. And we can see that now. This is endoscopic remission, that same endpoint. This is met by this patient I showed you before already at week 12, despite his very refractory history. But just getting our patients into response, remission, and endoscopic remission at week 12 is not enough. We need it maintained out to week 52. So let's look at the maintenance data. The maintenance data here includes the pivotal population plus some of the patients who had gone through the induction without reaching response, who then had an extra 12 weeks of induction with 30 milligrams of upadacitinib. And here we will see clinical remission at week 52, 46% in the 30 milligram dose, 36% in the 15 milligram dose. And we can maybe discuss this a bit later, but across pretty much all of the endpoints I will show you, look at the delta between the 30 milligram dose and the 15 milligram dose, and you'll see it's roughly 10%. And we know from subgroup analysis that it's more pronounced when you look at those people who are biofailure patients. So we can discuss what that means for dosing later on. So here you are, you see, you and your subgroup analysis, that middle chart showing the bio-naive population, 59 versus 44%. On the right is the biofailure population. Let's look now at durable clinical remission at week 52. So these are people in clinical remission at week 12 and maintained all the way through to week 52, 55%, 42%, and 14%. And you can see here, this is important, I think. In the biofailure population, it's 54% on the 30 milligram dose, it's 35% on the 15 milligram dose, indicating that I think that for most of these biofailure patients, the 30 milligram dose is the correct dose. That's what we're doing routinely in our clinical practice in Edinburgh. You and your data here, this is now looking at visible mucosal improvement, so endoscopic response, 41% versus 28%. You can see this. Again, look at this on the right-hand side. When you're going to start using this drug, you're mostly going to be using it in TNF-failing patients. In that population, that 42% endoscopic response at a year in the 30 milligram dose. Here we can look at endoscopic remission, the stricter endpoint, and now we're looking at steroid-free clinical remission at week 52. So you can look at the patient I showed you before. This patient has severe Crohn's disease at week 0. He then goes into endoscopic remission at week 12, and that's maintained all the way out to week 52. The safety of the drugs is very important for us to look at in detail. What is very reassuring to see, as I will show you now, is that we have data for upadacitinib, not just for Crohn's disease, but also for ulcerative colitis, and in addition for multiple other immune-mediated diseases, and I'm going to show you the data across all of these in a minute. This is the data on safety from induction, which is important because it's the 45 milligram dose, but it's really when you look out to maintenance safety that things become more important. Most of the early treatment adverse events are related to worsening of Crohn's disease, both in induction and then when we look out to maintenance. So here is the maintenance safety set. You've got serious adverse events that are higher in placebo. That's because of worsening of Crohn's disease. You have very few adverse events leading to discontinuation of the study drug, but it's not zero. You have serious adverse events with infection, which is lower with active drug because there is less active Crohn's disease. You do have a couple of minor other events, some significant events, including malignancy, but it's 1 or 2 cases not related to study drug. And then you have 1 perforation each across each of the study groups, so there's no significant signal there. You do need to vaccinate your patients against zoster. We can do that very effectively now using the Shingrix vaccine. If you do not vaccinate your patients against zoster, you will see shingles. This is a class effect. We see that across all of the JAK inhibitors, across all the indications, and I think in our IBD patients that's important. How do I do that in practice? I start the drug, I vaccinate with the first dose, not having waited, but within the first couple of weeks, we give the second dose of Shingrix 4 to 8 weeks later. This is, I think, a really key slide. This is the long-term safety of upadacitinib across rheumatoid arthritis, psoriatic arthritis, ANX-Bond, non-radiographic axial spondyloarthropathy, atopic dermatitis, ulcerative colitis, and Crohn's disease. The caveat, of course, is that it's only in IBD we're using the higher doses. We've got in atopic dermatitis a 30 milligram dose, but only in IBD the 45 milligram dose, and across rheumatology it's just 15 milligrams of dosing. But they have a more comorbid population, and overall you start to build this safety profile of information that gives us reassurance using these drugs moving forwards. So let me wrap up by showing you another patient. This is a young lady who came to me originally in 2020, absolutely desperate, with her mum, who was beside herself with worry. They travelled all the way from one of the remotest corners of Scotland to come across to my clinic. They arrive, as these patients typically do, very end of the day, a little tired, what's coming next, and then we have this very, very complicated situation. She's significantly undernourished. She's really pretty depressed as well and withdrawn, and her mother, as I said, beside herself with worry. She's had Crohn's disease for 5 years. She's been on azathioprine at an optimized dose throughout, but she keeps needing to have steroids. She's never gaining weight. She's really withdrawing. I'm like, okay, it's fine. We'll get on top of this. We'll start you on an anti-TNF. Everything will be fine. Of course, it wasn't that simple. Adalimumab, within 8 weeks, I'd optimized the dose to weekly. It's not shifting. Her calprotectin is still very, very high, 1,500. I give her ustekinumab. This will work now, and actually, it does initially. I'm very happy, but she has COVID, she has chest infections. Maybe it's that, maybe it's something else, maybe it's the antibiotics, but it's just as bad as forever. She's stuck on steroids. The ustekinumab goes up to 4 weekly. Mum says, can we not just restart the azathioprine? Sure, let's do that. Calprotectin is still over 1,000. Her bowels are opening 8 to 10 times a day. Okay, we need to move on. We move her now onto infliximab. We give infliximab, really aggressive dosing. Let's see how this works. But to no avail. She comes back having thought initially it might be working. I've just been in a persistent flare state for years, Professor Lees. What can we do? So we start her on upadacitinib, standard induction, 30 milligrams of maintenance. And look what happens finally. Week 10, her calprotectin, it's not normal, but it's 310. Her bowels are opening once a day. She says, I'm sleeping a bit better. My energy levels are improving. Month 6, this is September this year, calprotectin 142. Bowels are normal. She now can eat freely, whatever she likes. Sleep is good. She says, actually, my mood is very, very much better. And she comes back to see me finally last month. She's back at university. She's studying again. She's re-engaging with her social group. And the most important person who was smiling, her mum. She's finally happy. She's relieved that we've got there. So I think that's a really nice case to illustrate what we're doing here with this drug. Just to remind you how to use it practically, you've got a 45 milligram tablet, a 30 milligram tablet, and a 15 milligram tablet. They're all the same size. They all have some kind of MMX formulation inside, so you can't crush them, you can't split them. They have to be swallowed whole. But this is what you've got here. And overall, I think what I've shown you is a drug that in Crohn's disease works fast, heals the mucosa, durable clinical remission, with a safety experience that is well studied now overall, particularly in Crohn's disease. And then for us as gastroenterologists, importantly, a drug that works across ulcerative colitis and Crohn's disease. So I really think actually now, at the end of 2023, with these 2 new drugs, we have a huge opportunity to make lives better for our patients. You see a lot of sick patients with severe phenotypes here in Saudi. I do the same in Scotland. I would like to have the opportunity to discuss my experience with you in more detail. If you come along to the booth at 1:30 today, I will share some of these data again, and there'll be the opportunity to have a lot of discussion where we can chat about my experience and your early experience too. So thank you for this. I think maybe we have some time for some questions now, Turkey.
We do. Thank you so much. Please have a seat, Charlie. We'll take a few questions. Thank you so much. This was a great tour de force of the data in upadacitinib. Professor Lees will be available at 1:30 in the AbbVie booth to further discuss the practical aspects of using this agent in patients with Crohn's disease, and he has kindly accepted the invitation of the Saudi Gastroenterology Association to present another lecture related to nutritional aspects of patients with inflammatory bowel disease, and this will be late in the afternoon at 4 p.m. So while people gathering their thoughts, I have a question for you. The cases you presented, both the one in your practice and the one from the clinical trial, involved patients with previous failure to anti-TNF and relatively refractory patients. In our system, especially in the private sector, you can actually start JAK inhibitors as first-line agents after failure of conventional therapy. Would you recommend this, or would you rather advise patients to go through anti-TNF and then try a JAK inhibitor?
Yeah, thank you. So our initial experience a year ago was before the drug was formally approved. So in that situation, we started using it in patients who had run out of options. These patients were stuck on, escalated doses of ustekinumab or vedolizumab, but still, with significant active disease. So we were treating patients then, and then as the approvals came through, we started to move it up and up and up. So now, what are we doing? So now I've moved it right up to after TNF failure. Typically still probably second TNF failure. So if I have a patient that has a true primary non-response to TNF, fine, I'm not going to a second TNF. But if I have a patient with secondary loss of response to TNF, second TNF, if they fail that, then we're going on to either upadacitinib or on to risankizumab, depending on their profile and their preference, etc. Would I use upadacitinib first line in Crohn's disease? Yes. Have I done that yet? No. For us, it's quite difficult because actually we live in the UK in a biosimilar world, and anti-TNF is effective for Crohn's disease. I would like to start using it in this patient population. I think for now, my recommendation is that this is a really good drug to use early after TNF failure, before other drugs, particularly before ustekinumab and vedolizumab, co-position with risankizumab there. But yes, I would use it first line, but bear in mind we have a few different options there.
Perfect. Dr. Al-Wardi has a question.
Professor Lees, great talk as usual. My question is regarding patients with an ileostomy. We've had at least one patient who would see the capsule in the ileostomy bag, although they're clinically better. So how do you handle these situations?
We've had the same issue occasionally. I think, I have treated a lot of patients with ileostomy, no problem at all. So I think this is definitely the exception, but it does happen. There are a couple of different approaches. You can try slowing down the small bowel transit with the drug to try and improve absorption. Sometimes it just needs a bit of time. So for a couple of patients, it's just been a transient thing. And actually once the drug bites, everything slows down and they're doing better anyway. For other people, it's just going to end up being an issue. And in which case, if they haven't had it already, I would move them across to risankizumab, probably in that situation. There is, as I said, you can't crush them or split them, or there's no widely available liquid solution yet. I suspect there will be in the future, but there isn't yet.
Thank you.
Thank you, Dr. Boardi. Now, you alluded to the mechanism of action and the fact that upadacitinib, like filgotinib, is a selective JAK1 inhibitor. Do you think this has implication on the safety? Is that the reason why we didn't see safety signals as we did with tofacitinib, for example?
Yeah, I mean, I think the first thing we see is that this molecule is really highly effective. And it looks to be the most effective of the JAK inhibitors that we have. In terms of the safety, I think we are seeing that, you know, particularly once you take zoster out of the equation, because zoster does look to be a class effect. Once you take that out of the equation, which you can, just vaccinate, then the safety profile looks, you know, really quite good. And I think probably a lot of that is responsible from the JAK1 selectivity. I think we all are waiting to see more longer-term safety data with all small molecules in IBD, and that will come. But the early signs from the pivotal data look good, and from my experience, you know, it seems reasonable.
Now, to the point that Dr. Bouardi raised earlier on, which is the probably effective of JAK in small molecules in patients with specifically small bowel disease. I think there was the Divergence trial looking at another JAK1 inhibitor, filgotinib, in patients with disease limited to the ileum, which showed promising results. So would you say these agents are still effective in patients with pure ileal disease?
Yeah, absolutely. They absolutely are. And in fact, many of the early patients I treated have pure ileal disease, and you know, it's working there for sure. The data from Divergence with filgotinib is interesting, actually. I mean, I suspect what you're seeing with that molecule with filgotinib in Crohn's disease is the failure is due to it just not being quite potent enough, particularly during induction, partly related to the inherent properties of the molecule, and partly related to the dosing of the molecule. So I think, yeah, and probably similar with tofacitinib as well, actually. You know, there you have and this comes back to your point before around JAK1 selectivity. Tofacitinib probably works in Crohn's disease at a 30 milligram dose, but there, because you've got a pan-JAK inhibitor, you're maxing out on the, you know, the safety efficacy window. You're going above the threshold, so you're not able to use the drug. So to me, it's clearly an MOA that works in the small bowel as well as it does in the large bowel. And many of the patients who have been really stuck in my practice in the last year, bearing in mind we've treated about 80 patients now, have been refractory small bowel patients. And I would add another point. Many of these patients have quite severe fistulizing disease, and a number of them we're starting to see not just response, but healing of the fistulas as well. And that's borne out from what we saw with the initial post-hoc analysis from the UXceed, UXL, and Urindril data set. So I'm quite optimistic there, actually. I'm not sure how long it will be before we see a dedicated fistula RCT with this MOA, but I am more inclined, if someone has fistulizing disease, to move them straight now from an infliximab failing situation onto upadacitinib, so that we can get them healed both mucosally and fistulas.
Great. Any other questions? It's perfect. So this concludes the session. Thank you so much. We'll have a break and we'll be back at 5 to 11, so 10:55. Thank you.
Alaikum wa rahmatullahi ta'ala wa barakatuh. Can we call can somebody ring the bell or something so that we stay on schedule, please, and call the people, the colleagues outside? Okay, Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salam ala Rasulillah. Good afternoon, ladies and gentlemen. We are going to start the next session. The first lecture is going to be given by Dr. Iman Salais. She is a consultant gastroenterologist at King Fahd Specialist Hospital in Dammam. She's a consultant gastroenterologist and IBD and intestinal rehabilitation specialist. She completed her clinical IBD fellowship from Cambridge University Hospital in the United Kingdom and has an interest in research related to IBD and has published numerous important projects in this field. One of them is a recent ECHO guidelines on inflammatory bowel disease and malignancies in 2012. and she is going to tell us about managing IBD patients with history of malignancy. Dr. Iman, please.
Assalamu alaikum. Good morning, everyone. Thank you, Prof. Gary, for the nice introduction. It is a real pleasure to stand here and present in our annual meeting. My talk today will be about managing IBD in patients with a history of malignancy. I don't know how to move. How to move the slides, please? Yeah. So this is my disclosure, and we'll start with a case. So Miss A is a 50-year-old female diagnosed with ulcerative pancreatitis last year. Later in the same year, she was diagnosed with breast cancer. Since the diagnosis, she was kept on oral and topical 5-FA. Although she remains symptomatic, she has mild abdominal pain on and off with diarrhea, bowel motion around 2 to 3 times per day. Unfortunately, early this year, she presented to the emergency department with picture of acute severe UC. We did abdomen X-ray, showed no toxic megacolon, stool analysis indicate that there is no C. diff infection, and we did flexible sigmoidoscopy within 24 hours of the presentation, which showed MyoScore 3 active disease. We started her on IV methylprednisolone, and she responded very well. CMV was negative, and she was discharged in oral prednisolone. We set MDT discussion for her, and we discussed the case with our colleagues, the oncologists, and the decision was to go for vedolizumab. So on which basis we usually take decisions in such setting? We have, on one hand, malignancy. We have to keep in mind the aggressiveness of the tumor and the modalities that we are gonna to use and their impact on the IBD. We have to keep in mind is the cancer is active or recent. On the other hand, we have the IBD, so we have to keep in consideration the disease severity, current and recent disease activity, and the available options of treatment and their impact on the tumor. So my talk will be divided into 2 parts. In the first part, I'll talk about the tumor aggressiveness and impact of the tumor treating modalities on IBD course. And in the second part, we'll talk about the data available and safety of IBD medications in setting of recent or active malignancy. And we'll do that by going through the ECO guidelines, the recent one published this year, 2023, and we'll then shed a light on the largest available data for each statement. So we'll start with the first part by asking this question. Which of the following malignancy treating modalities doesn't increase the risk of IBD flare? If you can just showing hands, is it radiotherapy, hormonal therapy, immune checkpoint inhibitors, or all of the above? Who vote for A? Radiotherapy doesn't increase the risk of IBD flare. Who vote for B? What about C? D? Okay. So what evidence we have? Data on use of checkpoint inhibitors and hormone therapy indicate that there is increased risk of relapse. Radiation and chemotherapy, on the other hand, do not. Patients should be monitored, of course, closely for potential flare. So what available data we have on the safety of radiation therapy? We have systemic review published this year, included 12 retrospective studies. Total number of patients was 129. And population included in this systemic review were patients with prostate cancer and IBD. And the result was radiation therapy associated with low rate of grade 3 plus GI toxicity. We have the largest cohort published in 2017, total number of patients 240 with IBD and prostate cancer. They compare radiation with non-radiation modalities of treatment, and again, the risk of IBD flare was low. The only predictor for disease flare was the disease activity in the preceding year of the cancer diagnosis and treatment. What about the safety of chemotherapy? We have retrospective cohort published In 2020, total number of patients was 447 patients. The patient was with IBD with either breast cancer or prostate cancer. Among 34 patients who received chemotherapy, 75% remained in remission. In the same study, they included also that the hormone therapy with or without chemotherapy increased the risk of relapse almost two-folds. What about the immune checkpoint inhibitors? Just a few words about the immune checkpoint inhibitors. It is monoclonal antibodies that inhibit T-cell activation and function, and it is widely used now in cancer. It has beneficial effect in more than 14 kinds of cancers, like skin, lung, renal, and hematological malignancies. And also, it includes a lot of side effects, and toxicities include endocrine, skin, GI, and liver toxicity. From the GI side, can cause colitis, hepatitis, and pancreatitis. Important to mention, it is commonly affects the GI tract, and especially the colitis. It can happen in 5 to 25% of the patients and can be life-threatening. So what data we have on the safety of immune checkpoint inhibitors in IBD cohort? We have a retrospective study included 548 patients with a solid tumor malignancy treated with ICI. 20 patients with pre-existing IBD. The flare occurred in 20%, with median of 7 weeks. All the patients treated with systemic steroid, 2 required anti-TNF, and 1 required vedolizumab, followed by colectomy. Also, we have systemic review published in 2018, included 49 publications, total of 123 patients with several autoimmune diseases included. 13 of them were having IBD, and the flare occurred in 40%. So we can conclude that we have signals indicate that hormonal therapy and immune checkpoint inhibitors can increase the risk of relapse in our IBD patients, while the radiotherapy and the chemotherapy are safe. So moving to the other topic, which of the following malignancy considered as being low risk of recurrence? Vote by showing hands, please. Lung cancer? None. Cervical cancer? None. 1. And testicular cancer? 1. And GI cancer? Nobody. Okay, so the data from the IBD cohort is really limited, but what we know from the transplant literature, that the cancer type is an important determinant of recurrence of the cancer. And we know from the literature of the transplantation that lung, GI, cervical malignancy associated with a higher risk of recurrence. On the other hand, prostate, testicular, and hematological malignancy are having lower risk of recurrence. We'll move to the second part of the talk about safety of IBD medication in setting of recent or active malignancy. Before we do that, we'll take another question. Do patients with IBD and history of cancer carry a higher risk of developing new or recurrent cancer? A, solid yes. B, solid no. Only if they were on immunosuppressive and or biologic agents. 1. And the data is really limited and conflicting in this setting. None. Okay, so what we have as a data in IBD cohort, we have the SESAME cohort, which is a prospective observational cohort of almost 17,000 patients with IBD. The report from 2014 included 405 patients with cancer and follow-up time of 2 years. It showed that there is increased risk of developing cancer, whether it is new or recurrent, with a predominant incidence of new cancers. They studied the role of the immunosuppressive therapy and showed that it is despite the immunosuppressive therapy, IBD patients carry higher risk of malignancy. Also, we have systemic review of 14 studies, included almost 900,000 patients. Both Crohn's disease and ulcerative colitis showed signals that increase the risk of skin and hepatological malignancies. Also, ulcerative colitis increased the risk of lung and hematological malignancies. Again, in this study, showed that immunosuppressive therapy have additional risk, but IBD can carry risk of higher malignancy. But I have to comment on these studies that isolating the effect of the immunomodulators and the biologic completely was really difficult. So I'll say the data is limited and conflicting, and we need more studies to prove these results. Also, we know that our medication can also increase the risk of certain malignancy. We know that thiopurine can increase the risk of the lymphoproliferative disorders, myeloproliferative disorders, non-melanoma skin cancer, and cervical cancer. We know also that the anti-TNF increases the risk of melanoma and lymphoma, especially if it is given in combination with thiopurine. It seems that vedolizumab and ustekinumab are safe in this setting, and JAK inhibitors increase the risk of non-melanoma skin cancer and rheumatoid arthritis population. I have to comment on this, that this also gives us signals as a clinician. Do not extrapolate data from other cohorts other than the IBD, especially in this setting. Methotrexate can increase the risk of non-melanoma skin cancer. So what data we have about the safety of thiopurine use in patients with recent malignancies? The ECO guidelines stated that no additional risk of incident cancer with thiopurine use in patients with IBD and past history of malignancy beyond the known risk associated with this class. Although I have to mention that most of the data were from observational studies, and the patient in that studies started the thiopurine more than 5 years after the cancer resolution, and patients were with a low risk of cancer recurrence. So we have data, but with limitation. We have also meta-analysis included 12,000 patients with immune-mediated inflammatory disease and past history of malignancy, and the risk of cancer was not greater in patients receiving immunomodulator therapy. When they did also subgroup analysis restricted to IBD patients, the result is the same. So the ECO guidelines stated that it is reasonable to start patient on thiopurine with caution after appropriate consideration of risks. Screening examination in patients using thiopurine after cancer should follow the same guidelines as those applied to general non-IBD population. I have to add that you have to consider also the availability of other safer modalities. What about active cancer and thiopurine? Thiopurine should be preferably withdrawn in patients with active cancer diagnosis until the cancer is controlled. Patients with cancer or preneoplastic lesion to be deemed to be at low risk of recurrence, like non-aggressive basal cell carcinoma or preneoplastic lesion of the cervix or sporadic colonic polyps, thiopurine may be continued in this setting with the close monitoring. What about methotrexate? We have insufficient data to make any recommendation in the use of methotrexate in this setting. Anti-TNF can be used with patients with current or previous cancer, but keep in mind that the data on individual cancer types and timing of treatment with anti-TNF are lacking. So you have to set, again, MDT setting and discuss the patient case by case and take the best decision. What we have as available data on the safety on anti-TNF, we have systemic review and meta-analysis published in 2019, included 9 observational studies, 12,000 patients with a history of cancer, 4,000 patients exposed to anti-TNF, and there is no increased risk of cancer recurrence. And when they restrict the analysis to the patient with diagnosis of IBD, the result came the same. We have also a recent retrospective cohort study published in 2022. IBD patients exposed to anti-TNF were a total of 184 patients, compared to patients with IBD non-exposed to anti-TNF, total number of 183, and it showed the same result. There is no increased risk of new or recurrent cancer in these patients. What about vedolizumab? IBD patients with history of prior malignancy do not appear to have increased risk of cancer recurrence or new cancer when treated with vedolizumab. The data on the use of vedolizumab in patients with active malignancy are inadequate to draw any conclusion. So the ECO guidelines give us signals that you may use vedolizumab in setting of past history of malignancy, but in case of active malignancy, we don't have sufficient data. So what available data we have? We have retrospective cohort study that compared IBD patient exposed to vedolizumab after a prior cancer diagnosis, total number of patients 96. They compared it with patients with IBD with no exposure to immunosuppressive therapy, total number of patients 183, and there is no risk of cancer recurrence. When we move and talk about ustekinumab, again, the ECHO guidelines stated that the patient with IBD and history of a prior malignancy do not appear to have increased risk of cancer recurrence or a new cancer when treated with ustekinumab. Data on the use of ustekinumab in patients with active malignancy are inadequate to draw any conclusion. What we have as available data on the safety of ustekinumab, we have retrospective cohort study published in 2022. Total number of patients treated with ustekinumab was only 14, and the signal indicates that there is no increased risk of cancer recurrence or new cancers when treated with ustekinumab. Again, just to emphasize, do not extrapolate data in this setting from other cohorts. From SOLAR registry, ustekinumab showed some signals of increased non-melanoma skin cancer, but in our cohort doesn't. What about JAKI? There is insufficient evidence to make recommendation in the use of JAKI inhibitors with current or prior malignancy, whether it is inside the IBD literature or even outside the IBD literature. So the last part of my talk will shed a light beyond the ECHO guidelines. We have a very nice paper published June this year in which they address this very specific question, and I'm glad to say that our dear colleague, Dr. El-Bawardi, was co-author in it. So this study was a multi-center retrospective cohort study, and they have two cohorts in this study. Cohort A with active cancer, total number of patients 125, and cohort B with recent prior cancer, total number of patients 170. 75% of patients in cohort A and 84% cohort B were having a solid organ cancer. And they divided the modality of treatment to anti-TNF and non-anti-TNF modalities, including vedolizumab, ustekinumab, and thiopurines. And they look at progression-free survival in cohort A as a primary outcome and recurrence-free survival in cohort B. If you can see here that in cohort A, the patient with active cancer, almost 44% were on anti-TNF, and a third of the patients were on non-anti-TNF modalities. 31 patients were on vedolizumab, 9 patients on ustekinumab, almost a quarter of the patients were on immunomodulators therapy, 22% of them were on combination. And you can see from the graph nicely, there is no difference between the patient treated with anti-TNF compared with non-anti-TNF with a p-value of 0.144. In the cohort B, patients with recent cancer, almost half of them were on anti-TNF, and 36% were on non-anti-TNF modalities, 51 on vedolizumab, ustekinumab, only small number of 15 patients, 15% were on immunomodulator monotherapy, 12% were on combination. And you can see from the graph nicely that there is no difference between the patient treated with anti-TNF when compared with non-anti-TNF modalities in these patients. To conclude and wrap up my talk, so in these patients, please do not take individualized decision. Please set MDT and discuss the patient with our colleague, the oncologist. Engage the patient in the decision. Factors to be considered: disease severity from IBD side of view, the disease severity and disease activity, and also the available options and the data available in the safety of these medications. Also, from the tumor side, you have to consider the tumor aggressiveness and the modality the patient will be treated with. And to conclude, we can say that we have signals that the anti-TNF, vedolizumab, to lesser extent ustekinumab, are safe. And I put the remaining medication in orange because we have insufficient data to comment on them. So thiopurine, methotrexate, and JAKI, still we are lacking data. And thank you so much for your listening.
Thanks a lot, Dr. Iman Sles, for this nice and elegant talk. I'm pleased now to introduce the second speaker for this second session of inflammatory bowel disease, Dr. Badr El-Bawardi, is currently working as a consultant gastroenterologist and IBD specialist with the King Faisal Specialist Hospital. So he's a colleague, and he's currently as well an adjunct associate assistant professor at Yale University and at Al Faisal University as well. Dr. Bouagdi has completed his medical school at George Washington University. Then he joined Mayo Clinic Rochester for his postgrad training. He led as well and created the IBD fellowship at Yale University before moving to Riyadh. Dr. Bouagdi is known in the IBD community for his active contribution in research. He's been leading in that, and as well has been an editor in multiple journals. Dr. Bouagdi has a difficult task today to inform us about a hot topic in the field of inflammatory bowel disease. So Dr. Bouagdi is going to talk to us about positioning advanced therapies in inflammatory bowel disease. Without further ado, Dr. Bouagdi, the floor is yours.
Okay, Assalamu alaikum wa rahmatullah jami'an. Before I start, I want to congratulate the organizers on an extremely well-put conference as usual, and also thank our moderators for the kind introduction. So these are my disclosures. See, the objectives of this talk is to first review the newly approved agents for IBD and to talk about the comparative effectiveness and safety of these agents, and then we'll try to end with a more practical algorithm on how to position first-line therapies. So I'm going to start out with a case. This is a 35-year-old woman who was recently diagnosed with Crohn's ileocolitis. She comes to you with minimal symptoms, about 4 to 6 non-bloody bowel movements a day, some episodic right lower quadrant abdominal pain. She has no extraintestinal manifestations. She is a smoker. So your limited workup reveals no C. diff infection. She is mildly anemic with a hemoglobin of 10, and she also has elevated inflammatory markers. These are images from her ileocolonoscopy, and the first image shows large deep ulcers in her terminal ileum, and also in the ascending colon you see similar ulcerations. Images from the CT interrography reveal an extensive long segment of terminal ileal wall thickening and hyperenhancement, but there is no stricture and no fistula. So I'm going to pose a question to the audience, and this is sort of the daunting question we see now in our clinics. This is a biologic naive patient. She's coming into you with extensive ileocolonic Crohn's disease. Which of these agents would you start first? So the A is telling you, are you going to do the corticosteroids with immune modulator? And then choices B through H, are you going to pick an advanced therapy? And if so, which advanced therapy? So I want you just to take a quick look at these options, and in your mind, if you're sitting in clinic, which of these options would you select for the patient? I'm going to take a very quick poll. Any takers for A? None for A. How about infliximab? I see many choices for infliximab. How about adalimumab? Some for adalimumab. Certolizumab, I assume none. Ustekinumab? We have a split between infliximab and ustekinumab. Risankizumab? None so far. Veto? None so far. And how about upadacitinib? We have a couple for upadacitinib. Okay, so before we talk about these individual patients, I'm just going to take a step back and review the differences between disease activity and disease severity. So disease activity, think of this as a snapshot in time. This is the patient's clinical symptoms, their inflammatory markers, their endoscopic findings. It's certainly very important to take into consideration. The only limitation with disease activity is it does not necessarily correlate with progression or natural history. Now, disease severity, on the other hand, is our prognosis. It's how the patient will do over time, and it's what we take into consideration to say if the patient needs advanced therapy, and if so, which advanced therapy. So let's go over examples of what we consider high-risk disease in ulcerative colitis and Crohn's disease. So these are factors of disease severity. So for UC, young age, extensive large ulcerations, extensive involvement, elevated inflammatory markers, hospitalizations, concomitant infections such as C. diff or CMV, and need for corticosteroids are high-risk features. So when you see these features, you know that this patient is going to need advanced therapy. So what about Crohn's disease? So let's do an exercise on our patient. So we had a young patient, so she satisfies one of the criteria. She has deep ulcerations. She has extensive anatomic involvement, elevated inflammatory markers, and she's also a smoker. So we have determined that this patient has high-risk disease. So she does qualify for getting advanced therapies instead of using step-up therapy as we used to do in the past. So before going into individual agents, there are a couple of factors that we have to take into consideration that we know make our advanced therapy work better. And one of them is early use of biologic therapy, and this has certainly been shown in Crohn's disease more than ulcerative colitis. And in this nice systematic review and meta-analysis of over 18,000 patients, they had two groups, a group that had early start of their biologics, so within 2 years of disease, and another group which initiated biologics later in their course. And this included patients on anti-TNFs or vedolizumab. So in the group that received biologics within 2 years, these patients had higher odds of clinical remission, higher odds of endoscopic healing, and even lower relapse rates. The other factor that we have to take into consideration is that our biologics or advanced therapies in general work best when they're first line, and the effectiveness goes down as second and third line. And this was nicely shown recently by a large cohort from the UK IBD bioresource, which looked at effectiveness of agents and also at sequencing, which was defined as persistence of drug. And I'm also happy to say that one of our colleagues, Dr. Iman Slace, was an important co-author in this important study. So I'm just going to share one of the results of the study, and it looks at persistent or drug effectiveness. And if we look, the red line is first-line therapy, the blue line is second line, and then the third line is third-line therapy. So if we have effective first-line therapy, that tends to persist more, but when the patient's on their second or third-line agents, the persistence wanes and the effectiveness wanes. Okay. So this is the US FDA approval timeline. So in 1998, we had the first approval of advanced therapy with a biologic, which was infliximab for Crohn's disease. So at the top of the chart is Crohn's disease, and at the bottom is ulcerative colitis. And it wasn't really until 2014, with the exception of natalizumab in 2007, that we had non-anti-TNF biologics with vedolizumab for both UC and Crohn's, and then subsequently ustekinumab. 2018 is an important year because that's when we had our first small molecule approval with tofacitinib for UC, and then subsequently ustekinumab. But look at what happened in the past 3 years. We have a significant expansion in these advanced therapies for treatment of UC and Crohn's disease, including upadacitinib, which we heard earlier, a selective JAK1 inhibitor, and then risankizumab, an IL-23 inhibitor, and etrasimod and ozanimod, S1P receptor modulators. So how do we select from all these therapies? Well, in an ideal world, we would have our patients, we would apply prognostic biomarkers, and we would isolate the patients with low risk and high risk disease. I showed you some clinical factors, and in my mind, the way we're doing it now is a little too late. It's when the patient actually develops these complications, we call them high risk. But in an ideal world, we would identify them early, and then after that, we would apply predictive biomarkers, and we would say patient would respond to drug A, drug B, drug C, or even we would say that maybe patient would have side effects to drug A, drug B, and drug C. Now, the only problem with this is it's not clinically applicable, and we're not even close to being there yet. So how do we help kind of sequence, or at least position the first-line therapy for our patients with IBD? And I think it's putting pieces of the puzzle together. So one of the factors we look at is effectiveness or efficacy of the drug itself. So this is looking at outcomes, onset of action, durability, immunogenicity or lack of immunogenicity. And then we look at safety. So I listed some of the safety factors, including malignancy and also infection. So over the next few slides, we'll talk about effectiveness and safety. So if we apply a truly evidence-based approach on comparing these agents, we have pretty much 3 different types of studies. We either have head-to-head clinical trials, we have systematic reviews and network meta-analysis, or real-world studies. And in my mind, all of these 3 different types of study designs are very important, and they all have their advantages and disadvantages. For a simple example, head-to-head clinical trials are great because you don't have any confounding. These are usually well-matched groups, but it's also a very restrictive patient population and not necessarily generalizable to the patients we see in clinic. And that's where real-world effectiveness or comparative studies come in. Now, for the sake of time, I'm only going to be able to hit on the head-to-head and systematic reviews and network meta-analysis. So this is really a landmark study. This is the CView study, which is a head-to-head randomized clinical trial comparing ustekinumab to adalimumab in biologic-naive patients. So there's a similar case scenario to our patient. And these patients were not allowed to continue concomitant immune modulators. And the main results of this study is that there was no difference between adalimumab and ustekinumab when it comes to primary outcome, which was clinical remission at week 52, and also all the secondary outcomes, including objective parameters such as endoscopic healing. And this is also some more data showing no differences in endoscopic healing between the two groups. Now, more recently, we had the sequence study, which I'm going to skip this one. The sequence study is a head-to-head randomized clinical trial, but it's second line. So we're looking at Crohn's disease patients who have been exposed in the past to anti-TNF and not vedolizumab, and they were randomized into either getting ustekinumab or risankizumab, which is our selective IL-23 receptor inhibitor. Now, this study had two major outcomes. One of them is clinical remission, which was a non-inferiority outcome. And what we see in this graph is that risankizumab was non-inferior to ustekinumab with higher rates of clinical remission approaching 60% compared to 40% in ustekinumab. The second objective of the study is to look at superiority with endoscopic remission, and it's shown here that risankizumab is superior to ustekinumab in terms of endoscopic remission with a delta of almost 15%. Now, when we look at the all secondary outcomes, these were superiority secondary outcomes. We see that risankizumab was superior to ustekinumab in terms of secondary outcomes. And just to remind the audience that this is second-line therapy after TNF exposure. Now, in terms of comparison of side effects were comparable between risankizumab and ustekinumab as shown here in this chart. So now let's move into the systematic reviews and network meta-analysis. There have been many of these published over the past couple of years, and I chose probably the most recent so far of these network meta-analyses. So network meta-analyses, what they do, they essentially are indirect comparisons based on clinical trials. And I'll share with you first data looking at induction of clinical remission in Crohn's disease. And what we see here is that infliximab, then risankizumab ranked highest in terms of induction of clinical remission in a biologic naive population. However, in a biologic experienced population, risankizumab, then upadacitinib ranked highest. And this is the summary of the systematic review and network meta-analysis. It showed that the overall ranking was highest with infliximab, followed by risankizumab, followed by upadacitinib. And then in biologic experience, it was risankizumab followed by upadacitinib. Now, I think it's really important to take a pause in this slide and discuss the limitations and consideration for interpretation of network meta-analyses. So these are not perfect studies. So findings should be interpreted with cautions. They are indirect comparisons, and there is confounding. These were comparing studies across different decades. So we have different disease durations. We have different concomitant medications. We also have different trial designs, quality, and outcomes assessment. Also, I think the follow-up period is too short in these studies to make assessment regarding safety, and some of the data was presented in conferences only. Okay, so now we're going to shift from Crohn's disease into UC. So we're going to take a case of an ulcerative colitis patient. This is a 68-year-old man with UC, pancolitis, not responsive to maximum oral and topical mesalamine. He had a colonoscopy that revealed active pancolitis with Mayo UC endoscopic subscore of 2. His past medical history includes diabetes, hypertension, coronary artery disease, and class 3 CHF. So you see this patient in your clinic. He is biologic naive, and you've already established that this patient does need an advanced therapy. What is the next best step in management? Would you choose one of the anti-TNFs, infliximab, adalimumab, Vedo, Tofa, upadacitinib, ustekinumab, or our newest agent in UC, which is mirikizumab? So I'll let you just glance at the different options and just have an option in your mind, and then I'll move through just for time's sake. Okay, so when it comes to head-to-head randomized clinical trials in ulcerative colitis, we know the varsity trial compared vedolizumab to adalimumab, and in this trial, it was shown that vedolizumab is superior to adalimumab in ulcerative colitis when it comes to overall primary efficacy endpoint, which was clinical remission at 52 weeks. But in the biologic-exposed patient, there was really no difference between vedo and adalimumab. When it comes to endoscopic improvement at week 52, vedolizumab was also superior to adalimumab in terms of endoscopic improvement. What about network meta-analyses for moderate to severe UC and advanced therapies? There has been many of these network meta-analyses done over the past couple of years, and they've actually shown similar results. So I'm going to choose to review one of these network meta-analyses. So first, we're going to look at induction of clinical remission. In induction of clinical remission, upadacitinib ranked highest, followed by infliximab. And in the induction of endoscopic improvement, infliximab 10 milligram per kilogram ranked highest. So if we review these indirect comparisons, for moderate to severe UC, clinical remission, upadacitinib ranked highest, and for endoscopic improvement, infliximab 10 milligrams per kilogram ranked highest. And recall, we discussed the limitations of network meta-analyses. So how about in biologic-exposed patients, the induction of clinical remission? Again, upadacitinib this time ranked highest for induction of clinical remission, and also it ranked highest for endoscopic improvement. So based on indirect comparisons, in moderate to severe biologic-exposed UC patients, clinical remission was highest with the use of upadacitinib, endoscopic improvement also highest with the use of upadacitinib. And in terms of adverse events, upadacitinib ranked highest for adverse events, and vedolizumab ranked lowest. Okay, what about safety? So we spent a significant amount talking about effectiveness. We said it was part of the puzzle. Safety was the second part of the puzzle. And for time's sake, we can't review all the safety parameters of these different agents. But I've adapted the safety pyramid and added some of the new agents. So I'll go briefly over the safety pyramid. So on the top of the pyramid is what we think is our safest agents. So that's vedolizumab and potentially IL-12 and IL-23 receptor inhibitors. Now, the next three agents are not necessarily listed in order. That's the S1P receptor modulators, such as ozanimod, etrasimod, anti-TNFs, and JAK inhibitors. And on purpose, I've put arrows going back and forth between these three agents. And the rationale for that, I think the safety profile of these agents are really affected by the patient profile. I'll take a quick example. If you're seeing an elderly patient over the age of 50 or 65, with risk factors for coronary artery disease, we know that anti-TNF would be safer than a JAK inhibitor based on RA data. Now, subsequent to that, we have thiopurines, then anti-TNF combination therapy, and our least safe option to continue long-term is corticosteroids. So now we've talked about effectiveness or efficacy, safety, but we know that's the only two parts of the puzzle. The other two is the more, I think, in my mind, are more important. It's the patient who's sitting in front of us. So we want to know the patient's comorbidities, age, and potentially frailty, which plays more of a role in terms of safety of drugs. Pregnancy, the patient's preference is very important. The best drug is the drug that the patient is willing to take and adhere to. So that includes cost, route of administration, and then look at the disease as a whole. Does the patient have perianal disease, stricturing disease, fistulizing disease? Does the patient have extraintestinal manifestations? Has the patient had surgeries in the past? And what was the exposure to previous therapies? Okay, so I'm going to end with clinical scenarios where I would probably select one agent over the other. So this is not a perfect science, but it's from interpretation of the limited data we have to help us with sequencing these agents. So for Crohn's disease, I will reach to an anti-TNF, and if I do use infliximab, I use it in combination therapy unless there's a clear contraindication. In situations where there is a high inflammatory burden, penetrating or perianal disease, and extensive extraintestinal manifestations, we would obviously avoid if the patient has lymphoma, melanoma, MS, or advanced heart failure. The point I'm going to make about anti-TNFs, it does not necessarily have to be first-line therapy for every patient. For example, if the patient has a moderate to high inflammatory burden, whether it's small bowel or colonic disease, without penetrating or perianal disease, I think using IL-12, 23 inhibitors or IL-23 inhibitors such as risankizumab would be a good option, especially if the patient has limited extraintestinal manifestations such as skin manifestations or peripheral, not axial, peripheral arthritis. This will also be a good option in risk-aversive patients who are at risk for infections or even the elderly. And then I would place risankizumab higher than ustekinumab with what we saw with the sequence study. How about vedolizumab? Vedolizumab would also be a good first-line option for Crohn's disease patients who have more of a moderate than high inflammatory burden, predominant colonic location, no extraintestinal manifestations, or if they have minimal peripheral arthritis, which can sometimes parallel the bowel activity, I think vedolizumab is still a good option. When it comes to the safety profile, similar considerations to the IL-12, 23 inhibitors. Now, we heard about upadacitinib in the previous talk, and in major parts of the world, upadacitinib is reserved as a second-line option. Now, can we consider upadacitinib as first-line option? According to the drug label, you can still use it as first-line option. I think it would be helpful to use it in the patient who has a very high inflammatory burden, particularly if they have a low albumin, which we know is a risk factor for loss of response to our biologics. It would be a good option for a patient with extensive extraintestinal manifestations. However, we have to be cognizant of the patient profile. For example, it won't be a good first-line option in an elderly patient with VTE risk factors. So these are just potential clinical scenarios and not necessarily a guideline. But as you can see, in the appropriate scenario, you can consider one agent over the other. Now, what about ulcerative colitis, where we have more agents? So I would reach to an anti-TNF again first, and I'll make a quick point on anti-TNFs in UC. I no longer am using adalimumab for UC. I think we have good data from network meta-analysis to show us that adalimumab does work. It is superior to placebo. However, we have a plethora of other agents that actually work a lot better. So when I reach for an anti-TNF for UC, I'm reaching to infliximab and not adalimumab. And as discussed earlier, I typically use it with combination therapy because the risk of immunogenicity can approach 60% with infliximab. So it's a great option for your patient with acute severe UC. And if I use it in the hospital, I'm using 10 milligrams per kilogram. Also a great option for a patient with extensive extraintestinal manifestation. So vedolizumab is a wonderful option as a first-line agent for outpatient ulcerative colitis who has moderate to severe disease. And again, this is a good option for risk-aversive, infection risk, elderly patient, and minimal or no EIMs. Now, how do we position IL-12, 23 inhibitors such as ustekinumab or mirikizumab, an IL-23 receptor inhibitor? I think of it as a similar position to vedolizumab in terms of disease activity. So this is going to be your moderate to severe outpatient. Maybe the only difference is extraintestinal manifestation. So if your patient has comorbid psoriasis, comorbid peripheral arthritis, I think it would be a good option. And then what about upadacitinib and tofacitinib? So we know from network meta-analyses that maybe upadacitinib is a little superior to tofacitinib. And we also know that this is a more selective agent. So when I'm reaching for a JAK inhibitor, I might position upadacitinib higher than tofacitinib. So this might potentially be a good option for patients with acute severe UC with low albumin who potentially have been exposed to infliximab in the past. Again, extensive extraintestinal manifestation. I think upadacitinib will be a good option. And the same caution and avoidance in pregnancy, advanced liver disease, and in the elderly with risk factors. Now we still have one more class of agents, which is the S1P receptor modulators, such as ozanimod and etrasimod. The advantage of these is they're oral agents, so they're easy to use. They are dosed as once daily. What about where do we position them? Where do we put them across the other biologics and advanced therapies? From reviewing the data, I think these would be a good option to be used in biologic naive, so as first-line therapy. Especially for ozanimod, from the True North data, it seems that when it's used as second-line therapy in biologic failure, it's not as effective. So it's You want to avoid it in patients who have extensive heart block, recent MI or stroke, severe untreated OSA, pregnancy, or concomitant monoamine oxidase inhibitors. So I'm going to summarize. The armamentarium of therapeutic agents to treat IBD is rapidly expanding. We have limited head-to-head data on advanced therapies. Network meta-analyses are slightly helpful, but we have to interpret them with caution. And the choice of advanced therapy extends beyond efficacy and safety. We have to look at the whole patient profile, inflammatory burden, extraintestinal manifestations, and comorbidities. Thank you for your attention.
Thank you, Dr. Badr, for this amazing talk. Now, please join me in welcoming our next speaker, Dr. Muhammad Shihab. Dr. Shihab received his medical degree from the University College of Cork in Ireland. He then achieved MRCP diploma from the Royal College of Physicians in London, UK. This was followed by his internal medicine residency at the University of Toronto, and then his gastroenterology fellowship and advanced training at McGill University in Canada. He has many publications in the field of IBD in well-respected journals, and he's currently the Secretary General of the Kuwait Gastroenterology Association and consultant gastroenterologist at the Habib Center in Kuwait. The floor is yours, Dr. Shah.
Thank you. Assalamu alaikum. First, I would like to thank the SGA and the organizing committee for having me today. I'm very pleased to be in Jeddah for the first time. I really like it so far. I know we are, I think, the last talk before the Jum'ah prayer, so I try to summarize. This is a bit challenging to finish in 20 minutes, but I will do my best. So I'll talk today about if you have a patient with IBD who is not responding to therapy, which is a common scenario that we encounter in the clinic, what to do next. So these are my disclosures. So today I'll talk about the differential diagnosis in those patients who are not responding to therapy, how objectively we assess disease activity, and then we'll touch on therapeutic drug monitoring, then we'll try to talk about treatment optimization, and then maybe I'll touch on treatment sequencing. Already Dr. Badr talked about that. I'm not going to spend a lot of time on treatment sequencing. So first to start, like the IBD in the last century, treatment-wise and diagnosis has changed a lot. We know at the beginning we used to aim for symptomatic improvement. Once the patient was doing well, then we stop. We don't advance any therapies. But then moving on, we have more evidence that symptomatic improvement was not better or not enough. So then we have moving to more objective markers, blood tests, stool tests, endoscopy. And now also we have targets such as quality of life improvement, preventing complication, day out of work, and so on. Also management-wise, like for many years, we only had steroid immunomodulator until the era of biologic, the beginning of 2000, where we start having biologic, which changed the way that we treat maybe IBD or better treatment. And recently, maybe in the last 5 years, maybe Dr. Badr showed you, there is a lot of molecules and medication coming in IBD. So the treatment of IBD has been changed dramatically over the last couple of years. So when you have a patient who's not responding to therapy, the first thing you have to ask your question is this patient not responding because of IBD itself or there is something else? Because this is very important. Not every patient, because we get called sometimes a lot, or we get patient admitted with IBD flare, they do not have IBD flare. So not every patient with IBD who has diarrhea or abdominal pain do have an IBD flare. So if the patient does have IBD, then we'll talk about that later. The first thing the patient does not, you don't think they have IBD, so what else? So this is like a figure which was, I think, nice, was presented in the Crohn's and Colitis Foundation. So the common mimickers of IBD are infections. The first common one we know, like C. difficile. So if you have a patient with IBD who is presenting with a flare, make sure that patient does not have C. difficile. To a lesser extent, CMV is also common, but we don't routinely test it with every flare. If the patient is refractory to treatment, usually we test for a CMV. And other infections are also common, like patient with IBD also entitled to have a gastroenteritis and other like these uncommon infections. Irritable bowel syndrome is common with patient with IBD in remission. Some studies quote like maybe up to 40% of IBD patients may have IBS during remission. I'll talk about that in the next slide. Bile salt malabsorption, patient with Crohn's, especially, patient have surgeries with small bowel resection, gallbladder removed, they may have bile salt malabsorption. Short gut syndrome, not so common, but if you have a patient with Crohn's who have many surgeries with the lift, which is small bowel lift is short, then may have also short gut syndrome. Drugs also, we know like non-steroidals, for example, are one of the mimickers of IBD. And other drugs like in the market now, recently we have immune therapy, for example, for cancer. They also like can present like colitis and IBD, and there are other drugs. So we have to be aware of these other causes of IBD. SIBO is also like can be associated with IBD and one of the mimickers. We know SIBO now is in our country at least we call it the new HEBA, or it's being very commonly used, especially in the private sector. But not every patient with bloating or diarrhea also have SIBO. It's very uncommon causes of a flare. So just talking about IBS. So IBS is very common in patients with IBD. You have a lot of patients in IBD in remission. They present with IBS. And this is just a recent study. It's a very nice prospective multi-center study. They examined like more than 1,000 patients with IBD. They only excluded those with active disease based on the HBI score and partial Mayo score. They left with 206 patients in clinical remission. And if you can see like around 16 or 7, like around on the red, in the first figure on the red are those patients who does not meet ROM3 criteria symptoms of IBS. They do have some IBS symptoms, but they don't meet ROM3 criteria at the baseline, even after 12 months of follow-up. But the majority of patients, the minority, they meet the criteria. However, the majority do not meet the criteria. So patient may have some abdominal pain, constipation, diarrhea, but they don't meet the ROM3 criteria, which are the majority of patients with IBD in clinical remission, but they have IBS symptom. If you go like by how of them resolve, so like if you can see like 18% of those patients, their symptom resolved during the 12 months period, and another 18% will have persistent symptom of IBS during the first 12 months when they are in remission, but the majority of those patients fluctuate, like they have up and down IBS symptom. So it's very important to take a good history. We know like history is important. Even as a consultant, you need to take a detailed history. Does the patient have nocturnal symptom, which is not usually common with IBS? Does the patient have blood in the stool, decreased appetite, weight loss, and so on? So you have to take a good history to differentiate, does the patient have an active IBD flare or IBS? And then you need to use some objective markers such as fecal calprotectin and CRP to make sure this patient does not have a flare. And also you have to bear in mind that CRP and fecal calprotectin, although we use them very often and they're good inflammatory marker, they're not 100% sensitive and specific. We have those patients, I'm not going to go into detail about this, but if the patient also have a normal CRP and a fecal cal, if you think the patient have an IBD and you have susceptibility of IBD or your pretest probability is high, then you have to move on for other investigation. So if your patient, you don't think the patient have other causes of IBD, so IBD, you think the patient has an active flare. So what to do next? So the first thing is check with adherence. Don't assume that your patient is adhering to the medication. Whether your patient is taking oral tablets, sub-Q biologics or IV infusion, your patient may not be compliant to the medication because our patients, the majority are young, they don't like taking the medicine, they miss their doses. So first thing, check adherence. This is like a very nice study. It shows you like the laws of erosive response with anti-TNF and adherence to treatment. And if you can see like what they call higher medication position time, which is the adherence, MPR, patients who were like around 100% adherent to the medication were the most least likely to have loss of response to anti-TNF, where those patients who are like 0 to 40% adherent to their medication have around 100% of them lost response to anti-TNF. So, and the risk factor for loss response was the low APR and steroid use. So make sure the patient is adherent to the medication before you escalate therapy or if you do something else. So if your patient, you think they're adherent to therapy, the patient but still having IBD flare, so how you check or make sure the patient is reaching the target that you want. So what are our targets? So we know like try to set us like target guidelines for us. First we start with UC. Our immediate target is clinical response, then clinical remission, and a clinical response and remission. Now we define it by PRO2, which is basically rectal bleeding and stool frequency. Rectal bleeding has to be 0, no rectal bleeding and stool frequency. Patients allowed to have 1 or 2 bowel motion more than what's the usual or that is average before the flare. And then intermediate like targets is normalization of fecal calprotectin and CRP, and the long-term target is endoscopic remission, which is a Mayo score now is of 0, and restoration of the quality of life, so patient does not have any disability, patient can go to work, there is no absence of school, and so on. How about in Crohn's disease? A similar thing. In Crohn's disease, it's similar thing. We also aim for Pro2, so stool frequency and clinical thing before moving to Crohn's. So we'll talk about these are some older slides, sorry, but just for time I shortened them. So there is a new definitions of UC, just to be aware of. So if you read the clinical trial now in 2023, you will see some terms, maybe they mean are different things. So endoscopic improvement now means if a patient has Mayo score of 1 or 0, endoscopic remission means patient has Mayo score of 0. And there is a newer term like histological endoscopic mucosal improvement, or HEMI, is that basically patient have endoscopic improvement plus Juba score of less than 3.1, and the mucosal healing means the patient has a Mayo score of 0 plus a Juba score of 2. So those, just to get familiar with this term if you're reading a study. So in Crohn's disease, also like we're aiming for clinical improvement first with Pro2 improvement of more than 50%, and intermediate target is the Pro score improvement of less than 1, or HBI score of less than 5, and normalization of fecal calprotectin and CRP, fecal calprotectin less than 250, although maybe the AGA have now a stricter target they just published of 150, but this one may be not maybe a current target, but for now we'll go with the try-to with fecal calprotectin less than 250. And the long-term target is endoscopic healing Crohn's disease, which is defined as SCD score of less than 3. And maybe like in UC, the coming target will be histological healing, and in Crohn's disease, maybe transmural healing with MR enterography and intestinal ultrasound. Maybe these are the coming target, but for now, endoscopy is our current target. So I'm just going to move on just for the sake of time. So if your patient is objectively, the patient is active based on the objective measure I talked to you. So what to do next is optimize therapy. So first we'll start with 5-ASA. So one of the common scenarios we see in clinic, the mesalamine patient in low dose mesalamine. And you see a lot of patients being like in 500 milligram mesalamine or 1 gram mesalamine. Even in patient in remission, the maintenance dose should be at least 2 grams per day. Don't make your patient less than 2 grams per day. And the patient with active flare, you can use a standard or high dose. Even maybe the high dose, there is some evidence maybe favors over standard dose. And the higher dose, maybe if you keep them in high dose for a longer time, there is some recent data, maybe there is the risk of flares are lower. But don't use a low dose or less than 2 grams per day in a maintenance. If the patient has extensive disease, if the patient is in an oral therapy, you can add rectal therapy. And those who have left-sided colitis like proctus sigmoiditis or proctitis, then topical therapy may be better than oral therapy. And please try to use once daily mesalamine versus 3 times daily mesalamine. I've seen a lot of patients on 3 times daily mesalamine. There is no improvement, no superiority of 3 times daily over once daily, but compliance-wise, data have shown that compliance once daily better than 3 times daily. So the patient can take, I know like for example, like one of the mesalamines are big tablets. If the patient can take them together, then that will improve the compliance. And there is no need to keep them in 3 times daily mesalamine. Then with sulfasalazine, it can be used as a 5. لا ما أذن بعد.
Apologize for this inconvenience, guys. Sorry, Dr. Shahab, for this. Just wait for a while until we have the maybe projector back. It's already, you have it here. I think it should be few, so it might just take a few seconds. It seems to be like a power kind of related issue.
I have the slides, but I don't have them in the projector.
If you have the slides, if
can
you are fine,
continue?
Dr.
Okay, no
have to
problem.
continue until we have
Anyway,
the projector back. We apologize for
sorry,
this. Yeah.
No problem. And there are some slides from my older presentation I'm going to skip just for the sake of time. So sulfasalazine also as a 5-ASA used to be, like, can be used for external manifestation on UC, but we don't commonly use it nowadays. I don't actually use it nowadays because we have a safer agent because of drug-drug interaction with the sulfa group. So moving on. So immunomodulator there is a figure here anyway. So with azathioprine TDM, I just want to make sure the patient is not improving and you can do a 6 TG level and 6 MMP level, then please do so. If you have a patient with the low 6 TG level and the ratio between 6 MMP over 6 TG is less than 30, usually you need to increase the dose of azathioprine. Wherever if you have a low dose of 6 MMP with the ratio between 6 MMP over 6 TG more than 30, then this is maybe because of the, unfortunately I cannot show you the figure because 6 TG is the active metabolite and 6 MMP is an inactive metabolite. So if the ratio below 30, above 30, 6 MMP is high and 6 TG low, maybe only the active metabolite is working. So you can block this pathway by adding allopurinol, but you have to be very careful in this situation because the drug-drug interaction between azathioprine and allopurinol. If you add allopurinol, you have carefully check the 6 MMP level and 6 TG level, and also check the CBC liver function test and so on. I have the slides back. So as I mentioned, 6 TG level is the active metabolite, 6 MMP level. This is commonly happen as indirectly, like I have a patient with the UC and azathioprine and went to a rheumatologist who prescribed them allopurinol for gout and came into the emergency department with pancytopenia. So this is sometimes happening like without we want it because of drug-drug interaction. 6 TG level are associated like bone marrow toxicity with azathioprine associated with 6 TG level usually more than 500, and hepatitis associated with 6 MMP level more than 5,700. If you don't have 6 TG or 6 MMP level, studies have shown that MCV to WBC ratio more than 12 is associated with a good response. Why these numbers are important? Because sometimes you get consulted, for example, by general surgeon, patient is azathioprine and they have gallstones and admitted with pancreatitis. So is the pancreatitis secondary to is it biliary or because of azathioprine? So if you do the levels and 6 TG levels are not high and it's normal or low, then the pancreatitis is unlikely gallstones or gallbladder, or sorry, from the azathioprine. The same thing for hepatitis. If the patient has liver enzymes elevated and the 6 MMP levels is not high, then the hepatitis is likely unrelated to the 6 MMP levels. Pancreatitis, we know, is also like one of the side effects of azathioprine. If the patient develops pancreatitis, don't try to re-challenge, try to look for any other agent. Lymphoma, I think Dr. Iman already talked about, there is increased risk of lymphoma with azathioprine. So try, like, not avoid it if you can, or use it for short-term period with the young patient or elderly patient, or those for EVV, AGM negative. So anti-TNF, so anti-TNF when the patient have lost or not responding. So we'll talk about patients that have reactive TDM. Patient means not responding on anti-TNF. So what do? So you check levels on antibodies. If the patient levels are normal, but they have antibodies, so better to switch outside the class, but maybe add immunomodulators. If the levels are normal but no antibodies, then maybe this is mechanistic failure, so switch outside the class. If the levels are low and there is no antibodies, so you have low levels, so this is mainly non-pharmacological failure, so you increase the dose by increasing the interval or the dose itself. However, the levels are low and antibodies are high, then you switch within class with adding of immunosuppressant therapy. So the question here, this is the debate about proactive versus reactive TDM. I'm not going to go into this details. We know there is a lot of now evidence that maybe we should do proactive TDM, or we keep the proactive TDM for now, like maybe the standard is reactive TDM, but there are certain situations where proactive TDM is useful. So basically, if you have patients who have high clearance or low drug level state, then this patient needs proactive TDM. So there is a demographic factor. So males are more likely to have high clearance. Patients with obese patients are more likely to have low levels of high clearance. I have a patient with BMI of 45, fistulizing Crohn's on infliximab. maybe the highest infliximab doses I have given, and my colleagues were worried about the dose of those patients, and he keep having low levels, so you need a very high level to reach a therapeutic dose, especially with some phenotypes. So immunomodulator use, if you're giving, for example, infliximab monotherapy, if you decide not going to give combo therapy, so it's wise to do proactive TDM. Or if you de-escalate patient being on combo therapy for 1 year, for example, and you want to stop the immunomodulator, then it's also a good idea to do a TDM before stopping, just to make sure there is no antibody building up and you have a good level before holding the immunomodulator. And there is some genetic risk factor. We know HLA-DQ-A105 is associated with antibodies to anti-TNF and some severe disease. So patients have fistulizing Crohn's. For example, in infliximab, we aim for levels above 5, but in fistulizing Crohn's, maybe you aim high up above 15 or maybe above 20 even. And if the patient have high inflammatory burden, severe inflammation, ileocolonic disease, multiple segment, the patient have low albumin, high CRP, low high fecal calcium, you anticipate those have high clearance, so maybe you go with high proactive TDM and high levels. So if you do proactive TDM, same thing, if the patient does not have antibodies and the drug levels are low, then you increase the dose or frequency. If the normal levels, then you check again in 6 months. If they have high level, you can reduce the dose. If they do have antibodies, if the levels of antibodies are low, then you can overcome it by increasing the dose. But if the level of antibodies are high, then change to different anti-TNF or maybe outside class. So some practical tips. The one that the TDM for anti-TNF that we use in Kuwait is ELISA, and worldwide, the good thing about ELISA, it's cheap, widely used, available, and easy to use. The disadvantage, it is drug-sensitive assay, which means it's unable to detect antibodies in the presence of a drug. So if you have high drugs or normal drugs, sometimes you're going to get false negative antibodies with ELISA. The better test to use, the homogeneous mobility shift assay. Unfortunately, we don't have it in our country. I'm not sure if you have it in Saudi. Usually, it's a very good test because it's drug tolerant, can accommodate, even if you have high levels, you will have less false negative antibodies. The problem with it is expensive and not widely available, maybe available in some research center and tertiary care. The next is when to draw the blood levels for anti-TNF. So in infliximab, it's better to draw it before the next dose, usually the first, like the last 24 hours, because in infliximab, we know it's the one we have, like IV. I know the sub-Q is coming, not sure if you have it in Saudi yet, but for the IV now, because of the waxing, weaning, and up and down the levels, it's better to check it in the last 24 hours, also better for antibody detection. But for adalimumab, because it's the intervals every 2 weeks and maybe in every week, and because it's sub-Q, more a steady state, you can do the TDM at any time. So what about non-anti-TNF antigenicity? So immunogenicity to ustekinumab and vedolizumab is low. We know that from clinical trials, but also there is an exposure relationship between Vedo and ustekinumab has been demonstrated. So if you go high with the patient on ustekinumab every 8 or maybe 12 weeks and the patient is not improving, so it's wise to increase the dose, escalate therapy in both medication before switching to another medication. Do we need to add immunomodulator for non-anti-TNF biologics? We don't, because with low immunogenicity, you don't need to add an immunomodulator for the immunogenicity part, but maybe for some phenotypes, the patient have fistulizing Crohn's, maybe adding an immunomodulator in this scenarios maybe can help. So now your patient is adherence to therapy. You checked objectively, the patient is not improving, the objective-wise. You optimize therapy, but the patient is still not improving, and then you choose. So which drug, what to do next? So it all depends on many factors. As Dr. Badr mentioned, there is unique patient profile. The best biologic is your best biologic. The first one is best one. So you have to make sure which biologics to use. This is a real-world sequencing. This is a very large cohort in the USA talking about how was sequenced biologic. And you can see still steroid, unfortunately, is being used more oftenly and maybe more than 10 times. And 5-ASA still being used in Crohn's disease, even though we know it does not work in Crohn's disease, mainly because it's cheap and it's oral therapy. I'm not going to go into these details, sorry. So this is also, Dr. Badr showed you this safety pyramids. This is based on indirect evidence, network meta-analysis, that immunomodulators, especially like combo therapy, is maybe causing more infections risk, and the safest maybe Vedo and IL-23 inhibitors. Steroid is the worst all medication. However, if your patient have active inflammation, is the worst cause of infection. So don't keep patient with active inflammation without a treatment, or not giving them anti-VNF because you're worried about infection. Because having an active inflammation is the worst, or maybe the worst reason to have an infection, okay? So keeping patient with active inflammation is not a good idea, even if you need to treat with the anti-TNF or JAK inhibitor, then do so. I'm not gonna go again into detail, so this is the patient, what is the best therapy? It depends on the phenotype and depends on the profile. In ulcerative colitis, maybe in acute severe, we start with, if the patient failed steroid, with infliximab or cyclosporin. The patient failed, maybe we have some cohort studies now, maybe JAK will be the next step, still didn't make it to the guidelines. Moderate to severe, all other options, Dr. Badr also mentioned that. In Crohn's disease, if your patient has fistulizing disease, still anti-TNF is the first option, maybe infliximab. We don't have now any head-to-head to compare what's the second one, but there's many options. You can use ustekinumab or zinzimab, or OPA also have shown some efficacy. Special population, so in pregnancy, biologics are shown so far to be safe in the pregnancy. Avoiding small molecules and JAK inhibitors, still data is not, we don't have a good data on those, and also methotrexate should be avoided. And cancer, already Dr. Iman talked about it. In elderly population, maybe use ustekinumab and vedolizumab, but still, if you think your patient needs an anti-TNF, it's not a big no, it's not a counter-indication. You can still use an anti-TNF in the elderly. There is real-world data suggests its safety in there, but we have to be careful in those situations. External manifestation, peripheral arthritis, type 1, usually you're treating the disease itself, treating the IBD itself, whatever biotic will heal it. Type 2, sometimes you need to add maybe anti-TNF or JAK inhibitors. Axial arthritis, pyoderma, uveitis, also like anti-TNF or maybe JAK inhibitors effective. Ustekinumab, vedolizumab, there is some evidence, but maybe smaller case series. We don't have a good evidence for those. This is like an advance of how every mechanism of action, like anti-TNF, we know fast.
Dr. Shihab,
best with immunomodulator.
we apologize, time.
Yeah.
Just focus
So
play your
one
time.
more slide and I'm done. Sorry for this. So surgery is not a last option. Just I want to mention this. Don't leave your patient too late for surgery, because those patients will have complication and then will have bad outcomes. And UC and Crohn's, if your patient is not improving with therapy, patient have multiple medical therapy in UC, or they have a high-grade dysplasia in UC, indefinite invisible dysplasia, or cancer, or in CD, not the last option in CD. Now we have even evidence, and before using biologic, maybe surgery, the PREDICT study, and also in the LYRIC trial, maybe is a better option as a first-line therapy in limited areal disease than medical therapy. So don't leave surgery as a last option. Is an option whenever you think your patient needs it. So the take-home message: treat IBD flare, check the adherence and optimize therapy, choose the right drug. The first drug is usually the best drug, then you keep losing efficacy. So you have to be aware of the efficacy and side effects. Keep the surgery in mind. Don't keep the patient on steroid a long time. If your patient taking steroid for multiple courses, maybe there is something wrong. Is it the patient, the IBD is active, or their management is not good? And then the last thing, please don't use mesalamine in Crohn's disease. It doesn't work. And with this, I conclude my talk. Thank you.
Thanks a lot, Dr. Shihab, for this nice talk. We apologize for the technical issue. We apologize to the audience and to the speakers for not having time for questions. We'd invite the audience to talk to and ask their questions to the individual speakers in private, like after the finish of this session. It's just for sake of time for the Friday prayer. So there is a Jama' here inside the hotel campus. So hopefully, inshallah, we'll have time to pray Friday on time. I would invite everyone to be here back sharp at 2 o'clock exactly. We'll start this Talat Symposium that will be presented by Dr. Shakir Bakari, inshallah. So thank you, everyone. And this is the time to conclude our session. I would like to thank my co-chairperson as well for this organization. Thank you.
Saudi Digestive Disease Forum 2023. We will start our afternoon session with a satellite symposium sponsored by the industry. This symposium is sponsored by Janssen. I would like to thank them for inviting me to chair this session. The session title is Revolution in the Management of Ulcerative Colitis. Our speaker this afternoon is Dr. Shakir Bakari, who is a consultant gastroenterologist at King Saud Medical City in Riyadh, Saudi Arabia. Dr. Shakir Bakkari qualified in medicine from King Saud University in Riyadh, went on to pursue residency in internal medicine at King Faisal Research Hospital, Specialist Hospital and Research Center in Riyadh. This was followed by a fellowship in gastroenterology under the Saudi Commission. He went on to pursue a year of training in inflammatory bowel disease at the University of Alberta under the supervision of the late Richard Fedorak, and then completed a year of advanced endoscopic training at the University of Ottawa. And since then he returned to Saudi Arabia, where he has a large practice, large gastroenterology practice with focus on inflammatory bowel disease. He leads multiple initiatives under the Ministry of Health and has been a very important contributor to the efforts to manage patients with IBD, including being a co-author of the recently published Saudi Gastroenterology Association Guidelines in the Management of Inflammatory Bowel Disease. So we look forward to this talk. Thank you so much, Dr. Shakir, for accepting the invitation, and the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. Thanks to Dr. Turki for a nice introduction. Thanks, Johnson, for inviting me for this satellite symposium. So our talk today will be treatment options for ulcerative colitis, which option for which patient. This is my disclosure. And we'll start my talk by putting a new proposal, a new EC activity index published by ACG in 2020. So they look for stool frequency, blood in the stool, urgency, hemoglobin, ESR, CRP, and fecal cal into endoscopy, and they add also the endoscopy subscore, and they add UC endoscopy index of severity. So our target today will talk about moderate to severe ulcerative colitis that require biological therapy. This is AGA guidelines, which are addressing how to treat or how to put the biological therapy in moderate to severe ulcerative colitis. So AGA suggests early use of biologic in patients with a moderate to severe ulcerative colitis that require biologic, other than gradual step-up approach after failure of 5-ASA. So if you split it in bio-naive and bio-exposed, so bio-naive patient, the both infliximab can be used, vedolizumab can be used, ustekinumab, there is no comment about ustekinumab to use it in biological naive. TOFA, they added, again, they didn't put it as an advice for bio-naive patients. In bio-exposed, they can use ustekinumab, preferred over adalimumab, over vedolizumab. Tofacitinib can preferred also over adalimumab or vedolizumab. This is AGA guidelines. So if you look for the ECO guidelines, which published in 2022, so the ECO guidelines, they recommend to use anti-TNF in patients who's moderate to severe ulcerative colitis that have inadequate response or intolerance to conventional therapy. Also, they advise or they recommend to use vedolizumab for those kind of patients who's moderate to severe that require biologic and intolerance to conventional therapy or inadequate response. They recommend as well TOFA can be used as a first line. So ECO guidelines, they advise TOFA can be used as a first line therapy for moderate to severe ulcerative colitis who inadequate response or intolerant to the conventional therapy. And advise also ustekinumab can be used. So they put all biologic in front of you, and they ask you to choose between this medication, which is a bit probably, I don't know, we are not all practicing GI is epidemiologist, not all practicing GI, they have a lot of experience for this medication. So still we have lack of advice I could consider. So regarding choosing biologic, which use which biologic can be used for which patient. This is a landscape in IBD. So far, we have a medication for colitis. So starting from 1999 until now, so 1999 we know the infliximab, then followed by adalimumab, golimumab, and filtuzumab, tofacitinib, and then ustekinumab. So in 2021, I saw a lot of evolution in medications. So in 21, we start to have a lot of medications, and you have. If you have a lot of medication, then you will have difficult to choose between those medications. So in 21, we have filgotinib, ozanimod. In 2022, actually, we have obadicitinib. In 2023, we have risankizumab and etrasimod. In 24, probably we'll have golzikimab. It's not mentioned here, risankizumab was, as actually in 2023, is approved risankizumab. And then probably we'll have 26 biosimilar for vedolizumab. So a lot of medication that probably will have difficult to choose between those medications. So we'll try to go through this medication and we'll see which medication work for which patient. This is just medication that approved for so far and licensed for UC ulcerative. This paper was published by our friend Turki Lamil and Dr. Abdullah Mutardi and Dr. Badr al-Bawardi. So just published a nice review and I advise you to read it. So the licensed medication so far, vedolizumab, ustekinumab, tofa, filgotinib, obadicitinib, ozanimod, infliximab, adalimumab, and golimumab. And in late 23, in October, sorry, risankizumab was approved by FDA for ulcerative colitis. So the principle of choosing medications is all biologic are the most effective in bio-naive patients. You should anticipate which biologic you will be used after starting the first biologic. You should have evaluate data for primary endpoint comparing the efficacy in bio-naive versus bio-exposed. Not to forget the safety profile of medication, and as well as not to forget EIMs, which is important role, play a role in choosing medication, mainly biologic. We'll start with anti-TNF in ulcerative colitis. There is no head-to-head trial studies supporting efficacy of anti-TNF in ulcerative colitis. However, we know from multiple trials, we know it is ACT-1, ACT-2, Ultra, PURSUIT trials that anti-TNF is good for clinical remission and clinical response with a significant p-value if compared to the placebo. We know a long time ago that adding immunomodulator agents to anti-TNF, it will help the efficacy of biological anti-TNF. So this is from the UC success that adding immunomodulator agent, it will help for mucosal healing and steroid for remission by almost with a significant p-value. We know that using anti-TNF in early patients that refractory to steroid, it will prevent the colectomy rate by almost 46% at 2 years. But the problem with anti-TNF, there is high rate of non-response. So either primary or secondary loss of response. So if you look for the data, the primary non-response in anti-TNF almost about reaching 30 to 40%, with the secondary off-load response is about almost the 40 to 50%. So it's a good medication, but there is high rate of losing a response or primary non-response on this medication. This is a trial this is a systemic review from SINC published in 2018, looking for the patient who's primary response to the anti-TNF. So if patient from the trials, a patient he's not responding as a primary, then you will have a low chance to respond to the second biologic, regardless of biologic. So if this is lower response rate, if you compare it in patient with a primary response, if you compare it to the patient who loses response. So patient who's primary responder, they will have less response comparing to the patient who's intolerant to the biologic. regardless of what kind of biologic you use. So now we'll come to the vedolizumab. Vedolizumab is a good option to be used as a first-line therapy. So this is from the Gemini studies. The vedolizumab efficacy outcome is at week 6. If you split it to the bio-exposed and bio-naive patient, so bio-naive, if you look for the delta between the placebo and the drug, so the anti-naive or biological naive, so the delta is significant with the 24 in the mucosal healing, 26 in the clinical response, and clinical remission at 16.5. If you look for the anti-TNF failure, then the delta is is diminished or slow. So the delta is about 9.6, 9.9 in mucosal healing, 18.4 in mucosal in clinical response. Clinical remission is about only 6.6. So the FIDO, it may help good, it may work good in patients with bio-naive. Sorry. This is from the study from the Blisterer in 2021. They analyzed the difference between the infliximab using as a first line or second line therapy. So you have patients if they look for the patient who's using vedolizumab, and then after that they use anti-TNF, or they use anti-TNF as a first line. So the follow-up cumulative rate of treatment persistent and clinical effectiveness at 3 and 6 months, there is no difference. So infliximab can be used as a first line or second line after FIDO. But FIDO, it will work better if you use it as a first line therapy. So FIDO position, effective and safe in ulcerative colitis, less effective in biofailure, no benefit in patients with EIMs, can be used preferable in outpatient with a moderate ulcerative colitis who's in biological naive. Anti-TNF is effective if used as second line after FIDO. Safety profile is excellent in FIDO. What about ustekinumab? So ustekinumab, this is from a trial from the Unified trials. Look for ustekinumab at week 44 and the primary endpoint was clinical remission at week 44. So it's almost 58% compared to the placebo with a significant p-value. The Unified trials was the first trial addressing the histoendoscopic mucosal improvements. So meaning that endoscopic improvement by Mayo score or subscore of 0 to 1 with histological improvement in neutrophils infiltration less than 5 of the crypts, and there is no crypt distortion, and there is no ulceration granulation, and they looked for histological endoscopic mucosal improvement. They address it in Unified trials, which is so both endoscopic and healing and endoscopic healing, both healing and histological healing achieved by Stelara, which is ustekinumab, with either use 130 milligram or 6 milligram per kg. If you look for the long-term efficacy, this is a maintenance trial. This is as long-term extension. So there is clear benefit of ustekinumab in inducing endoscopic improvement and histoendoscopic mucosal healing by almost 46% with a significant p-value in all parameters, either histological improvement or endoscopic improvement or mucosal healing. This is a 4 years data for ustekinumab from Unified trials, which is meaning that it's addressing the point of sustainability. So patients who respond well to the ustekinumab will stay up to 4 years by almost within clinical remission or symptomatic remission and steroid-free remission. This is again, we know from the trials that I discussed about prominent responder, which is correlated with the HLA DQ1. So this is from Unity and Unified trials addressing that regardless of the presence of the gene or absence of gene, there is the effect of the ustekinumab stay there regardless of presence or absence of gene. So it was not significantly affected by presence of gene. And probably because of this, because of number one, not affected by the gene, number two, there is a low percentage of developing antibody or immunogenicity. So up to 4 years, up to 5 years in Unity long-term extension, the response or long-term efficacy of this is up to the presence of immunogenicity in patients with ustekinumab using ustekinumab is only 5.8. So if you try to split it now to either exposed or naive patient anti-TNF, so there is no big difference in bio-exposed and bio-exposed or bio-naive patient in regard of three and the primary endpoints, either clinical response or endoscopic improvement or clinical remission. So either bio-failure or bio-naive or bio-failure, there's no much difference in using ustekinumab. And this is safety data up to 4 years. There was no safety signals were observed with the Stelara. So the positioning of Stelara, effective and safe in ulcerative colitis, effect in both bio-naive and bio-exposed or failure patient, can be used as in the first and second line therapy. It's useful in patients with the psoriasis, so it's particularly useful in psoriasis, and safety profile, it has long safety or there is no high signals. What about tofacitinib? Tofacitinib was not shown to be reduced efficacy in anti-TNF exposed patients. This is result from the OCTAVE 1 and OCTAVE 2. We saw clearly that either anti-TNF exposed or anti-TNF naive, the mucosal healing and clinical remission has significant delta difference between the placebo and the drug. Tofa is a rapid onset effect in patient with anti-TNF refractory and has effective in patient with arthritis. It works well in patients with AIMs. However, increased risk of herpes zoster has major adverse effect regarding of cardiovascular events, and there is a chance of, I will mention it in the coming slides about non-melanoma skin cancer. Tofa is showing there is a clear benefit or effective in patients with acute severe ulcerative colitis. So patient admitted as acute severe UC, this is a retrospective case control for looking for effectiveness of tofacitinib in bio-experienced patients admitted as acute severe ulcerative colitis. The use in 10 milligram TID, and it was showing a benefit in patients with acute severe ulcerative colitis. There is a risk of non-melanoma skin cancer in ulcerative colitis using tofacitinib. However, the risk is low, and the risk factors were increasing age, prior history of non-melanoma skin cancer, and prior TNF failure. So if you look for here, another in rheumatoid arthritis data, 50 years of all order, at least one additional cardiovasculars, the risk of JAK to have major adverse cardiovascular events about 3.4%. If you look for the combined tofa dose is 10 milligram or 5 milligram. What about obasitinib from the UACHIEVE trials? It's the clinical remission at 52 weeks in bio-exposed or bio-naive were good, reaching about 50%. So obasitinib was not affected by using anti-TNF before or bio-exposed before. So positioning of JAK, it can be used in severe inflammation. Rapid onset of action. It can be used in younger patient if you have patient with a few comorbidities, no cardiovascular disease, cancer, or thromboembolic events, non-smoker patient, if you have patient with a biological experience, prior anti-drug antibodies can be used, or good drug for patient who has arthralgia or EIMs and willing to take shingles or test for TB. Against use JAK in patient who has mild inflammation, older patient, prior malignancy, former or current smoker, bio-naive. This is in US and Europe. Can be used as a first line, and our Saudi guidelines, it can be used as a failure of a biologic. Prior history of thromboembolic events, and unwilling to take shingles or test for TB. Ozanimod as well, which is 1B1 modulator, it can be effectiveness in moderate to severe aspergillitis, and this is a 10-week data on the patient who has bioexposed. And actually there is, if we look for the clinical remission, the lower rate of remission seen in patient who is exposed to 2 biologic. So if a patient is exposed to 2 biologic, the delta is only 1.3, and patient who has exposed to first biologic, the delta is about 11.2. So probably this is a signal that it's ozanimod, it works well in patient who's bio-naive. There is a safety concern in ozanimod. There is patient who has a cardiovascular disease or type 1 or type 2 AFib block. It can cause asymptomatic bradycardia, and major adverse events can be seen in like hepatotoxicity or AFib block and macular edema. And one of the things you should do it pre-using ozanimod is ECG, endoscopic exam, and vaccination for varicella zoster, and contraception recommended while taking a 3-month taking a dose and 3-month post-dosing. So position of ozanimod, effective in aspergillitis, induce less effective if TNF experience. It's used in moderate to severe, a moderate patient, aspergillitis, bio-naive, as we said. Avoid in patient with cardiac conduction abnormalities. Caution in heart block and arrhythmia and macular edema. So this is tool can be used, which is clinical decision, clinical options, care options. It's a tool from the experts. Advice, give you a guide that how you choose medication in patients with moderate to severe. This is supervised or recommended, the recommendation based on 5 experts in IBD. I think all IBDologists know those IBDologists, Dr. Afzali, Dr. Adam Raymond, Millie Long, and David Schwartz. So if you look for if you go to the tool and you choose your patient, either bio-naive or bio-exposed, disease activity moderate to severe, and then comorbidities, if you have comorbidities, patient he has comorbidities or no, and excellent system manifestation, and safety always concern. So patient level of concern of safety, and you click this and it will help you to choose which drug best for your patient. Recommendation from those panels in bio-naive, so 5 experts in moderate to severe patient, in moderate to severe ulcerative colitis patient who is bio-naive, either use Fido or ustekinumab. Expert 2 advice for Fido or ustekinumab. Almost all agree on Fido or ustekinumab. So more severe, you can use infliximab with the proactive TDM and modulator agents. Most experts advise infliximab with TDM. Recommendation from TNF primary non-responder. The advice, if you look for most of the recommend ustekinumab or tofacitinib. We mentioned that vedolizumab is work less in patient who's bio-exposed. So either in patient who's not responding or primary non-responder, you can choose between ustekinumab, tofacitinib. This again, if he has comorbidities and no advanced age, you can choose between the two, ustekinumab or tofacitinib. Recommended, again, this is again in patient with a more severe ulcerative colitis. Patient who's primary responder, as we explain or we showed clearly that tofacitinib, it may work well in patient who has a moderate or severe colitis that not responder to the, or primarily not respond to the anti-TNF. If you have patient with arthropathies or rheumatoid arthritis, tofacitinib is the way to go, or a patient, it will respond well to tofacitinib. If you have patient with a psoriasis, ustekinumab, you can be one of the options you can use. So this is meta-analysis and network meta-analysis and systemic review. Look which agent considered to next after TNF expose. And from network meta-analysis and systemic review, the higher ranking were for ustekinumab and tofacitinib. So the position of therapy in moderate to severe by subpopulation, by subgroup. If you have patient with older age more than 65, preferred treatment, you can use vedolizumab or ustekinumab. In patient with if you have inpatient, either infliximab as induction and maintenance, or cyclosporine followed by vedolizumab or azathioprine as maintenance. If you have patient with a low albumin, you may go with the cyclosporine, or tofacitinib can be a good option. If you have patient with a significant cancer history or lymphoma, vedolizumab or ustekinumab could be a good option. Pregnancy, I think all medication safe in pregnancy, except we don't know about JAKs, so and S1P1 modulator, so we don't have data on it, but other medication, biologic, are safe during pregnancy. Extra-stem station, you have patient with psoriasis, you can use ustekinumab. If you have patient with arthritis, you can use TNF inhibitor or tofacitinib. If you have patient with a previous TNF inhibitor failure, choose between tofacitinib and ustekinumab. Thank you. I think that my questions.
اقرب لك بسارة هذا ولا اللي ورا الكاميرا؟
So I've been advocating, or at least in my mind, thinking about the use of TOFA in the setting of acute severe ulcerative colitis, and you've just shown us one publication on that. I think it was retrospective, right? So where do you position now, or how comfortable you feel now to start a patient with acute severe ulcerative colitis who is, this is his first presentation, for example? Would you consider JAK or no? Not at all. Still keep it as a second line.
As second. Okay. So we heard, tofacitinib is in the market for a long time. I think there is a black warning about using tofacitinib. And the data came from rheumatoid arthritis patients who's elderly, and they have side effect of medication like major adverse cardiovascular events. I think I have used a lot of now, I start using a lot of TOFA in patients, younger patients, moderate patients. I never use it in severe colitis, but I think it will be as a second biologic after anti-TNF. So if you have patient acute severe UC, I will use anti-TNF. I will use anti-TNF first. A patient already failed or primary failure of anti-TNF, the second option now will be TOFA. So it will be the second of my option.
Yeah, So I think just because the room, I think the audience is mixed and we have trainees, the standard of care remains IV steroids for acute severe UC and then rescue therapy with infliximab or cyclosporine. And if the patient responds to IV steroids, you can go to other advanced agents, including ustekinumab or JAK inhibitors. Now, what is your approach to using ustekinumab in bio-naive patients? Do you combine it with an immunomodulator or do you use it as monotherapy?
I use it as a monotherapy. I don't know, I don't have data supporting adding immunomodulator agent. So all my patients, I use it as a monotherapy. And now we use it, I use it a lot. I keep infliximab, my approach is not, I keep infliximab for patient fistulizing Crohn's disease. So I use ustekinumab more in bio-naive patients.
So I think the point is worth mentioning. They are less immunogenic. These agents are less immunogenic than anti-TNF agents. Now, I had a patient with ulcerative colitis who failed conventional therapy and was started on ustekinumab. She was bio-naive and started on ustekinumab in late 2019, shortly after the publication of the Unify. Did very well for several years, and then her fecal cal went up. We scoped her. She had Mayo 2 disease. So we escalated the therapy to Q4 weekly, and the mucosa healed. Is this common? Do you see this approach being effective in patients who either develop clinical symptoms or increase in their biomarkers on the Q8 weekly dose?
I think still the guidelines recommended every 8 weeks, but in the practice we use it. To be honest, I have a good number of patients they escalated to 4 weeks, and I achieve the mucosal healing after that. So it's one of the options can be used, but still the guidelines is, the recommended dose and the frequency is 90 milligram every 8 weeks. But based on the clinical practice, you can escalate it up to 4 weeks, and it should be effective.
Prof. Gary.
Yes? Just a question now. In moderate to severe ulcerative colitis, I see the recommendations, everybody is pushing towards anti-TNF. Now, in view of these new medications and classes with less formation of antibodies, safety profile, why do we insist in giving anti-TNF all the time with UC? What about using these as a first-line therapy? Now, you've shown us that ustekinumab and JAK inhibitors would not be that much affected if you start the patient with anti-TNF and they fail, and then you put them on them. So the difference is not all that much difference, but with Vido, you'd rather start it as a first line because that would be where you get your better results. But why still always anti-TNFs comes first? If we have such a good results, why not to consider ustekinumab as a first line, for example, in moderate to severe? I know the options are there, but would you do that, or would you still, everybody, you would give them anti-TNF first?
I think the choosing of anti-TNF, it came by default. I mean, most of GI, gastroenterologists, the most drugs in the market now, the long medication in the market is anti-TNF. So are we familiar with it? Most of the people, they know how to use it, easy to use, induction and maintenance. I think this is in the back of the brain of the most gastroenterologists to use anti-TNF as a first-line therapy. But I agree with you, Prof. Gary, that we have a lot of medication now, safe medication, safety medication in long term, efficacy in long term, low immunogenicity in long term. So I think I will keep infliximab for my patients that require infliximab, like patients with arthropathies, like the patient with the vistulizing. So I will keep this patient in those subpopulation patients. But I will move to using the drug that's showing effectiveness in long term and low side effect.
And not only that, but you mentioned that the primary failure, the primary non-responders percentage is not that low, about 30%, and say at 1 year, secondary loss of response is about 60% or so. So you almost can foresee that when you follow these patients within a year or two, you're going to have to switch them over. This is what
totally agree with you. Yes,
and the onset of action as well with the JAKs is much quicker than
yes.
the other biologics.
Totally agree. I mean, we should think about. I mean, with this evolution in the pipeline on the medication, we should think not. And I'm not not saying that not to use infliximab, but keep it for some selected group of patients.
So I think I agree with Dr. Bakari. I think you make a very good point, and we don't have to go through anti-TNF agents. So when you take ustekinumab, for example, the data was very clear in the unified trial that patients who were bio-naive were included in the study and did very well on the medication. And the case I just mentioned was a patient who was bio-naive and did very well on ustekinumab. The second point I would like to make in this regard is that you're absolutely right. I don't think we should go through less effective agents before we go to these advanced therapies. So I'll give you an example. Adalimumab in ulcerative colitis, I think we all share the experience that it's not a very effective agent. When you look at the original studies, the ULTRA study, the delta was not effective, was not significant, the delta was not that huge, I should say. And with the availability of other subcutaneous agents like ustekinumab, there is probably little benefit. This being said, the fact of the matter is sometimes decisions are driven by the financial aspects, and with the introduction of biosimilars to anti-TNF in many jurisdictions and in many hospitals, like the center where I work, they demand that you go through anti-TNF before you start another advanced agent unless there is a contraindication, be it demyelinating disease or latent TB. So, but if the patient has good insurance, they have access, I think it's very reasonable to start with the advanced therapy. We have a question here. Tfadal, Doctor.
Thank you for excellent presentation. If you have a patient have decompensated cirrhosis, CLC, elderly about 70 years, and have moderate to severe ulcerative colitis, and naive, so what do you prefer to start with him?
So this is a very challenging probably aspect, and I'll just try to address it briefly. I would probably shy away from using small molecules, particularly JAK inhibitors. The safety in the elderly population is not that clear. Now, when it comes to monoclonal antibodies, the largest experiences with anti-TNF, vedolizumab is probably more gut selective, but there is no contraindication using ustekinumab with cirrhosis as far as I know. So I think these are the main options we think about.
Also in patients with renal disease?
Yeah, so again, with renal impairment, they're generally immunocompromised. Think about renal clearance. So JAK inhibitors usually are cleared through the kidneys, and most studies excluded patients with advanced chronic kidney disease. So great, I think we're out of time. Thank you so much, Dr. Shakir, and thank you, Jansen, for the great satellite symposium. We'll go straight ahead to the hepatology session. It's an absolute honor to invite the co-chairs of the session, Dr. Hadi Kariri, the consultant gastroenterologist at King Fahd Specialist Hospital in Dammam, in my center, and my dear friend, Dr. Karim Gomosani, who is the consultant gastroenterologist and an associate professor at Western University in Canada. He's the program director for hepatology transplantation and the program director for the adult gastroenterology fellowship. Thank you.
So welcome back to the third session, which is a hepatology session. So I'm delighted to present and introduce our first speaker, Prof. Khalid Swat. He is a well-known figure in hepatology, and he is a senior consultant. Professor Swat, he is a professor of medicine and consultant hepatology at King Saud University College of Medicine, and also he is the director of Liver Disease Research Center at the same institute. Professor Swat is well known to his contribution to a scientific field, and also he is a member in many global as well as national society. He is part of the Global NASH Council and also part of the Steatotic Liver Disease MENA Scientific Council. Again, it's my pleasure to present Professor Swat. Professor Swat, the floor is yours.
طيب السلام عليكم ورحمة الله. مساكم الله بالخير. Thanks for the scientific committee for inviting me, and thanks Mr. Chairman and co-chairman for this nice introduction. The topic is challenging to address fatty liver or muscle or the new names in 20 minutes, but it's a highlight of certain aspects of the disease because we cannot cover everything in this 20 minutes. So we will go with the first thing, probably the new thing for us is the change in the name, and we know over many years since the discovery or the description early 1940s of something described or known later on to be fatty liver disease. The name was first introduced as NASH in the early 80s, then NAFLD a couple of years later, and for 3 decades the name remained the same. It wasn't satisfactory name, it was a negative terminology, it does not describe the disease because it wasn't known at that time historically. They described something pathologically, they didn't know why there is some inflammation in the liver in those patients, and does not describe the mechanism, the pathophysiology. With evolution of understanding the disease, there was a demand to rename or describe it, and there was some efforts to change the name in the 2020s. Some group of experts describe it as metabolic associated dysfunction fatty liver disease. This name did not last for a long time because it described a significant portion of the disease, but did not describe everything because there is spectrum of the disease which is not metabolic associated. So that name is not that satisfactory. Yes, it is a positive name, positive terminology, not like the previous none, but in the same time does not describe everything. And there was a call. This is just if you want more history about this is the article we did it, not for the name, this for every aspect in fatty liver disease at that time prior to muscle. So there is a global effort from contribution from several countries to change the nomenclature and to define the disease to encompass and include a wide spectrum of the disease, and this effort included many experts from all over the world, and the name, or they describe it based on several criteria. I'll start with this criteria because it's one of the corners of the defining the disease, which is the cardiometabolic factors, which is mainly the metabolic factor known, the BMI, the fasting blood sugar, and the pressure, blood pressure, and the plasma triglyceride and cholesterol, and the same some criteria for pediatric, and the spectrum of the disease. No pointer. No, I'm trying to move. The spectrum of the disease is, this is, if you see in the left side, it is a metabolic dysfunction associated with steatotic liver disease, which is muscled. This is describing almost most of the patients we know under the umbrella of NAFLD. However, let's move to the right side and to the alcoholic part, which is the small square, which is well known. This alcohol is one of the causes of steatosis. In between, it has been known that the alcohol has effect, and sometimes, and this is one of the things which you should overcome the previous terminology, that some patients, they might have not significant alcohol threshold to label them as alcoholic. However, the disease, it can progress in a way more than the muscle. So the name of MET ALD came, and it describes several degree of alcohol intake. And then on the right side, the specific etiology. We know there are many etiologies of fatty liver disease, including drug-induced monogenic disease, like lysosomal acid lipase, Wilson, and others. And if none of these, then the name is cryptogenic SLD. So this is a decision support tool which is describing SLD. If you have a patient described to have fatty liver or steatotic liver disease, then move to assess for cardiometabolic risk factor. If they are there, check if there is any coexisting disease to name them. If none of them, then the muscle terminology is there. If you go to the other side, there is no cardiometabolic risk factor. Think if there is any reason for that, like alcohol, drug, other factors, or if none, then you can label them as cryptogenic SLD. So this is regarding the terminology. There are some, in brief, there are concerns about the impact of this on literature, on database, registry, clinical trial, etc. There are many letters and studies assessing that. Briefly, there is little impact, if any, on that, because most of the patients, in many studies, 98 to 99, almost muscled, fitting the NAFLD in previous terminology. And this have been published, endorsed by many organizations. So no more fatty liver, FLD, change to SLD, NAFLD to muffled, NASH to MASH, and MIT-ALD is a new, and other terminology. So this is regarding the disease in brief, in a short time nomenclature. Regarding the prevalence, you see focus on the MENA area. It's increasing. Every report in a couple of years or decade, it's increasing. The global prevalence of muscle is 30% or higher. In our region, it's one of the highest in the globe, which is 36%. The same for NASH. NASH prevalence is 5.2, and the MENA region, 5.8 or 6% of the patient. This is in general. So, and if you want to see in a specific group of population, this is a US study, assessed patient based on MRI. You see the different group of people, the prevalence is higher. Specifically for obese people, for diabetic patient, the prevalence of muscle is high, NASH is high, and to the right side, if a patient diabetic with obesity or more metabolic risk factor, 75% or more, they have muscle. The problem, not only that, the problem, how many of them they have NASH? It's very high percentage. So this is very alarming, and that's why those patients need to receive special attention when managing them. So we know the outcome of the disease. If you have muscle, this has been studied in this large cohort. After 15 years, 3% will develop compensated cirrhosis. And after 4 years, 30% of those patients will develop decompensation, first decompensation and second decompensation. So this is if you take it from the number of patients seen in a specific hospital or a clinic or a country, this will be a huge burden of a disease, and this have been studied in many countries, including our country. So this leads to a point that we have a huge pool of patients. Not all of them will develop the disease, but there are some will develop the disease. Who are those patients? How can we manage those patients? Because it's challenging. You cannot, there is no special test that, one test that you can define them. You cannot refer all patients to hepatology. Most of the frontliner to those patients are family physician and primary care. So who are at risk? This have been addressed by many studies, and there are many risk factors. NASH is one of the risk factors in the long-term outcome. The survival in NASH patient is less. The same for multiple metabolic risk factor, the one in the lower part. Probably, I hope if we have pointer, but anyway, multiple risk factor, the survival is the lowest. The same for fibrosis, the mortality is higher the more a patient develop fibrosis. So fibrosis is one of the most important predictors of disease progression. And it's associated with the overall outcome. The more the patient has fibrosis, the more mortality is increasing. The more liver-related mortality and the more cardiovascular event happening in those patients. And remember, those patients, the main reason for their death is more cardiac and cancer rather than liver-related. That's why you need to take care of those and address them when you are managing those patients. And most of the guidelines recommending screening at risk, especially diabetic or people with multiple metabolic risk factors. If you see the prevalence of advanced fibrosis in multiple studies in diabetic patient, so if you have 100 patients with diabetes, 6 to 19% of them, they have advanced fibrosis. If obese, a significant number of them, they have fibrosis. The same if patient has alcohol, that's why the point of alcohol and the terminology of MIT-ALD came. And the same, which is very interesting, that patients with relative of NASH cirrhosis, they are at higher risk of advanced fibrosis. And this is studied in multiple studies. So, if we have this problem, how to define those patients, and we identify some parameters of detecting the patient, how can we assess fibrosis or the disease progression in those patients? Of course, biopsy is the gold standard with its limitation. So it cannot be done in every patient. So the area of NET is a hot area of research, and there are hundreds of investigations and assessment of many parameters. But broadly, when you read them, you need to identify that not all of these identifying only fibrosis. Some of these studied, you need to be careful and to see what are the endpoints in these studies, some assessing at-risk NASH, some as well studied to assess the clinical outcome and the treatment response. So there are many, and the idea of this, just to show you this area, is one of the important areas to address when you are assessing patient and follow the non-invasive test. For example, one of the most important one, which is FIB4. FIB4 addressed and now endorsed by many guidelines as easy, available test in every clinic. So it's good to assess it. It has some limitation, but at least from a negative predictive value, when the level is below 1.3, it's good. It has good sensitivity, and the problem with it is the positive predictive value. And the other problem with it, the people in the gray zone who has between the 2.6 or 1.3 is 40% of the patient. So these are some limitations. As well, for older people, you have to be careful because with age, ALT level is dropping, and this depends on the ALT. So you cannot use 1.3. You need to use the cutoff less than 0.2 in people above the age of 65. So this FIB4, the advantage of it, it's available in every clinic. There are many multiple tests. We will go to the vibration control transit elastography, which is FibroScan, well studied, and as well in many guidelines. It is available now, but the problem is not in every primary care, so you need referral as well. So we have unmet need in that aspect. That's why there are many developed factor and algorithm developed. But before we go to algorithm, there are some other net to detect at-risk NASH, and example of these, the ones in the bottom, some adding some inflammatory marker or some scores like FAST score, MAST score, or MRI elastography FIB index, and there are many studies trying to improve the area under the curve and the sensitivity and specificity of the test by combining these tests to have the test. We know that MRI is good, whether it's MRI for steatosis or elastography, but the problem with MRI is the limitation, the cost, etc., not available, and the accessibility issue. This is the same for the outcome. There are multiple levels assessing different outcomes. So when you are assessing any paper, you need to read in between what that's meant. This is to show you the overall result. This is a litmus project. It's a European study cohort assessing many patients to evaluate 17 non-invasive tests, biomarker in detecting NASH and significant fibrosis. None of the single biomarkers reach the target area, threshold target, which is 0.8. Most of them below that. Some combination of these met proteomic based like Soma Signal and others, they met it, but the problem with this, as you know, it's not available everywhere. FibroScan, one of the tests which met that project. So there are multiple validation study, different cohort, different population assessing these non-invasive tests. Bottom line is still these tests has a good negative predictive value, variable positive predictive value, depends on the setting. If you are in a clinical setting, hospital-based or and sometimes accessibility, the cost, some of them are not easily available test. So that's why these algorithms, you will find them in multiple guidelines. Basically, you will find the similarity between these algorithms to stratify the risk in those patients. They are very useful in assessing people at risk, especially for primary care. This ASLD one, there are many similar ones. There is similarity. The similarity between them, there are multiple level, or most of them, two risk assessment level. The primary risk assessment level in most of them is FIB4, and if it is higher than the cutoff excluding those patients, then you go to the second level, which is and some are ELF score or fibroscan or MRI. And if patient is intermediate or high, refer the patient for evaluation. This is, you'll find them in all. The AGA new one, the only thing highlighted in this one, that if you see here, and for diabetic patient, if you have patient type 2 diabetes, or two or more multiple risk factor, one primary assessment is not enough for those patients. So if you exclude, for example, FIB4 in those patients less than 1.3, it's not satisfactory in diabetic or patient with multiple risk factor. So in that, you need another factor. This is good, in fact, the AGA1, to go for ELF, vibration or MRE. But the problem in practicality, because if you have diabetic in primary care, ELF score is not available in many institutions. And even the countries where it's available, it's costly, around $300. It's more than the fibroscan. Fibroscan is not available, but it's good maybe in hospital setting in those patients to evaluate them with the second level of assessment. This is how I was highlighted because diabetic patient or patient with multiple risk factors, they are at higher risk, so you don't want to miss them. So this is recommended to have another layer of assessment in those patients. So we'll move now. It's highlight from each area because you cannot cover everything. The management aspect here, managing patient, I think it should be multidisciplinary team. It's multiple aspects need to be addressed in those patients. Remember, the cause of death in those patients is heart. And if you are, the nice thing that if you are controlling one aspect, you are controlling the other. So you need to address every aspect in those patients, treat it, tackle the weight in obese people especially, and other factor, the diet and the lifestyle modification. Lifestyle intervention remain the gold standard, or let's say the main prescription to be given. This has been evaluated in multiple studies, and it's effective in many patients in meeting all the endpoints in the disease outcome. There are many, it's recommended by many guidelines regarding the diet, the exercise, and the weight loss intervention with variable recommendation, but more or less there are some similarities regarding the amount of weight needed. Hypocaloric diet or Mediterranean diet probably endorsed by many guidelines rather than any other diets. And the same for exercise, any exercise, but maybe aerobic better than others. This is in brief. Then we'll move to pharmacotherapy. This area is as well one of the active areas of research because the demand, this disease difficult. There are many medications tried in the past. They failed to reach solid endpoint in the disease. So in that aspect, there are multiple targets: metabolism, lipotoxicity, insulin resistance, anti-inflammatory, antifibrotic, or other extrahepatic. And at the same time, if you keep this in mind, keep in mind that maybe one agent is not enough, and maybe combination of agents or combination agent with combination mechanism may be effective, and that's why there are studies assessing monotherapy and some studies assessing more therapy targeting more than one area or more than one therapy have been in multiple registered trial. Most are in phase 1 or 2. Okay, practicality. Let's talk about how can we go over this patient. I think this is one of the nice slides. Most of you are aware of this AGA recommendations. The nice thing, it gives you some guide how to manage those patients if you stratify the risk to low, intermediate, or high risk. If they are low risk lifestyle, the same intervention. You don't need pharmacotherapy in low risk patients. Cardiovascular risk reduction, of course, and diabetes care in all of them. If you move to the intermediate risk, and let's take with them the high risk for the sake of time, the same, this prescription of lifestyle intervention is in all, but maybe in those patients you needed more emphasis on that, more structured program, more follow-up in those patients to assess the disease activity. Pharmacotherapy is indicated in those patients. Nice thing about that diabetic care in those patients, you think about bioglitazone or GLP-1 receptor antagonist or bioglitazone or GLP-1 as well. It may help as well. For diabetes, the ADA now, there is update on the guidelines. The AACE, the endocrine as well, they have update. If you want, you can refer, because most of the patients, and there are nice algorithm and guides in managing diabetic patients in these guidelines.
1 minute left.
1 minute? Only one? Okay. No zero behind, beside it? Okay. We'll try to finish. Okay, we are about to finish, but we'll go over the trials quickly because I know it's condensed to. Anyway, so for low risk lifestyle and control the other risk factor, intermediate risk lifestyle modification, and refer those patients, and you may start pharmacotherapy. Vitamin E, based on the medications recommended by the guidelines, it may have impact in diabetic and non-diabetic patients. The same for bioglitazone and other thiazolidine-glitazone. There are multiple studies and meta-analysis with some benefit in these patients. But keep in mind, the nice thing, if you have diabetic patient, try to ask endocrinologists and diabetologists to modify the regimen to meet to target both the fatty liver and diabetes, and there are many guidelines. There are many guidelines with some failing and some promising in the future, and there are some studies assessing the NASH and fibrosis, most of them in phase 2 with very good promises. We are hoping that the future will have this. I'm sure you are about this in the latest meeting. Resmetirom, which is a thyroid hormone receptor agonist, it works in multiple factors. Showed some improvement. By the way, these mysterious studies are ongoing studies with multiple arms, and there is improvement in the primary endpoint in NASH resolution, and as well in fibrosis improvement. The same for GLB. The GLB in cirrhosis in the recent study did not improve in the phase 2 trial published in Lancet recently, but hopefully in the phase 3 we will see better improvement. So in conclusion, no more NAFL terminology. SLD muscle are the recommended name. New names or nomenclature seems to solve several old limitations, several advantages. Muscle MASH are metabolic disease occurring with diabetes, obesity, and other metabolic syndrome factor. Patients at risk need to be identified and managed. So this very crucial points. And generally, patients at risk in routine practice can be identified using sequential NITs. And there are new metabolic target associated improvement in MASH with a new promising therapy in the horizon. Thank you very much.
Thank you, Professor Aswat. So I'll introduce our next speaker, Dr. Walid Al-Ghamdi. So Dr. Al-Ghamdi is a graduate of medical school at King Abdulaziz University in Jeddah. Then he did his internal medicine training in GI in Western University. Then he did adult advanced transplant hepatology at Western as well. He has the Canadian and the American Board of Internal Medicine, GI, and adult hepatology as well. He returned to King Abdulaziz University in 2020, and he's currently the director of the endoscopy unit, and he had a strong passion post-grad medical education. So without further ado, Dr. Al-Ghamdi, the floor is yours.
Assalamu alaikum jami'an. Thank you for the organizing committee for arranging this amazing gathering. Great lectures for the day. Thank you, Dr. Kumusani, for the nice introduction. And without further ado, we will start. So no conflict of interest pertinent to this presentation. This is an overview of the objectives I'm going to cover. So we're going to delve into pathophysiology diagnosis of AKI and cirrhotic patients, cover some diagnostic tools and treatment modalities, and then we will touch base at the end for future emerging research. I'll try to be as practical as possible for the 20 minutes given. Let's start with the pathophysiology of AKI and cirrhosis. So this is a slide showing the background of pathophysiologic mechanisms seen in AKI. We'll highlight first that the patient with cirrhosis would have low blood pressure due to excess nitric oxide generated by shear stress. And this is from the vascular endothelial cells leading to splanchnic vasodilatation, which leads to increased portal blood flow. This will further lead to more formation of ascites and hence associated bacterial translocation. And when we look into the connection between serum creatinine and GFR in cirrhotic patients, remember, in the setting of cirrhosis, I want to just, as seen here, serum creatinine level overestimates the GFR. And this is by around 10 to 20 milliliter per minute. In normal subjects, on the left side, the serum creatinine level, for example, of 1.5, which is actually a significant impaired renal function, may correlate with 55 to 60 ml per minute. While on the right side, in cirrhotic patients and ascites, the same creatinine level will correlate to likely close to 30 milliliter per minute GFR. Looking at the prevalence, again, it's very common to see acute kidney injury, especially in decompensated cirrhosis, around 50% of them, with significant high mortality, reaching 90% if we look at weeks, and if we look at 90 days, it reaches 50%. There are multiple causes of acute kidney injury, the most common being pre-renal, followed by acute tubular necrosis, followed by the least and the minority of the cases, which is HRS or hepatorenal syndrome, around 20 to 43% in this particular review. Moving on to, let's cover the intrinsic renal etiologies. Most of the etiologies for intrinsic renal diseases in these patients would include acute tubular necrosis, which is usually ischemic injury or toxic injury. Glomerulonephritis, which connects to infection, especially viral hepatitis in this population and characterized by RBC casts. Interstitial nephritis, which is caused by drugs or medications, characterized by urinary eosinophilia. Usually the urine sediments is abnormal in these patients and would have proteinuria or hematuria. You might need to confirm the diagnosis with a biopsy, but this is rare. When we talk about the conditions leading to AKI, this usually happens because of the vasodilatory status. Many things can lead to AKI in these patients, including vasodilators like beta blockers used for varices, large volume paracentesis without albumin, leading to decreased effective blood volume, excess lactulose leading to diarrhea, and also reduced effective blood volume, variceal bleeding, doing the same thing, NSAIDs, using prostaglandin effects will affect the renal perfusion, leading to renal dysfunction. In HRS, it is a functional renal impairment. So there is no structural etiology. There are as many functional disorders, criteria to be met before making this diagnosis, which is, by the way, overestimated in intensive care unit settings. You're going to need sinusoidal portal hypertension. These people have marked arterial vasodilatation and extrarenal circulation due to excess nitric oxide. In addition, there are inflammatory mediators leading or combined with bacterial translocation, generating pathogen-associated molecules or PAMPs, such as lipopolysaccharides. The damage associated with these PAMPs will contribute to the inflammatory response, leading to decrease the GFR and renal vasoconstriction, combined with splanchnic vasodilatation, which is going to eventually lead to arterial hypovolemia or hypoperfusion. And as I said, these changes happen in the absence of any structural abnormalities. Historically, I put this graph just to show you the 3-month survival probability of general population in transplant candidates. And you see type 1 and type 2, which is old nomenclature, HRS, how significantly they fall off the general population survival curve. Historically, type 1 HRS, which is now HRS-AKI, is more rapid progressive renal failure. Doubling of initial creatinine to a level of more than 2.5 usually happens, and it's in less than 2 weeks. Type 2 is now HRS-CKD or HRS-AKD based on the duration of the disease, and it's more steady or slowly progressive and typically associated with refractory ascites. Now, talking about stages, most of the time we follow the KDIGO criteria, and these are the 3 stages of acute kidney injury. And these are the diagnostic criteria for hepatorenal syndrome. So in order to diagnose this condition, which is usually diagnosis of exclusion, we need to meet the criteria mentioned by the previous slide of International Club of Ascites, followed by diagnosis of cirrhosis with ascites, followed by absence of shock, absence of nephrotoxic medication, and parenchymal or intrinsic renal injury. Add to that, no complete response when challenged with albumin. And the albumin challenge is defined by 1 gram per kg albumin IV given to a maximum dose of 100 per day, given over 48 hours. Usually, if the patients are hypotensive, if you see hypertension, question the diagnosis. Urine sodium is to the floor, so usually it's very low. Updated criteria, and looking back at what we just mentioned, and the complexity of liver disease, you might be actually in face with more than 1 renal etiology, or sorry, 1 acute kidney injury etiology combined together. Severity of the disease actually correlates with the prognosis. And when we look at stages of acute kidney injury, here you see the survival probability, and it's low throughout the stages of acute kidney injury, especially stage 3 at 31%. Hence why we are intervening early in order to prevent such deterioration and bad prognosis. Now, keep in mind, the closer you are to the baseline, the easier to handle this condition, and the easier or the sooner, or actually the easier the reversibility. When we cover management, treatment of choice is by default liver transplantation. So as soon as you can get people to the transplant list, if they are qualified, get them as soon as you can. This is a reminder of the liver package that we usually cover for these patients. So vibes, remember, volume, IV albumin challenge, as we mentioned, paracentesis, infections, cover the patient's antibiotics as, for SBP, cover them with prophylaxis, perform endoscopy to screen for varices, make sure that they get to TIPS if it's indicated, and within the window that they don't encounter encephalopathy, which is treated usually with lactulose, and again, try to expedite evaluation when needed. When we look at paracentesis, as we mentioned it now, if you follow the guidelines, you will be okay with albumin given post-paracentesis. In this study, they looked at the large volume paracentesis and actually the occurrence of AKI in this population. The rate of AKI generally was very low. It was like around 5%. It's even lower in people with large volume paracentesis, so it is actually safe to do large volume paracentesis in these patients. It helps in a way that we can relieve the intra-abdominal compartment syndrome and the pressure on the vasculature of the kidney, which increases the perfusion. Keep in mind, in this study, 2/3 of the patients were actually small volume paracentesis. So, however, the lack of AKI in the large volume paracentesis patients is still reassuring. Vasoconstrictors for hepatorenal syndrome. We got all these medications in the table. So midodrine is an alpha-1 agonist and increases MAP. Octreotide somatostatin analog. Vasopressin is a vasoconstrictor. Terlipressin is a vasopressin analog. And norepinephrine works on alpha 1 and 2 receptors and beta receptors and increases the MAP. Now, there is one actual trial over the past 6 to 7 years. I think it's 7 years ago, and it was stopped early because of the inferiority of midodrine and octreotide to terlipressin in reversing HRS. Quite few trials looking at the norepinephrine or Levophed versus terlipressin, and they tend to perform about the same. These are the pros and cons. So midodrine octreotide is a cheap, easy access. However, does not work well. So 10 to 15% of the cases, while terlipressin is effective in 50%. It is the first-line therapy nowadays after the 2021 trial. However, side effects common because of the possible ischemia happening, especially in the abdomen, with abdominal pain, nausea, vomiting being the most common. And these are reversible side effects that can be stopped or can go away after stopping the medication. And can be serious, progressing to cardiac ischemia or digital ischemia, or even more serious, correlating with the black box warning of the medication, which is the respiratory failure. Norepinephrine is similar in efficacy to terlipressin. However, it requires ICU, so it's not really practical. Now, this is a meta-analysis of the studies looking at HRS reversal. And by default, terlipressin is superior to albumin alone. Terlipressin is definitely superior to midodrine and octreotide, and is of similar efficacy to norepinephrine. In terms of the trial, none of the individual trials showed mortality benefit despite renal improvement, and this is just to highlight this fact. Now we'll touch base on the New England Journal 2021 publication, and which included actually another publication in the same issue related to IV albumin. I'm going to touch base on. This is the terlipressin confirmed trial. To approve this medication through FDA, American data were needed. 2 prior trials did not reach statistical significance, hence this trial helped a lot in approval. Included 300 patients with type 1 HRS. This is the first trial that describes HRS reversal that is verified, which is described as 2 consecutive serum creatinine 1.5 or less, at least 2 hours apart. A patient has to be alive and has to be off renal replacement therapy. And definitely 30% reached primary endpoint compared to placebo arm, only 16% reached that. The earlier you start, the lower the serum creatinine, the lower the serum creatinine, the more likely the response, as we mentioned. In terms of the results of this trial was echoed in this paper. So this is a real-world experience of terlipressin in the UK, including 26 centers. And as you see, the earlier you treat the AKI, the better the response and the prognosis. And it also correlates with survival. Highlighting again, one of the major adverse reactions is respiratory failure, 10% versus 3% in the placebo arm. This is the approval of the medication. This is the black box warning. The respiratory failure is due to use of albumin and terlipressin at the same time. Terlipressin is acting as a preload enhancer, and albumin is preload enhancer. Terlipressin is an afterload enhancer. Of course, fluid will have nowhere to go other than the lungs in this situation. This is the other paper in the same issue, which is the AFFIRM trial, looking at the use of albumin and the possible anti-inflammatory benefit that it has in patients for SBP, especially to reach a level of more than 3 grams per deciliter. The composite outcomes were infection, kidney injury, and death by 15 days. In this trial, they loaded patients with albumin. And this happened because of multiple reasons. One of them is probably getting more than 1 dose of albumin at the same time during transfer of patient to the trial center, etc. Reaching here, it's 220 grams, but in reality, some patients received actually 600 grams of albumin. There was no difference in the composite outcomes. There is no difference in infection, AKI, or death, as I mentioned. In terms of adverse events, the pulmonary edema and fluid overload was seen significantly in the trial arm versus the other arm. In terms of
2 minutes.
how to navigate, 2 minutes, okay. How to navigate through this, we can use point-of-care ultrasound, which helps guiding the therapy. This is the algorithm for terlipressin, which initially you can use it for 3 days, then reassess the response. After that, you discontinue or double or continue the medication. Maximum duration for terlipressin is 14 days, and it's used every 4 hours, 1 to 2 milligrams. TIPS has really theoretical benefit in reducing the pressure and improving the kidney function, halting the decline in GFR. Mortality benefit is seen in ascites and bleeding, but there is no enough evidence to recommend. RRT, get the patient to renal replacement therapy as soon as you can. However, select your therapies if patient is not listed. Moving on to emerging research, shaping the MELT score. Now we have MELT 3.0, might add benefit and yet to see the effect of this, similar to sodium when added more MELT points to patients. NGAL is one prognostication marker that can be used, and it helps differentiating ATN from pre-renal. These are the list of the new therapies ongoing, and these are the parameters for the future research in the next decade. Overall, HRS or AKI in cirrhosis is significant with high mortality. Nowadays, we have first-line therapy, which is terlipressin. Should not be the other way around. Don't use midodrine octreotide, then terlipressin if failed. No, start with terlipressin if available. Use midodrine octreotide if not available. And consider benefits versus risks. And consider personalized IV albumin using POCUS or point-of-care ultrasound to guide IV distensibility and volume status. Future therapies are undergoing research. We hope to see within the next decade a lot of markers that can help in mitigating such a condition with high mortality and high morbidity. And thank you all.
Thank you, Dr. Walid, for the nice lecture. We'll go to the third lecture. Our third speaker, Dr. Mohammed Jawad. He is a gastroenterologist and transplant hepatologist. He is certified board, American and Canadian board in internal medicine and gastroenterology. He completed his training in advanced hepatology and liver transplant at Western University. Dr. Jawad, he contributed a lot to the multi-organ transplant center in King Fahad Specialist Hospital, Dammam, for the last 7 years, with interest in autoimmune hepatitis and HCC. Dr. Jawad recently joined Johns Hopkins Aramco Healthcare and establishing liver service there. Thank you, Dr. Jawad, for accepting our invitation, and the floor is yours.
Okay, thank you, and I would like to thank the organizer for the kind invitation. So I'll be talking about some misconceptions related to the care of patients with liver cirrhosis. So I'll talk about coagulopathy and cirrhosis, then I'll move on to nutrition recommendations and misconceptions, as well as common drug use. I'll focus on statin. So first, coagulopathy and cirrhosis. So patient with cirrhosis, these are some misconceptions in our mind when we treat patient with liver cirrhosis. So first, patient with cirrhosis are at risk of bleeding but not thrombosis. Second one, elevated INR reflect the risk of bleeding in patient with cirrhosis, so that lead to delay in the management to give FFB, for example. And patient with liver cirrhosis, especially advanced liver cirrhosis, are self-anticoagulated, so we don't need to give them anticoagulation. So I'll talk about hemostasis in liver diseases. So in general, in a normal population, there is equilibrium between antithrombotic and prothrombotic agent. So in patient with liver cirrhosis, what happens, there is change in both sides in the procoagulant and anticoagulant factor. For example, there are factors that favor the bleeding, such as decreased platelet count and impaired in platelet function that favor the bleeding. On the other side, there's increase in vulvobrand factor as well as decrease in Adams T13 that favor thrombosis. There is change in the coagulation, decreased production in many coagulation factor. On the other hand, there is increase in factor 8 and decrease in protein C and S. All that lead to what we call it rebalanced hemostasis. That lead to a fragile and delicate balance that can be easily tipped toward either bleeding or thrombosis. So the question is, are the patients with cirrhosis are coagulable, or they are in their blood they are more prone to bleed? So in a study looking at almost 130 patients compared with 130 controlled patient, and they looked at multiple factors, mainly factor 8 as well as protein C. Factor 8 as a potent procoagulant and protein C as anticoagulant. And in this study, they found that patients with liver cirrhosis are more hypercoagulable than general population. What's interesting, they are more hypercoagulable as their liver disease advances. So if they are child B or C, they are more hypercoagulable and they tend to thrombose more than general population. And we know that. So about 10 to 25% of patients with cirrhosis, they have portal vein thrombosis because of that. And risk of portal vein thrombosis increases with severity of liver disease. Not only portal vein thrombosis, they also are prone to have DVT and PE. An important question, what do you need to do a hypercoagulable workup for patient with cirrhosis and portal vein thrombosis? So in general, you don't need to do the test, the workup for hypercoagulable if they have underlying liver cirrhosis and if they have family history of thrombosis or their blood work suggestive of hypercoagulable condition. So this is a meta-analysis of 11 studies. They have a huge number of patients. They compared patients with cirrhosis versus control. And as you can see here, patients with liver cirrhosis are more prone to have DVT and PE when are compared with general population. So moving on to INR as a measure of risk of bleeding. So INR was initially validated in patients receiving anticoagulation such as warfarin, was not developed to check the coagulopathy of patients with liver cirrhosis. So it's considered poor marker of bleeding risk in patients with cirrhosis. However, it's used it has a prognostic value since it measures the synthetic function of patients with liver cirrhosis. That's why we use it in MELD score. So there are studies looked at this concept. So this is a study with one child and 24 observational studies. They looked at patients with elevated INR and they looked at their risk of bleeding. And in this study, they found there is no difference in terms of risk of bleeding regardless of normal versus elevated INR. So conclusion of this study is high INR is not predictive of post-procedural bleeding. So we shouldn't be using INR as a risk of bleeding in patients with cirrhosis. Another study looked at the same concept, 29 studies, more than 13,000 patients, and they looked at patients who bled, and then they looked at their INR, and they compared the two arms, patient with bleeding versus no bleeding, and they looked at their INR, and in this study, post-procedural bleeding was not correlated with INR level. How about platelet count? In a study looked at a platelet as a thrombus generation as a function of platelet. They found that platelet in patients with cirrhosis are adequate to generate thrombus at the level of 50 to 60. In a larger study in the HALT-C trial, this is in the era of hepatitis C, where we used to do liver biopsy for patients prior to starting hepatitis C medication in the interferon era. So they looked at the risk of bleeding and the platelet count. And it was shown in this study that platelet count more than 60 is sufficient to prevent the bleeding. So you don't need to give platelet for patient with platelet count more than 50 to 60 to do a liver biopsy. In this review article at the New England Journal of Medicine, they commented that bleeding complications are not frequently related to abnormal hemostasis. So it's not necessarily related to the INR level or platelet count. And the cause of bleeding is usually related to portal hypertension, endothelial dysfunction, or development of endogenous heparin-like substances due to bacterial infection, renal failure, and uremia. These are the risk factors for bleeding rather than abnormal hemostasis. So the question, do we need to give prophylaxis prior to doing invasive procedures for patients with liver cirrhosis and coagulopathy? If we take the AASLD guidelines, in general, they don't recommend giving FFP for a patient with elevated INR, not even platelet correction, and they don't even recommend fibrinogen replacement. Other societies, other gastrointestinal societies such as the AGA and ACG, they don't recommend correcting INR. However, they suggested platelet count of more than 50 and giving fibrinogen replacement to achieve a level of around 120. So how do we measure coagulopathy and risk of bleeding in a patient with cirrhosis? This is a very challenging question, and one of the ways that that can be used is to check a blood viscoelastic test. There are two machines. One machine called thermoelastography. The other one is ROTAM, or rotational thermoelastometry. They assess the dynamic assessment of hemostasis. They give you insight of coagulopathy of liver cirrhosis. Actually, this is a test that usually used during liver transplantation. So usually when the patient, they go for liver transplantation, especially during the operation, you don't have the time to check their platelet and INR. So they use this test, and they give blood product accordingly. And even in trauma and in the emergency department, they use thermoelastography to guide blood product management. So the idea behind this is thermoelastography, that you can actually measure the clot initiation, the clot kinetics, as well as the stability of the clot and the time needed to generate the thrombus. And that will give you a figure similar to the ones on the right side. And that will give you an idea if the patient needs platelet transfusion or blood product a transfusion such as FFP, or if they need fibrinogen replacement. And this is a point, and it's a point of care test, so you get the results right away. In a study, looked at patients who are undergoing invasive procedure, different invasive procedures, and they used either the standard of care, so upon the discussion of the physician, they give blood product based on your clinical experience versus thermoelastography guided blood product use. So in this study, they have 30 patients in the two arms, and in the thermoelastography they gave according to the test showing in the machine versus the discretion of the physician. And as you can see here, there's more blood product given in on the physician discretion arm versus the thermoelastography arm. So in terms of blood product, more FFBs and platelet were given on one arm versus the other. However, there was no change in the risk of bleeding between the two arms. So there is another study. This is an ongoing randomized controlled trial looking at the same concept, patient who will be undergoing invasive procedure and trying to use the rotational thermoelastometry to guide the transfusion management of such patient. And they will be looking at this study at the safety of the procedure as well as the risk of bleeding and the amount of blood product given. So moving to anticoagulation use in patients with cirrhosis. So we usually think about patient with liver cirrhosis as self-anticoagulated, and they don't need anticoagulation. And this is not completely true, since these patients are at risk of thrombosis and their progression of thrombosis might have unwanted consequences. So one of the questions, is it safe to give antithrombotic to such patient? And the other question, is it beneficial? So in this study, meta-analysis of 8 studies, and they looked at patients who were given anticoagulation, either warfarin or low molecular weight heparin. And as you can see here, patients who were given treatment, they have more complete recanalization versus patients who did not receive anticoagulation. There was less thrombosis progression, and more interestingly, there was less variceal bleeding in patients who received antithrombotic agents. So I'll move to nutrition and patient with cirrhosis. So all the recommendation or that low protein diet is recommended in patients with cirrhosis and history of hepatic encephalopathy. And there's another misconception that obese patients with cirrhosis have enough reserve to prevent sarcopenia, which is a muscle wasting. So in this study, 30 patients who were admitted with hepatic encephalopathy all received treatment for hepatic encephalopathy. They were classified into patients who received normal protein versus patients who received low protein. And the conclusion of this study that protein restriction has no influence on hepatic encephalopathy. However, it actually exacerbated protein breakdown in patients who were on protein restriction. Another study looked at more than 600 patients on the waiting list, and they looked at their protein intake, and only 24% of patients with liver cirrhosis who were hospitalized and on the waiting list received the recommended protein requirement, which is 1.2 grams per kg of protein per day. And patients who received very low protein, less than 0.8 gram per kg per day, had worse liver disease severity, independent predictor of malnutrition, and they were more likely to die on the waiting list. Another very important concept in managing patients with liver cirrhosis, we always keep our patients with liver cirrhosis MPO, either because they need endoscopy or they need paracentesis or they need imaging. And we need to remember that patients with cirrhosis are different from general population because of their liver dysfunction. They don't have high glycogen store, so they are less likely to produce hepatic glucose when they are fasting. For that reason, and to keep their glucose level around normal, they need to have work on their gluconeogenesis. They need to break their muscle to provide amino acid for glucose production. And although this is an old study, but actually a metabolic profile of patients with cirrhosis after overnight fasting was comparable for patients who were starving for 3 days. So remember, this is a very important concept. So we need to make sure we don't keep our patient MPO for a prolonged period of time. And we need to think if our patient actually need to be MPO, for example, for imaging or paracentesis. So maybe we might be able to avoid unnecessary MPO order on our patient with liver cirrhosis. Another study looked at nighttime feeding. So patients were classified in this group to patients who were given supplementation, 2 cans of Ensure Plus equivalent to almost 700 kilocal. And they were either given as a supplementation, and the two groups, the first group giving this supplementation during the daytime between 7 a.m. and 7 p.m., and the other group were given this supplementation at either late night or early morning between 9 p.m. and 7 p.m. and 7 a.m., sorry. And they were given this supplementation for 12 months. And as you can see here, after 3 months of supplementation, there was a difference in their total body protein between the two groups. Even if you give the same amount of supplementation, however you give it at a different time, it makes a difference. Another concept is sarcopenia in patients who are obese. So remember, sarcopenia means a decreased muscle mass and decreased muscle function. And usually in patients with obesity, we don't think they are sarcopenic. But in fact, about 20 to 35% of patients who are obese, they do have sarcopenia. So it's actually considered as a risk factor for mortality. So in this study, it's a retrospective cohort study, more than 600 patients with cirrhosis awaiting liver transplantation. They compared patients who have no muscular abnormality versus sarcopenia versus sarcopenic obesity. So patients who were sarcopenic and obese, they did worse than patients who did have normal muscle mass. So it's very important we don't forget that such patients, they can have sarcopenia and can be also malnourished. So these are some recommendations when it comes to patients with liver cirrhosis. So we need to make sure they're getting enough total protein, energy intake, 35 to 40 kcal per kg, and they need to have 1.2 to 1.5 grams per kg. Avoid protein restriction even in patients with hepatic encephalopathy. Minimize fasting with a maximum interval of 3 to 4 hours between meals when they are awake. Early breakfast and late evening snacks should be recommended. Encourage the consumption of vegetables and dairy protein. So at the end, I'll come to statin use in patients with liver cirrhosis. We always think of statin as a contraindication in patients with liver cirrhosis, and we just learned from Dr. Sawad that we will be seeing more and more of patients with fatty liver disease or MASH or MASLD. And such patients, they have lots of metabolic risk factors. One of them is dyslipidemia, and we need to control their dyslipidemia. And the question, is it safe to use a statin in patients with liver cirrhosis? And how about patients with advanced liver cirrhosis and decompensation? And the other misconception that statin could cause progression of liver cirrhosis. So in this study, they looked, this is a double-blinded randomized control study. They have only patients with child B and C cirrhosis, and patients were given simvastatin 20 milligram plus rifaximin versus simvastatin 40 milligrams plus rifaximin versus placebo. And as you can see, the patient who received simvastatin 20 were comparable to placebo group. However, patients who received simvastatin 40, they did a little bit worse. So the conclusion of this study that low doses of statins, such as simvastatin 20, should be preferred over higher doses of statin and can be used safely in patients even with decompensated liver cirrhosis. So I'm coming to my final slide here. How about this? A study looked at patients with a statin and liver cirrhosis. So in this meta-analysis with 3 randomized controlled trial and 10 observational studies, patients who were given a statin, they are less likely to have liver decompensation and less likely to have progression of portal hypertension when compared with control. So there's actually beneficial impact of statin in patients with cirrhosis. And in this review article in the Clinical Liver Disease, statin use has been associated and proposed to decrease hepatic inflammation, decrease hepatic fibrosis, and decrease portal pressure in patients with liver cirrhosis. So in conclusion, high INR does not reflect risk of bleeding in cirrhosis or post-procedural bleeding. FFB to correct abnormal INR is not recommended prior to invasive procedures. Patients with advanced cirrhosis are not self-anticoagulated, and risk of thrombosis increases with severity of liver cirrhosis. Avoid protein restriction in patients with hepatic encephalopathy. Minimize fasting and encourage early breakfast and late night meals. Statin can be used safely in patients with cirrhosis, and statin use may reduce fibrosis progression and reduce portal hypertension in patients with liver cirrhosis. And thank you.
Thank you very much, Dr. Jawad. So I would like to invite our speakers, Professor Swat and Dr. Al-Ghamdi. He's asking about Ramadan fasting and what is the consequences in cirrhotic populations.
Okay, thank you. Very good question, a practical question. In general, for patients with cirrhosis and no portal hypertension, and if they can't tolerate fasting, I say yes. Once they develop a decompensation, especially if they have ascites, I say no. No more fasting, and it's haram, I tell them it's haram, you shouldn't be fasting. This is my recommendation to my patient in the clinic. So patient on the waiting list, they shouldn't be fasting, for example.
Thank you. I enjoyed the liver session very much. Thank you all for the speakers and the co-chairmen. I have a question for Dr. Swat. You think the new terminology will change in due time for the new terminology that's been recently adopted? You could think it will stand the test of time, you think, or it will change with time? That's my second question for Dr. Jawad. From your presentation, you seem to recommend statins. Do you recommend statins for cirrhotic patients even when they don't have an indication for statin? Thank you.
Yeah, thank you for this questions, which difficult to answer because this is something new. It's difficult to predict the future. If we compare it with NAFLD, it may stay for 3 decades. If we compare it with muffled, it may stay for 2 years. No, the problem with muffled, the problem when it was proposed in 2020, there was a real problem. In that nomenclature, there was no account for NASH, MASH, nothing. It wasn't there. This one. And it was focused on metabolic and forgetting the other name. So probably the SLD, steatotic liver disease terminology, I think it's one of the good ones. It accounts for many factors, the methodology behind it, and expert discussing many aspects of the disease. I think it has some flexibility. I do think it will. Unless there is something in the future. But I think this is probably for the future is good one, but we don't know. Maybe there is more critic in the future. Thank you.
Okay. Okay, Dr. Taif. Well, if you have an indication such as dyslipidemia or MAFLD, it's safe, and it's actually lots of studies over the years showing that it's actually not only safe, it's beneficial. But I don't think we have like a very clear recommendation based on the study that should be used for patient only to decrease the portal hypertension or to decrease the progression. Maybe because we have non-selective beta blocker, for example, that can be used for the same reason. But as far as I know, it's not solely recommended for that sake. So I don't start statin only to decrease portal hypertension or to decrease progression of the liver disease.
I just want to make a comment about the statins used. So the last EASL conference, there was a presentation, I think, from a Spanish group. They discussed use of statin in acute kidney injury in cirrhotic patients. The study or the presentation was negative, unfortunately. However, yet to await for the secondary analysis, etc. The dosage that they were able to reach was 20 milligram, but the limitation is the liver dysfunction, elevated LFT, which made it very restricted to use statin liberally.
Yeah, go ahead.
One more question, if you allow me. For Dr. Jawad, do you think incidence of statin hepatotoxicity is higher among patients with pre-existing liver disease compared to normal? Thank you.
Well, I'm not sure if it's more in patients with pre-existing liver disease, but I think more likely you cannot be using higher doses in patients with the pre-existing liver disease. And I think like most of the patients, or I would say not most, many patients that I see, and I diagnose as statin-induced hepatotoxicity, I discover they have another agent that the combination of statin and the other agent causing their liver injury rather than statin, and most likely they are using higher doses. So what I do, I try to see if I can eliminate the other agent, especially antibiotics use, and the other thing that I do, I reduce their dose. But I'm not completely sure if they are, because of a pre-existing liver disease, they are more prone to have hepatotoxicity. Maybe they are more likely to have consequences related to hepatotoxicity though.
Okay, so if there is no more question, we'll close this session. Thank you all for your attention, and thank you for the speakers. Who's next?
Assalamu alaikum. Welcome to the last session for first day of this excellent program. I'm delighted and happy to present one of the worldwide IBD figure, Prof. Charles Lees. He is head of innovative and genomic center at Edinburgh University. He's a well-known consultant and IBD specialist with multiple grants awarded for him and multiple publication in high-impact journal. He will educate us and talk about role of genetics, diet, and microbiome in IBD onset and flare. And floor is with you, Prof.
Thank you, Prof. Nalla. So a bit of light relief maybe at the end of a very, very interesting day, but a talk packed with, I think, real meaning and importance for our IBD patients, and also with some really interesting, hard-hitting new data. To set the scene, let's first think now about who's getting IBD and why, because we are seeing worldwide trends shift very rapidly. Crohn's disease and ulcerative colitis, until recently only described in the Western world. But we are seeing now, you are seeing now, this increase in incidence as we adopt a Western lifestyle. If we look in Edinburgh, we see in the middle here, we are in this third phase of IBD, this compounding prevalence phase. Incidence has now stabilized, but we're diagnosing people young with no excess mortality, and so the prevalence is going up. In Scotland, we have worked out the current prevalence, or from 2018, it was 1 in 125 people. But we are very close to hitting 1% of our population living with IBD. Within a few years, we will have breached this mark. Here in Saudi, you are firmly in this acceleration in incidence phase. You are seeing more and more people being diagnosed with Crohn's disease, complex fistulizing, disease-resistant phenotypes year on year. But if you look even further down to the emergence phase, well, this is probably the African subcontinent, sub-Saharan Africa, where this is most prominent. And this is all very important, because if you look where the world's population is predominantly going to be living in 2100, it's not in Europe, it's not in America, it's in Asia and Africa, and this, I think, is a very important thing for us to bear in mind. So critical to the conversation around epidemiological trends and thinking about Western living and particularly diet is this notion, is IBD an illness of modern living? And the answer to that, I think, is not exclusively, because we definitely have reports going back to antiquity, but I think very clearly it is a prevalent population problem. If you look at the epidemiology, we can see Western living, we can see diet, we can see antibiotics and multiple other factors, but urbanization appears to be the key signal. 2007 was the year when the WHO reported that more of the world's population was living in urban rather than in rural populations. So for ABD patients, I think we can think about modern living being the environmental driver, which reduces microbial diversity, less variety of bugs in the microbiome, and on a background of genetic susceptibility, we're seeing IBD develop. Now, the genetic susceptibility appears, at least in part, to be what has evolved in our genomes in response to pathogens over millennia. And one really interesting example of this goes right back to the Black Death, or to the bubonic plague, which in the 1300s wiped out more than a third of Europe's population and then spread across the world. Fascinatingly, recently, a group of scientists from the UK and Denmark have gone to skeletal remains from 50 years prior to the Black Death and 50 years after the Black Death. They've extracted ancient DNA and they've done a genome screen to compare the difference in the genetic variation pre and post Black Death. And when you do this, you can plot on this Manhattan plot those hits that are more or less prevalent after compared to before. And you see a cluster of immune-related genes, including ERAP2, which is a macrophage gene responsible for killing intracellular bacteria, which is associated with susceptibility to Crohn's disease. You see other examples with IL-23, you see examples with tuberculosis, malaria, and other illnesses. So it looks like as we have evolved to be protected against pathogens, in the modern world, we are susceptible to getting inflammatory bowel disease. The genetics has shown us many key biological insights, from epithelial barrier dysfunction to innate and adaptive immune deficits. Perhaps most interestingly, while we are getting more and more gene hits, and we will see more again in the next 12 to 24 months, we can start to see clustering of pathways that we are targeting with our drugs in the genetic hits. And that's particularly the case for IL-12/23 signaling, where the IL-23 receptor is a big hit. It's particularly a case for vedolizumab, where we see the integrins come out very strongly as gene hits. And it's also the case for JAK-STAT signaling, so upadacitinib that I was talking about this morning. There are multiple, probably 15 genes in that pathway that are associated with susceptibility to IBD. But what I really want to talk to you about is environmental factors and the diet. To put diet in context, we need to think not just about diet as a key environmental factor, but also food additives, hygiene, antibiotics, smoking, and other factors associated with geographical variation in our population. If you look at the dietary data, we can see evidence for breastfeeding, ultra-processed foods, high-fat diet, low-fiber diet, emulsifiers, sugars, polyunsaturated fatty acids, and red meat. I'm going to just set the stage a little bit before I show you a few highlights of the data, because there is a lot of interest in this area, but it's complicated. There's a lot of data that shows association, but this is not causation. There is a lot of misreporting in the literature, and even more misreporting in the media and the social media where our patients are getting their information from. A lot of the animal data is to do with food ingredients, but we don't eat ingredients, we eat whole foods, and mice are not humans, so we have to interpret accordingly. And even when you look at the human studies, they're full of bias and confounding. So one should look at the dietary data with a skeptical eye. I want just to give you two really interesting examples. The first are dietary emulsifiers, polysol by 80, carmagenin, carboxyl cellulose. This is not all of them. There are about 60 approved for use in Europe in consumption. They're what make your mayonnaise commercially not come out all oily and split. It's what makes homemade ice cream, which has ice crystals and is a bit clumpy and not so smooth, when it's commercialized, come out in that gooey texture, just like the stuff they were selling out or giving out free today. Got emulsifiers in it. Those buns and pastries this morning, stacked full of emulsifiers for sure. Now, Benoit Chassing in Nature in 2015 showed us that in mice, these emulsifiers, particularly carboxymethylcellulose and polysorbate 80, when given to mice that the FDA deemed to be safe for human consumption, cause colitis. There's decreased mucus thickness, increased mucus barrier encroachment, a reduction in microbial diversity, an altered microbiome composition in these mice, increased permeability, and increased severity of colitis. And in more experiments since then, we start to see the immune mediation where what's happening is these emulsifiers are interacting directly with bacteria in the gut to disrupt the mucus barrier and then trigger this inflammatory cascade that is driving colitis as we go forward. And the reason why I like this story so much is not because I can almost guarantee you've all eaten some emulsifiers today, but also because we are now taking this from mice to humans to intervention. So Kevin Whelan, along with Benoit Chassing, are doing the ADAPT study, take people with Crohn's disease, mildly active Crohn's disease, give everyone an emulsifier-free diet, and then give them supplements. And in a randomized manner, 50% of people get supplements that are emulsifier-free, 50% get supplements that are emulsifier-containing, and then you follow people up for 24 weeks and see what happens. There is a lot of interest on ultra-processed foods, which of course contain a lot of emulsifiers. And there are 3 data sets, all population-based, all studying adults of middle age and then looking for incident Crohn's disease sometime later, that have demonstrated an association with high consumption of ultra-processed foods and the subsequent development of Crohn's disease. These studies are interesting. There's a very clear clue here that we should follow up. We know there are many good reasons to avoid eating ultra-processed foods, not least obesity, diabetes, and other cardiometabolic disease. But in addition, there may be good reason to avoid them for Crohn's disease, but multiple residual confounding exists in these population-based studies, as it does for dietary fiber. So Ashwin and Krishnan has shown in the Nurses' Health study that low dietary fiber is associated with an increased risk of getting Crohn's disease. But if you look here, that's on their univariate analysis that's age-adjusted, but when they do their full multivariable model, actually the significance drops out in this analysis. So we should be careful, I think, to drive too much attention to these things until we have really good details. Moreover, the story gets more complex. This is not to do with IBD now. This is a fantastic study published in Cell last year looking at humans who are healthy given a high-fiber diet or, instead, a diet high in fermented foods. And actually, those that got the diet high in fermented foods appeared to have a more favorable shift in not just their microbiome, but in their whole transcriptomic profile later on in the gut. Bear this in mind when we think about fermented foods and yeasts in just a minute. What about sugars? We think sugar is bad. Sugar is bad. Sugar causes diabetes, obesity, cardiometabolic disease, and cancer. Is it bad in terms of the gut? Probably. It's difficult because all of the human studies look at people who've already got IBD, and when people are sick with IBD, they tend to reach for more sugary drinks. They may say, we'll take artificial sweetener drinks instead, Diet Coke, not full-fat Coke, for example. But actually, when you look at a human study looking at artificial sweeteners, you see that they have a big impact on the microbiome as well. So there is lots to think about here. The final dietary story I want to tell you before I move to show you one of our bits of data is about yeasts. 20 years ago, when I started as a gastroenterologist, patients came to us all the time and said, "Doctor, it's my candida. That's what's causing all of my gut problems." And we just said, "Don't be silly, it's not your candida, it's fine." But actually, there might be some truth to this. The yeast Deboromyces hansii, in a paper published in Science last year, appears to be very prevalent in the wounds, the ulcers in the gut of Crohn's disease patients, and it appears in vitro experiments to propagate inflammation. This may not cause Crohn's disease, but it appears to propagate it over time. And then more recently, another study published in Nature Medicine about a month ago showed that yeasts that are either commensal yeast in the gut or food-derived, they gave the cells Gorgonzola and Camembert, and with Gorgonzola and Camembert and these commensal yeasts, you drove this population of Th1 cytotoxic lymphocytes that were then increasing production of interferon gamma and IL-2, causing intracellular death and inflammation in the gut. But only in those patients with Crohn's disease who are ASCA positive. This is super interesting, and this story is going to get more complex probably before it may translate into strategies to reduce the risk of Crohn's disease and strategies to treat Crohn's disease. So can we prevent Crohn's disease and ulcerative colitis from developing in the first place through dietary strategies? Maybe. What's the best way to do it? Well, it might be to go right back up and affect the mother, change what the mother's eating, change the mum's microbiome, make the fetal microbiome, the neonatal microbiome, more favorable. And in fact, there's a study looking at this. The details don't particularly matter. It's taking mums who have Crohn's disease, it's giving them an anti-inflammatory diet in the version of the specific carbohydrate diet, which actually I don't believe very much in, but nonetheless it's an interesting concept here. And then what they're doing is they're seeing whether or not giving the mum a dietary intervention during pregnancy changes the neonatal microbiome. Very interesting approach to see what happens. Now, what about treating IBD? Well, to treat IBD, we need to think about our principles. I showed you those earlier. We need to remember our unmet need of our patients, not just getting our patients well, but using holistic strategies that include dietary therapy. We've used dietary therapy for decades. Exclusive enteral nutrition is a great dietary tool for children with Crohn's disease. In my hospital, we use it a lot for adults with small bowel Crohn's disease. We use it in place of steroids. We use it as a bridge to investigations and treatment and surgery, and it's highly effective in this situation. But most adults want a diet that contains whole foods. What's the best whole food diet strategy? Well, I tell my patients something close to a Mediterranean diet. And I can tell you, in Scotland, we're about as far removed from the Mediterranean as you are here in the middle of Saudi. But nonetheless, for those that want to, we try. It looks to be at least as good as the specific carbohydrate diet based on the DINE-CD study. This is a very nice study, but it doesn't have a control arm that without a dietary intervention, so it's difficult to know just how real these effects are. There's an even smaller scale study looking at the Mediterranean diet in ulcerative colitis patients, which gives some mechanistic and some microbiome analysis insights, but we need to study this further. And then there was this study from India where they looked at the anti-inflammatory diet plus a fecal microbial transplant in combination to compare against standard medical therapy, in which they showed superiority. Standard medical therapy here was limited to mesalazine for ulcerative colitis, so arguably it wasn't the strongest comparator arm. But I think studies like this are the future. Medical treatment plus dietary treatment plus microbial treatment is going to equal superior therapy for our patients. The final bit of this story is just to tell you a little bit of data that we've been working really hard to generate in the last 8 years, where we've been looking at dietary triggers actually of flare over time, asking the question that our patients are asking all the time: what should I eat? I'm well, what should I eat to stay well? And so in our PREDICT study, we took 2,500 people who were well. We then looked at their stool to look at microbiome and calprotectin. We then did questionnaires and dietary analysis and followed everyone for 2 to 4 years to then be able to compare diet in baseline in flarers versus non-flarers. We wanted to look at diet, environmental factors, genetics, and the microbiome. This is what our patients in Scotland eat. They eat quite a lot of carbohydrate in blue, fats, proteins, saturated fats, and PUFAs. And actually, it's pretty similar in men and women, Crohn's and UC, and pretty similar to the background population. Our patients get 40% of all of their calorific intake from ultra-processed foods. 40%. That's a pretty high number in the baseline population. So this is pretty cool. We looked at calprotectin at baseline in our patients. Calprotectin is a really excellent surrogate for gut inflammation. In this study, we asked people to be in remission, clinical remission, but 20% had a high calprotectin, 20% had an intermediate calprotectin between 50 and 250, whilst the majority had a calprotectin of less than 50. And if you look at Crohn's disease on the left and at ulcerative colitis on the right, you can see that the blue line, those people that had a calprotectin of less than 50, had the fewest hard flares over time. So this is symptoms, it's inflammation and a change in therapy or hospitalization or surgery. The red line shows people with calprotectin of greater than 250 at baseline. They are flaring much more quickly, but you also see this middle line, calprotectin of 50 to 250, suggesting that actually we should maybe be treating our patients to a deeper level of remission than we are at the moment. And then I want to just show you one dietary variable that's come out in our analysis. We were really interested in how much meat people were eating. It's an interesting thing to present here. I've eaten a lot of meat in the last 48 hours while I've been in Jeddah. But what I see in my patients with ulcerative colitis is that those people in the black line that eat the lowest amount of meat are much less likely to flare than those in the blue line that eat the highest amount of meat. And actually the hazard ratio is 2.08. It's about a twofold difference, which is pretty interesting, and we're following up this observation just now. So how do we put all this together? What could you do practically in your clinic tomorrow to help your patients with IBD when it comes to diet? Well, this is my schema for diet, for my patient interaction in the clinic. These are the questions I ask patients pretty much every time. It's a relatively straightforward thing to do. But it includes asking people about diet. And I don't necessarily want to look at all of it, but I'm looking at how is your appetite? What's your diet like at the moment? Is it good? Is it not good? We can talk about that in a bit more detail. Are there any foods that you are avoiding to manage your IBD, to stop things flaring, to stop you getting stricturing-related complications or whatever? IOIBD published this opinion piece about lifestyle behaviors for IBD patients. It's not particularly helpful with diet because it says avoid diets that have been shown to work best in clinical trials. And as I've shown you, we don't have much for that. So let me summarize. Diet is, I think, the key modifiable environmental factors for our patients, but there are huge challenges. Behavioral change, adherence, skills, knowledge, cost of living, and this all requires a solid evidence base. So my advice to my colleagues is that we approach this topic with sensitivity. People need to eat to live. We are surrounded now by processed foods that are designed to be highly desirable, addictive, and they provide very cheap calories for our patients. And a dietary strategy for IBD is likely to be more than just a 4-week course. It's likely to be for life, and so we have to approach this with sensitivity. So if I summarize all of the data, I don't think diet is the cause of IBD, but I think it is a key driver of inflammation. I think dietary therapy for IBD in combination with medical and microbial strategies will end up being a key plank of therapy for the next decade and beyond. And I think we can start to believe that prevention and prediction strategies based around diet and the microbiome will help prevent the disease onset and disease flare, but we have to be very sensitive when it comes to thinking about compliance, adherence, and patient knowledge and skills. But our patients want us to address this issue, and I want to give you a bit of information to help you address this issue with your patients in the clinic next week. So thank you very much for that.
Can you, or up to you if you would like to join and sit or at the podium. Yes. Excellent talk. Any question from the audience? I have a couple of questions and one comments. First of all, now I'm feeling and believing that more and more that IBD is so complex, as you rightly mentioned. However, I think environmental factor play a very important and crucial role rather than genetics. Maybe they have, because we know that they might run in family, but maybe they are sharing the same diet habit, same environmental factor.
So it's very interesting. So in Saudi, you have a lot of multiply affected families. And you can look at this in different populations. So you can look at it in some of the Ashkenazi Jewish populations as well. What to me is very interesting is that the clustering of IBD cases in multiply affected families, if you look across siblings, it tends to cluster together in space and time. So if it was purely genetic, you would anticipate that the children would be sort of equally affected no matter what the birth order. The risk would be the same. So why do you see that clustering? That seems to suggest that at least some of what's going on here, we know there's a genetic component, that's indisputable, but I think there is going to be an environmental contributor in some of these multiply affected families. How much is genetics versus environment? How much is cause versus drivers? I mean, genetics, of course, is is inherited, it's non-changeable, it is, the ground truth in many respects. And by definition, it is causative in that sense. But the addition of environmental factors, it appears to be very strong, particularly in UC. But it's a fabulously interesting yet challenging topic to tackle.
Any other question? So you nicely showed us that not only the microbiome, even the fungal play some role, but we don't have the full picture and understand it well. Can you comment on virome, the virus? I think there is growing evidence.
So viruses and IBD, I think, is a very interesting topic. Viruses and fungi, two things to watch very closely in the next few years, because there's some evidence, for example, that Epstein-Barr virus might be triggering Crohn's disease developing in at least some, or at least being contributing to it, a bit like we've seen for multiple sclerosis. And certainly if you look in the virome of prevalent IBD patients, you see changes. Bear in mind that the first decade of knowledge about the microbiome in IBD came from 16 sRNA sequencing, and in that situation, you're only picking up bacterial DNA. Now with bigger metagenomic studies, we're able to look at the virome and the fungome and start to analyze this in more detail. There's a question over there?
Yes, please, Dr. Aliza.
Sorry. I get a little worried when an IBD patient talks about specific foods that trigger symptoms, and whether that's real or functional, or we're straying into kind of avoidant, restrictive eating disorder type. Do you have any tips for untangling that mess?
Yeah, it's a huge problem, isn't it? I mean, it's a huge problem for IBS patients, some who come in and they have ended up saying, all I can eat is rice and chicken. I'm like, that's probably not true. Let's think about this. So I've taken all these things. And sometimes with those patients, just for example, I will say, I want your homework for the next month, is to get rid of all your restrictions, and we'll just start again. IBD patients, it could be the actual disease itself, it could be their IBS overlap, but it could also be driving their strictures or their SIBO or whatever else it is that's overlapping. I urge people not to get too restricted. I get quite wary, actually, if you have patients that want to be on EEN the whole time, because that's the ultimate restriction, and then you start to get into sort of pathological behavioral patterns and all the rest of it. I think working with a good dietitian, if you can, and encouraging people, you know, this is why, I mean, one of the trends that's the most worrying online, which we don't know anything about, but patients talk a huge amount about, is not just intermittent fasting, but fasting to stimulate autophagy, to help treat their Crohn's disease, and then you're at real risk that patients end up undernourished, not just malnourished.
Yeah, I think social media has a lot to answer for, doesn't it? Some good things, but some bad things like that. Yeah.
And that's right, and that's why, you know, I and others are trying to sort of put good information out there, but I think just bear in mind where people are getting their information from, and often they have the attitude, my doctor's not going to ask, so I'm not going to tell them, and I'm just going to get my information from this Facebook forum. And so I encourage people to ask, what are you doing? What are you doing about diet? Because you might just find they say, yeah, I'm eating once a month, and that's enough, and it's just bone broth the rest of the time. And why? Well, because there's hundreds of Crohn's patients talking about it on this crazy forum.
Awesome, thanks.
Thank you. If no more question, I think we are on time, 4:30 exactly, and we by that perfect. So perfect lecture. Thank you, Prof. Charlie, and Dr. Khan. If you would like to make any announcement at end of the first successful day.
Yeah, thank you very much for everybody of attending so late. Wonderful sessions by all our fantastic speakers today. Unfortunately, Professor Charlie Lee gonna leave us because he is going to catch his flight tonight. Otherwise, I insist again to join us tonight in gala dinner. Everybody in the room, we would like to invite a gala dinner on the swimming pool tonight in this same hotel, and there will be a screen for the football match also. So football match between the Saudi team and the Egyptian team. That will be great. The other thing, we are not finished yet. As a men, probably we are done. But there will be an important session, women's in gastroenterology, which start like in half an hour in the same room. So I think if men want to attend, it's important. Financial independency in profession. So it's important for men as well.
But
so
not the first meeting.
Huh?
I think we have to plan it and to make our plan without you this time. Then the next. Thank you for taking care of the audience and arranging the screen for the football match. And
yeah, hopefully to see you early morning tomorrow for the second day. And it will be only successful with your presence. Thank you.